Tell me. Tell me, then I will ask you questions. Then I will make you understand what is happening with the food. You eat paratha, right? So what happens with that paratha? This paratha is going to go to your mouth. Now we will understand what is happening with that food that you had, right? So this food will be going into your mouth. Whatever food we are eating in the alimentary canal. We have that alimentary canal. Alimentary canal is the canal that will start from the mouth. It will end it till the anus, right? So that is the canal. It is known as alimentary canal. In the morning, I told you 5 things we are going to eat. What are the 5 things? Carbs, fat, and minerals, right? So we are eating what? Macro and micronutrients, right? So that is what we are made up of. And all those things are going to go into your alimentary canal. And this alimentary canal will be having how many layers? It will be having 4 layers will be there. The innermost will be mucosa. Just think it like as a bottle, right? So it is a pipeline like kind of thing. The innermost layer is going to be what? Mucosa, which is going to come in contact with the food. Then second layer will be submucosa. Then third layer will be muscularis, and lastly we are having serosa. So mucosa will be there, submucosa will be there, muscularis will be there, and serosa will be there. So these are going to be the 4 layers. I'm just taking a cross section out of your GIT. This is going to be just think it like that. This is a round thing, right? This is a round thing. I'm just taking a cross section out of it. This is your GIT. I'm just cutting your esophagus or maybe below that. And I'm just taking cross section out. And what I'm going to find, this is the inner layer. This is going to be mucosa. Here your parathas should be there, right? These are going to be your parathas. And these parathas will be coming in contact with direct with the mucosa. So mucosa will be having this layer, and this layer will be what? This layer will be having villi and microvilli, and this villi and microvilli are responsible for increasing in area of absorption site, right? So what is going to happen when you have this microvilli and villi? They are going to increase the area for absorption. This is the first thing. Second layer we are having is submucosa. Third layer will be muscularis. Here you will be having inner layer will be circular, outer layer will be longitudinal. Inner layer will be, this one is inner layer. Inner layer will be circular. Muscularis will be having 2 layer. You can remember inner circular, outer longitudinal, and lastly we are having what? Lastly we are having serosa. So this is going to be the complete story. Okay. So when you are going to cut, you are going to enter, you are going to understand. Okay, sir, outermost will be serosa. Then muscularis should be there. Which muscularis will be first if you are going from outside? This is going to be outer layer. This is going to be longitudinal. Then you will be having inner circular. Then you will be reaching to submucosa, and then you will be reaching to mucosa. If you just try to go inside, that is a way, right? So this is going to be the thing. Now in submucosa, you can understand in submucosa, we are having a group of nerves. Group of nerves is known as what? Group of nerves is known as plexus. Like you are having brachial plexus, here you will be having brachial plexus. Uh, we are having other plexus also, like multiple group of nerves will be there. This is considered to be as plexus. Plexus means group, right? So here in submucosa, you will be having a special plexus. What is the name of this plexus which is going to be there? This is known as Meissner's plexus. And remember, Meissner's plexus is concerned with secretion. It is concerned with secretions. Remember, this Meissner's plexus is concerned with the secretions, right? Whereas muscularis will be having some plexus also, group of nerves, and it is concerned with movement. And this plexus is known as myenteric. This plexus is known as myenteric plexus or back plexus. Okay, how you can remember? Simple. It's very simple. I'm just telling you the trick. What is the trick? S, S, S. What is the trick? Submucosa will be having which plexus? Meissner's plexus, and it is concerned with the secretion. Secretions kahan se hoga? From where you will be having the secretion? This is from the glands. This is from the glands. So glands are responsible for the secretion. So this is going to be the submucosa. And remember, submucosa will be having two things. Here you will be having blood vessel also. Here you will be having glands also. So two things are going to be present in submucosa. You will be having glands. You will be having blood vessels. Okay. If mucosal tear is going to be there, is it going to bleed? Little bit. But if the tear is in the submucosa, that is definitely going to bleed well, right? So this is going to be the understanding. If you have ulcer and the ulcer is invading till the submucosa, what will happen? It is having blood vessel, it will bleed. It will bleed. Right? Mindtrig and orbit plexus is another name for muscularis. You can see here there is no S. Is there any S? No S. So you can simply remember this is going to be muscularis. This is going to be the Meissner's plexus. Okay, Meissner's plexus. And one more thing you can remember, which layer will be absent in esophagus? Serosa will be absent in esophagus. Serosa is the layer which is going to be absent in the esophagus. Now, second important question that examiner is asking is about the motility. What are the different kind of motility we are having? Okay, what are the different kind of motilities we are having? So we are having these four types of motility. We are having electrical motility and we are having mechanical motility basically. So this electrical motility is also known as BER, also known as basal electrical rhythm. Like your heart is working on the basis of a pacemaker, right? What is the pacemaker of heart? SA node. Here also the pacemaker of GIT is known as, it is known as interstitial cells of Kajal or Kahal. Interstitial cells of Kahal. It is going to generate the impulse. It is going to generate the impulse, and that impulse is going to transmit as contraction. So it is going to generate the impulse. Interstitial cells of Kahal is going to generate the impulse, and these impulse will lead to what? Contraction. Contractions in the GIT. They will activate your cholinergic system. And what is the neurotransmitter for cholinergic system? Acetylcholine will be there. And this acetylcholine, we already know acetylcholine is going to do two things in the GIT. Acetylcholine is going to do two things in the GIT. Salivation is going to be there, but in the GIT, M1 is responsible for the M1 is present with brain and GIT glands. So it is going to contract the gland, leading to release of acid. Second thing acetylcholine is going to do is going to increase the movement, right? So that is what is leading to what? Peristalsis. Peristaltic movements will be increased, right? These are the two things. What is this mechanical motility we are going to have? Let's try to understand what is this mechanical motility. We can have mechanical motility in the fed state, in the fasting state. There are going to be two steps. Either you are hungry, that means you have not eaten the food, and either you are in the state where you are already full, right? So you can have fed state, you can have fasting state, right? So what is the dominant motility of GIT? My question is simple. Examiner has asked this question. What is the dominant motility of GIT? You have the four options: peristalsis, mass movement, segmentation, migratory motor complex. How many goes with the A, B, C, D? Just raise your hand. How many goes with the D, migratory motor complex? How many goes with the B, C, A? How many goes with the A? You have to mark something. This is 149 marks you have already got. This is the 150th question. You mark right, you will pass. You will not mark right, you will get failed. Everyone have to mark. You are going to go with the A. How many going with the A? Raise your hand. For personal reason, personally. You guys are thinking A. Okay. How many things B, C, D, D. Okay. So should I do some 50-50 things? Right? Let's do one 50-50. D is not the answer. So those people who are answering D, D is not the answer, right? Now, how many of you are answering A? Like most of you are answering A. Okay, do you want another lifeline? You know A is not the answer. Now you got 50-50. Now you have only 50-50 mass movement and segmentation. How many goes with how many goes with the segmentation? Raise your hand. Huh? Raise your hand. How many goes with the C? How many goes with the B? Mass movement. Still you are confused. Only two options, 50-50. This is what happens in sometimes in examination. You rule out two options, still you have two options, right? Sometimes God is with us and sometimes he's not. Right? Now you will be marking how many of you are going with the option number B? How many of you are going with the option number C? You figure out which one is the right answer. So here in this case, mass movement is not the answer, right? The answer will be segmentation. But it is necessary to understand why C is the why this segmentation is the answer. What like most of you, if you have not studied physiology, you are going to mark 90% of you are going to mark peristalsis, isn't it? And then they will say examiner has some issues with me, right? It is the thing that happens. Examiner has no issues with you. They don't know your roll number. They don't know who you are. 60,000 students are sitting and people are always like, they know me. They are always giving me 147 because your target is what? Target is always 150. If you keep your targets high, then only you will be having some space that you will be getting. If you keep it like 200, then you will be getting somewhere around 180, 170 marks, right? If you are keeping it 150, you will definitely get some. You always get what you ask, minimum of what you ask for, right? You are asking for 150, you will definitely get 147. You should be happy at least you are getting 147, right? But 147 is just like a zero, right? So you should ask for how many marks? How many of you are going to get more than 200? Raise your hand. Your brain does not understand what is true, what is false. You watch a movie, you cry. You know, this is just a movie, but still you cry. Your brain cannot understand what is true, what is false. You watch a dream, you will get emotionally connected also, right? So understand yourself. Okay, your brain does not know the difference, what is right, what is wrong, what is true, what is false. It only understand what it sees, right? What your eyes can see, he will only understand that. So make sure you tell your brain that you are going to go get how many marks? How many marks? More than 200. If you think like that, your brain will work like that. If you think like that, right now you don't have confidence, you are like, "Oh, what my friend will think about me if I will get 150 or if I will not pass." It's not about that, right? It's about what you think about yourself is something that you are going to become, right? So we are having this peristalsis, we are having mass movement, we are having segmentation and migratory motor complex. What is this peristalsis? Remember, this peristalsis is forward movement of the food. Always remember this contraction is due to what? This contraction is due to acetylcholine. Contraction is due to what? Acetylcholine. Acetylcholine is going to do contraction, whereas nitric oxide is going to do the relaxation. You always know about it that food will always move in the forward direction. Food will always move in the forward direction. Is there any possibility this food will come from your colon through your mouth? No, it's not like that. Even if it start to happen, we are having certain sphincters like esophageal sphincter, pyloric sphincter. Right? We are not designed like that, but still you can have reverse peristalsis till some extent. Like if you are having food in your stomach, it can go to your stomach, it can go to your duodenum, right? Sometimes you have bilious vomiting. That is a reverse peristalsis, but not beyond that. The food will not come from the large intestine. Food will not come after the jejunum, right? So that is going to be the basic funda, right? Peristalsis means the food will move in the forward direction. Why this food is moving in the forward direction? Sir, posterior segment is going to get contracted and anterior segment is going to get relaxed. This posterior is contracted, anterior is relaxed. Food is always going in which direction? Forward direction. Okay, just like that, it will be contracted, it will be relaxed. This contraction is due to acetylcholine and substance P. This is what they have asked. This same image they have given in the examination, and they have asked why this, which of the following is going to be the thing which is going to be working here. But the option here they have asked, and the options are not any of them, right? Answer was VIP. One more thing which is going to cause relaxation that you have to remember is going to be VIP, gastrointestinal peptides. So two things contracting the posterior segment. This is going to be your acetylcholine substance P. Two things dilating your anterior segment. This is going to be your nitric oxide and vasointestinal peptide. This is known as peristalsis. Peristalsis, you understand what is peristalsis. What is mass movement? Mass movement cannot be the dominant modality. Mass movement you are having two times in a day. One, when you wake up in the morning, you have that movement, you have that urge to pass this tool. This is known as mass movement. Okay, so mass movement is what? Urge to pass this tool, that is known as mass movement. And this thing can be more in the children. Okay, just understand this from the pediatrics point of view also. This thing is more in the children because the mother will come to you and she will always be like, sir, I'm feeding my baby, and as soon as I feed my baby, he will start defecating, right? Because these reflexes will take time. When you are small, your smooth muscles do not have that power. That is why you urinate, right? You cannot control your urination, you cannot control your stool, you cannot control lots of things when you are small. As you grow up, you will have that power over those sphincters and all. Now you can control all those things, right? So this mass movement can be happening due to in children due to duodenocolic reflex can be there, or jejunocolic reflex can be there, right? Gastrocolic or gastrocolic reflex. So that means when you have the food in the gastric region, you will be having increased motility in the colon. And that is why what will happen as soon as the mother is feeding food in the stomach, and the baby will be having what? Defecation. You understand this? What is mass movement? You understand what is mass movement? What is peristalsis? What is segmentation? Segmentation is what? Segmentation is this particular process is known as segmentation. Try to understand this. Look here. We are having what? We are having, let's take any segment here. For example, I'm just taking this particular segment. Give your complete concentration. Look here. When I'm called, this particular segment is having what? Food. This is your food particle. And this segment is what now? Relaxed. This segment is what now? Relaxed. Now what is going to happen? The same segment is doing what? Contraction. The same segment is doing what? Contraction. Now the same segment is relaxing. Again, same segment will do the contraction. So it is this type of movement. This type of movement. One time contraction, one time relaxation, one time contraction, one time relaxation. Is it the dominant motility? Do you think is it the dominant motility? Yes, sir. This is the dominant motility because what is the function of digestion? Let me write it for you. The meaning of digestion is going to be what? Breakdown of complex food substances into simple. Like you are eating dosa, you are making what? Glucose. This is known as digestion. This is known as digestion. What is absorption? Now this glucose is going into the submucosal blood vessel. Submucosal blood vessel. This is known as absorption. Now it requires some glut or SGLT. That is going to be different thing. But what is digestion? What is absorption? Is it clear to you? Both of them together are known as assimilation. Assimilation. Both of them together known as assimilation. So breakdown of complex food substances into simple ones and absorbing those simple substances is going to be the process that is going to be happening over here. Right? So this is going to be what? This is going to be the dominant motility. If suppose if peristalsis is the dominant motility, do you think you are able to absorb anything? You are having this bolus that you are eating, it will be going away. If peristalsis is the dominant motility, give your reasoning. If peristalsis is the dominant motility, do you think this food will be absorbed somewhere? This food will be broken down into glucose. The peristalsis is what? Forward movement of the GIT is known as peristalsis. So peristalsis cannot be the answer, sir. Mass movement. Now you understand what is mass movement. So you are not going to answer mass movement, right? This segmentation. Now you know segmentation. You can understand. Yes, sir. Function of GIT is to what? Is to break this complex carbohydrate into simple forms, complex proteins into simple amino acids, right? Ultimately, we are having this particular thing, migratory motor complex. Before the class, you were hungry. You are having voices coming from your stomach. Do you know that sometimes we have voice coming from our stomach? A strong voice of like lots of mouse are running in our stomach, isn't it? So what is that voice is coming from? That voice is known as migratory motor complex, also known as MMC. This is a strong wave of contraction. Listen to my words. This is a strong wave of contraction that is generated from the stomach, from the mid part of the stomach, and it is going to go where? From mid part of stomach to terminal ileum. It is going to go to terminal ileum. You know, when we are hungry, every time we are hungry for such a long time, you skip your breakfast, and I'll keep you sitting here for 3:30, 5, 6 hours. You will be having that voices coming from your stomach, right? And what is this voice that is coming from your stomach? This is going to be your migratory motor complex, right? What is happening in your stomach? Stomach is just like this pipeline. You know, we have sink, below the sink we have that pipeline. We are putting all the materials, right? That would be getting dirty, right? Same story will happen with our alimentary canal also. You are eating whatever things comes in your hand, you are eating that, right? And because of that, what is going to happen? This thing will be getting, there will be some problems, right? So to clear that, to clear that particular thing, to do the cleaning, we are having this particular migratory motor complex. When you are hungry, you will be having a strong wave of contraction that is generated from the mid part of the stomach till the terminal ileum it will go. Okay? How you should do, what you should do when you have this MMC? What you should do when you have this MMC? This is also known as, this is the broomstick of GIT. And what you do, what you should do, and what you do whenever you have this, whenever you have this type of voices coming from GIT, you do what? You eat food. What you should do, you should help your body to clean, right? Cleaning is happening, right? This is what is happening. Cleaning is happening, right? You should drink some water. Like in the morning you have this particular thing, so you should drink water. You always, like in Ayurveda or like in old tradition, what we are doing, we are drinking lots of waters to clean that, to help that, to augment that. What we are doing, we think like that. This is what is the hungry stomach. This is not the hungry stomach, right? As a doctor, you should know. If you know, then you can guide others, right? So this is going to be what? This is going to be migratory motor complex. Migratory motor complex. This is also known as the broomstick of GIT. Motility is important. How many motility? Three motility I've told you. One is electrical, one is mechanical. Right? Electrical we are having is basal electrical rhythm. This is due to SA node cells, interstitial cells of Cahal. Right? Second is mechanical. Fat state is different. Fasting state is different. Fasting, you can remember MMC. Okay. Now, what is the function of GIT? We have already discussed. The function of GIT is digestion and absorption. So, how you are going to digest the food? Whatever food you are eating, paratha, what happens? What is happening with that paratha? The first bite you had of paratha, the first bite you had, you will be having the bite going into the mouth. Right? We are having three macronutrients that we are going to discuss about carbohydrate, about the lipid, about the proteins, right? So let's understand what are the locations where this digestion is going to take place. So we are talking about carbohydrate. Do you have carbohydrate digestion in mouth? Yes, we are having which enzyme? Amylase will be there. Amylase, always remember, amylase is always concerned with the digestion of carbohydrate. You have digestion of starch in the mouth. You have carbohydrate digestion in the mouth. Do we have any enzyme for digestion of some carbohydrates in the stomach? Remember, this is the another question. No enzyme. Stomach will be having pepsin, stomach will be having lipase. So protein digestion will be there. There will be lipase is going to digest lipid. Protein digestion is going to be there. Lipid digestion is going to be there, but there is no carbohydrate digestion in your stomach. Then comes the pancreas. You are having pancreatic. Amylase will be there. And in the intestine, you have the disaccharides, right? So this is going to be the carbohydrate digestion. These are the four places where this digestion is going to take place. Whatever food, listen to my words, whatever food you are eating a lot of things. Some of them are nutritive, some of them are non-nutritive. Some of them are digestible by your system, some of them are non-digestible. So whenever you are eating something which is non-digestible by you, who is going to digest those things? You are eating something, it is going to my stomach, it is going to my duodenum. First part is duodenum, then jejunum, then ileum. Right? Duodenum, jejunum, ileum, then there will be cecum. There will be ascending colon, transverse colon, descending colon, sigmoid colon, rectum. And story is over. The food will be going out. Right? Now, if you are not able to digest certain things, who is going to digest? Think about it. Till then, I'll just make you understand. Where is the absorption is going to take place? Absorption, mostly 99% of absorption is taking place in the duodenum, and jejunum. Duodenum will be having SGLT1 and GLUT5. SGLT1 and GLUT5. This SGLT1 is responsible for the absorption of glucose, galactose, and GLUT5 is responsible for the absorption of fructose. You understand? Whatever we are eating is going to convert into glucose, galactose, and fructose. What is this type of appearance? This is what? Suppose this is going to be your mucosa, and here you will be having the food. Here you will be having the food. This is the food. And now through this food will be going where? In the blood vessel. This is going to be which layer? Submucosa. Submucosa will be having blood vessels, right? So this food will be absorbed, and this food will be going where? Into the submucosa. What is going to go into submucosa? Glucose, right? You are eating anything, it will be converting into carbohydrate, will convert into glucose ultimately, right? As for fructose, it is responsible for the GLUT5 is responsible for the fructose absorption, right? Here you will be having GLUT2, which is going to transmit both of them. GLUT is going to be a type of. Does it require any energy? No, it requires certain pumps, right? This is going to be what? This is going to be a type of facilitated diffusion, right? You understand this? So absorption is going to take place in duodenum and jejunum. This is the complete story of your carbohydrate, any carbohydrate you are eating. Okay, I'll make you understand from this particular part. Till now I have make you understand till now I make you understand what will happen when you eat something, right? It will be getting digested, it will be coming into your GIT, right? This is a short summary. I'm not going into detail, but superficial things, at least you have the story, right? Second thing we are having is lipid digestion. You tell something about the carbohydrates. Something about carbohydrates. Digested. You asked me your question. What do you want to know? Want to? You told like you tell now something after this. I will explain you what will happen with this glucose. Not now. In next chapter, I'm explaining. हाँ हाँ बोलो. I forgot the question. Yeah, I got it. Okay, I'll make you understand that also by the end. So where this carbohydrate is going to go? Second thing we are having is about the lipid digestion. Let's see whatever we are eating. Basically, let's understand this. Then I will explain. Okay. So we are having this lipid digestion. Lipid digestion. Lipid is going to be what? Now you know what is lipid. What is lipid? Fats. Basically, lipid is going to be a fat, right? So, do we have lipid digestion in the mouth? Yes, we are having lingual lipase will be there, which is coming from the Ebner's gland, right? Do we have lipase in the stomach? Just now I told you, sir, lipase will be there in the stomach. Lipid digestion will be there, and pancreas definitely we have pancreatic lipase, right? So digestion of lipid will be happening all the places. This is the digestion of the lipid, not the absorption. I'm not talking about the absorption, right? Absorption is happening at the level of duodenum and jejunum. 99% of the things will be absorbing in the duodenum and jejunum, right? Protein digestion. Do we have enzyme for protein in the mouth? No. Now the second question is, we do not have any enzyme for which digestion in the mouth? Protein digestion. Protein digestion, we do not have any enzymes. Do we have protein digestion in stomach? Yes, we have. Do we have pancreas? Yes, pancreas will be having trypsin, chymotrypsin, which are going to digest the protein. So two questions. Carbohydrate is not digested where? Carbohydrates and proteins are not digested where? Mouth. Okay. Now I'm telling you whatever things you are eating. Till now, what I've told you, you are eating biryani. Let's say you are eating biryani. Biryani will be having what? Not just carbs. Some people see protein, some people see carbs, but some people also see the oil. Right? Three things will be there. Carbohydrate will be there, rice will be carbohydrate, oil will be there, and there will be maybe chicken biryani. That would be the protein part. Protein part will be there, right? So what will happen with that chicken biryani when you eat that chicken biryani? That is going to go to your carbohydrates will be converted. Those rice will be converted into what? Glucose. Rice will be converted into glucose. It will go to your blood. It will give you energy, right? What will happen with the lipid? That lipid will get digested, and this lipid will be transported. How? I'll make you understand that also, right? What about this protein? This protein is going to get digested, and this protein is going to go to your body. What is protein? Protein is long chain of amino acid binded together by which proteins? Binded together by Long chain of amino acid which is binded together by peptide bonds. Peptide bond. This is going to be what? This is your protein. This is your protein. So protein will break down into amino acid. Okay. What is the, like, one more question I can ask you? What is the only amino acid that, or you can say not just amino acid, what is the only substance that would be present in the blood when you eat the food? Like, you are not able to answer this, but let me make you understand. When you eat the food, all the amino acids will go into the cells, apart from only one, that is going to be your serotonin. Serotonin is 5ht, 5ht, right? So that 5ht will be present in the blood, and this will be circulating in the blood. So when you eat food, this 5ht will circulate in the blood, and you already know serotonin is something which is making you feel what? Happy. So when you eat food, you will feel happy, isn't it? Yes, good food, good life. Tara? So why this thing is happening? Because serotonin is the only one which is going to the brain. It can cross your brain, blood-brain barrier. It is going to make you happy, right? So this is going to be the thing. And whatever food you are eating, that is digestible. Sometimes some people are eating what momos and all, right? They are eating some things which are non-digestible, or maybe their digestive system is weak. So when you are not able to digest anything, that thing will be given to the bacteria. We have inbuilt dustbin. We have inbuilt dustbin. That is the cecum. Cecum is having what? Lots and lots of commensal bacteria. What is the function of bacteria? Bacteria will do fermentation. Bacteria will do fermentation. So whatever things which are non-nutritive, non-digestible by you, those things will be given to bacteria. Now bacteria will do the fermentation. They will eat up the thing. They will make what? Whenever they will do the fermentation, they will make gases. Right? That is what is the flatulence we are going to have. Right? You understand that? Why? If some people are going to come to you, you need to understand. It's not about the MCQs only. People are going to come to you and they will be like, oh, I'm having like lots. Okay, just a minute. What do you say now? From where it is? Hello, hello. All right. Are you able to? Now maybe okay. Is it okay now? Why this word? It's not about the book. It's about the. Come. Is it okay now? Is it fine now, guys? Yes. Okay. So what I was discussing about this particular thing. Huh. So what we were discussing about, whatever things which are non-digestible by you, they will be given to the bacteria, and now these bacteria are going to do the digestion, and they Whenever they do the digestion, they are going to make certain gases, and that is what is going to produce flatulence, and symptoms in the patient will be blocking. You understand? Patient is coming to you, they'll be like, I'm passing a lot of gases, flatulence is already there, and my stool is also not good. Right? You will check for the stool consistency. We have the Bristol chart. Right? We check for the stool consistency. We'll find this patient is maybe he's eating non-nutritive things. Maybe his digestive system is having some issues. Then you give the digestive enzymes to the patient or look for certain infections that are happening, right? So that is the thing we are going to have, right? You understand this, how these things are getting digested? Next thing we are having is cells in the GIT. What are the cells we are having in the GIT? Right? So we are having this particular stomach, and this stomach will be having this surface mucus cell, mucous neck cells, parietal cells will be there, chief cells will be there, and G cell will be there. Remember, G cell is going to release what? G for G cell is going to release gastrin. Parietal cell is going to release HCl and intrinsic factor. Parietal cell is going to release what? HCl and intrinsic factor. And this chief cells, you can remember Pepsi company chief. Okay, he's the chief of Pepsi company. You can remember pepsin, and along with the pepsin, always remember lipase. Okay, so pepsin and lipase are going to be together. Do we have any amylase in the stomach? No, no carbohydrate digestion in the stomach, no amylase in the stomach. Only two cells I've told you. Only two things will be there. Pepsinogen, which is going to digest what? Protein, and lipase, which is going to digest what? Lipid. This is what we have seen in the stomach. In the stomach, we are having what? We are having pepsinogen and gastric lipase. Gastric lipase will do the lipid digestion, and pepsinogen will do the digestion of pepsinogen will do the digestion of this particular thing, right? Now, apart from that, we are having other cells also. Now, let's try to understand other cells. Before that, just look here. So, whenever you are eating a food, I'll just give you a story. Are you guys able to understand this? I'm just giving you the story. If you have difficulties, like you can refer back to the our complete notes also, right? So, what is going to happen whenever you are going to eat a food? This is your pyloric. This is your esophageal sphincter. This food will be coming into your stomach, right? In the stomach, you will be having what? In the stomach, you will be having the acid. You are eating something. This is your paratha bite, right? You are eating maybe biryani. Let's say biryani is going into the. This is the food. It is coming into the stomach. Now, when the food is going to come to the stomach, your stomach will be releasing one hormone. What is the hormone? What is the thing which is going to come out when the food will be in the stomach? That is going to be your parietal cells will get activated. You will be having HCl, and this HCl is going to digest the food. What is the digestion that is going to happen over here? HCl is going to digest the food. What is the digestion happen in the stomach? Digestion of carbohydrate, is it going to happen in the stomach? No. Digestion of protein, is it going to happen in the stomach? Yes, sir. Digestion of lipid, is it going to happen in the stomach? Yes, sir. Here you will be having gastric lipase and gastric amylase, which are not amylase, gastric lipase and gastric lipase will be there, pepsin will be there, which is going to digest the proteins, which is going to digest the lipid over here. कहानी समझ में आ रही है? Are you understanding this story? Right? So what is going to happen? You have this particular food over here. Now this food, when it is digested here, now the food it is digested here. Now it will go where? It will go to your duodenum. It will go to your duodenum. As soon as it will enter into duodenum, the first part of the duodenum is going to release what? It is going to release a hormone. This hormone is known as secretin. Since this food is going to be acidic in nature, first thing we need to do, we need to make it basic. We need to make it basic. You already know that pH of duodenum is going to be acidic or basic. Basic pH will be there. So secretin will do what? It will activate your pancreas. This is the pancreas. Here you will be having opening of the pancreatic duct, right? And pancreas will be having this bicarbonate ion, and this bicarbonate ion will be coming into the this duodenum. And first thing will be that is going to be happening is going to be what? First thing is not digestion. First thing is neutralization. And this secretin is the first hormone to be discovered, and it is also known as secretin is also known as what? Nature's antacid. This is known as nature's antacid, right? Nature's antacid. This is going to activate your Brunner's gland. Brunner's gland will release what? Bicarb ion, right? This is going to release bicarb, and this is going to do the first thing. First thing. Second thing, it is going to do what? It is going to inhibit the gastric motility. right? So that more food will not come. And third thing, it will decrease the bile acid secretion. It will do what? It will say, first, let me make the pH basic. This is acidic food. First, let me make the pH basic. Once the pH will become basic, now what is going to happen? Now this food will travel more further, right? Now this food will travel more further. Now this is acidic food or basic food? This is acidic or basic? This is going to be a basic food. When this basic food is going to move a little bit more further, what is going to happen? Another hormone is going to come into action. This is your cholecystokinin. And this cholecystokinin will release what? It is going to the your pancreas, and now your pancreas will release the enzymes. What are the enzymes of pancreas? Lipase, amylase, colipase, trypsin. Remember, we have seen pancreatic enzymes. Pancreas will be having all the enzymes for digestion, right? Pancreas will be having all the enzymes for digestion. Pancreas has trypsin, pancreas has lipase, pancreas has amylase also. So carbohydrate, fats, protein, whatever is there in the food, it will be digested in the duodenum. Yes or no? Yes, and this cholecystokinin is also going to relax this sphincter. This is the sphincter of OD. This is the sphincter of OD, and it will be also having opening of from where? This opening will be coming from where? Bile duct, and it will be having opening from the bile duct, bile and hepatic also. Hepatic duct will come, bile duct will come. They will bind together, and then both the ducts will bind with the pancreatic duct, and this is going to be the duct which is going to open in the duodenum. बात समझ में आ रही है? Are you understanding this story? We are having this bile duct, we are having this hepatic duct. This is the common duct that is going to come here. It will be opening with the pancreatic duct. And now pancreatic substance or liver substance, bile substance, everything will be coming where? Into the duodenum. Duodenum, right? This is going to be the function. This is going to be the function of cholecystokinin. Cholecystokinin. Or let me just make you understand that also. The theory is written the same. What is the function of bile? Bile function. What is the function of bile? Speak, speak, no issues. Let me make you understand. Look here. Bile is going to do what? Bile is going to do what? We are having what? We are having this particular bile. Bile is going to coming from where? Suppose you are having the same biryani. You are having this biryani particles over here, right? Okay, you have eaten biryani. You are having those biryani in the mouth, in the stomach, in the from the stomach. Now it is coming to now it is coming to duodenum. Very important concept. You will be understanding the clinical relations also, right? So what is going to happen when this food is going to come into your duodenum? Your duodenum will be first doing what? First, it will be doing what? Base, it will make the pH basic. That is the secretin it will be releasing, and now it will become basic. Once it will become basic, now what will happen? Now pancreatic enzymes will come and they will do the digestion. Biryani will be having oil, and oil will be digested. Now, how this absorption is going to take place? Because it is a lipid, and lipid, this lipid cannot cross this particular membrane, and this lipid cannot directly come into the submucosa or in the blood. It directly cannot come here, right? So, what is going to happen now? That comes the bile, and the function of bile is what? You always say emulsification of fat. Now, you remember this thing, but what is the meaning of that? Let's try to understand. Now, this bile will come and this bile will bind with these particles, and it will be act like a vehicle. It will act like a vehicle. It will transmit all those particles, fat particles into blood vessel. They will transmit all those lipid particles into blood vessel. And after transportation, what will happen? This bile will go away. After transportation, this bile will go away. It will go to liver. This bile which was there is going to go to liver through blood, and this is known as enterohepatic circulation. It will go under enterohepatic circulation. And now you are having what? Now you are having lipid in the blood. Lipid in the blood is what? Lipid in the blood is known as lipidemia, hyperlipidemia, basically, right? So now this lipid cannot travel alone in the blood. Do you have lipid traveling in the blood? No. This lipid is going to bind with some proteins, and these proteins are known as lipid is binding with the protein. This is known as lipoprotein. How many lipoproteins you know? Five. You know about this. Just correct, correlate this story. LDL, HDL, VLDL, IDL, and chylomicron. They will be traveling in the body. They will be LDL will be traveling in the body. Suppose you are eating too much of biryani. Now what is happening? Try to understand. You are having bile. Too much of biryani means too much of oil. You are eating too much fried food. What will happen? This LDL will increase in the blood, and now this LDL will go to your coronary vessels. Are you understanding? This is coronary vessel. It will get extracted over here. This is going to cause what? Atherosclerosis. So you are having this disease because of eating glucose, because of eating carbohydrate, or because of eating oil. Oil. You understand the difference? The difference is very important. If you eat carbohydrate, it will convert into adipocyte. If you eat carbohydrate, you will get fat. But if you eat more oil, you will have what? Atherosclerosis. So what you will advise to your patient who are having risk of atherosclerosis, you will advise them to eat. Uh, they are having certain oils in the market like Sapola and all those oil, heart healthy oil and like that, right? You understand the functioning, right? So this is the functioning. If this liver or bile is not working, if this liver or bile is not working, do you think this fat is going to get into the blood vessel? If liver is not working, if bile is not working, there will be emulsification. Yes or no? No emulsification. If that bile is not there, है ना? Bile नहीं है ना? So if bile is not there, what is going to happen? No emulsification. Okay. No emulsification means what? Do you think this fat will be going out into the stool as it is, or is it going to get into the blood vessel? It is not going to come into blood vessel. It will go as it is. So stool in fat, that is going to be what? Fatty stool. That is going to be what? That is going to be statoria. Statoria. Fatty stool. Fatty stool. As soon as you see, what you will think about? Fatty stool means what? You will think about fatty liver because you missed the topic, right? They know what is the basic problem. Problem is where? In the emulsification. Emulsification is not there means what is not there? Bile is not there. Bile is made where? In the liver and then stored into the gallbladder, right? So what is going to happen? If anyone is coming to you with steatoria, where you will think about? Anyone, two patients are coming to you now. One patient with the flatulence and bloating and all those things. What you will suspect? Flatulence is there. That means he is eating maybe non-nutritive substances. Digestive problems will be there. Second patient coming to you with the steatoria. Steatoria means fatty stool, sticky stools, foul-smelling stools, and which is not going away with running water. These are the complaints patient will say. Okay, patient will come to you and he will give you these complaints. I am having this kind of a stool, fatty, sticky stool. So you will think about what is the problem. Bile is the problem. Bile is the problem. That means either the problem lies in the liver, either the problem lies in the bile duct. You understand? No need to mug up. Once you understand of how it is happening, no need to mug up anything, right? You understand how this lipoproteins are coming, how this LDL is formed. What is the basic funda behind this, right? Next thing is about the parietal cell. What is this parietal cell is going to make? This parietal cell will be having three positive factors. This is your exam question, INI set exam question. They ask you all of the following factors are going to all of the following factors are going to increase the acid synthesis except, right? So what are the three factors? First, we already know this acetylcholine is coming from which system? It is working via which receptor? Parietal cells means where it will be? It will be present in the GIT, in the stomach. These are going to be the cells which are present in the walls of the stomach. Suppose this is going to be the blood, this is going to be the smooth muscle, this is going to be your parietal cell, and here you will be having what? Here you will be gastric mucosa. Here you will be having gastric mucosa. Understand where is the location? Okay, this is going to be the gastric mucosa. Here you will be having the cell, and on this side you will be having the smooth muscle. Orient yourself first, right? Now what is going to happen? In the blood we are having in the smooth muscle. In the blood, we are having what? We are having not smooth. This is going to be submucosa, and submucosa will be having blood, and blood will be having what? Blood will be having this acetylcholine. This acetylcholine will come, and this acetylcholine will come, and it will activate which gland? Parietal cell. It will activate parietal cell, and now parietal cell will be making H plus and Cl minus, and they are together going to become what? HCl in the stomach. HCl in the stomach, right? So this is how it is going to form, right? H2 is going to be what? Histamine is the H2 receptor, which is also going to stimulate what? Which is also going to stimulate synthesis of this HCl. And third thing is G cells. G cells, we have seen G cells are going to release gastrin, and gastrin is also going to stimulate the HCl synthesis. So HCl synthesis, acid synthesis is under three things. What are the three things? First one is M1 receptor. Remember M1 receptors? Acetylcholine. This is the gland, right? Second is histamine. Histamine will be having four histamine, H1, H2, H3, H4, right? This is the H2 which is responsible for the GIT. Gastrin is going to be there. This is going to release what? This is going to release acid. That are the three things, right? Here you will be having a special pump. This pump is known as which pump? This pump is known as proton pump. You know proton pump inhibitor drugs? They are going to kill this particular pump. Proton pump inhibitor will be having half-life of 2 to 3 hours. But they are a kind of hit and run drug, so they will come and they will kill this. So this parietal cell needs to make new proton pump, and new proton pump will be formed within 24 to 48 hours. That is the reason PPI are going to be working very long, right? So this is going to be the thing. Here we are having this chloride bicarb exchanger. This is going to be what kind of transport? Chloride bicarb exchanger is what kind of a transport? Primary active, secondary active, chloride bicarb exchanger. Yes, very good. This is a secondary active transport because it is an exchanger. And this is the exchanger which is also responsible for 70% of this carbon dioxide in the body will be traveled via this bicarb form. This is the bicarb form which is going to traveling, which is going to responsible for the traveling of CO2. You can appreciate here H2O plus CO2 is going to make what? H2CO3, and now this H2CO3 is making what? HCO3 plus H plus, and this is the HCO3 which is going to be responsible for what? Transport of what? CO2. CO2, isn't it? Right? So this is going to be the HCl. This is going to be the HCl. Okay, so this parietal cell is going to responsible for the release of HCl, and second thing which is going to be coming from this parietal cell is going to be intrinsic factor, which is a cab for what? Vitamin B12. Vitamin B12 that you are eating, it is going to bind with the intrinsic factor, and then it will be absorbing where? Absorption of vitamin B12 is going to take place where? In ileum. If you do not have this, if you do not have this intrinsic factor, it will not get absorbed in the ileum, terminal ileum, right? You understand this? Okay. Now comes the ulcer part. What is the ulcer we can have? We can have two types of ulcer over here. We can have peptic ulcer. It can be of two types, gastric and duodenal ulcer. Okay. We can have gastritis. Three types of gastritis will be there. How many types of gastritis can happen? Type A, type B, type C. Type A is going to be autoimmune, where you have formation of auto antibodies against anti-parietal cell antibodies will be there. And this parietal cell antibodies is going to release excess of HCl. This is anti-parietal cell antibody, but here it will be causing gain of function. Gain of function means what? You will be having more HCl secretion. Type B is going to be due to a bacteria. What is the name of that bacteria? Bacteria causing this particular thing. Still, you have 70, 80 days in your hand. See then, 80 days. 80 days means limitless possibilities. Online people also 80 days. You can You can change your fate. Right now, I don't know, maybe you're with this particular subject like this. Remember this helicopter, Helicobacter pylori. Right? This is a bacteria, and type C is due to cytotoxic. Samsung is answering. Third one is cytotoxic. 80 days and you can change your fate. Even if you start today, even if you know nothing till now, even if you start seriously today, you can change the outcome. 80 days is more than enough time. Even if you start today, definitely you can get more than 200 marks. The only thing you need to have the right path, the smart study. That is what is important. And lots of revision and questions. How many of you are going to appear for the first time for examination? How many of you are going to appear for the last time for this examination? Still you are underconfident. Raise your hand like that. This is the last attempt. This is not the first, second, or third attempt. This is the last attempt. And one thing I always convey to my students, listen to my words very carefully. It's not about passing the examination. It's about how you enter into the medical field. When you go to hospital, you should have that much of confidence that you know things. You're not going to deal with the machine. You are not going to check with the. You're not a plumber or a mechanic, right? कि नहीं आता तो छोड़ दिया. It's not like that. You are going to deal with the humans, and if you make a mistake, instead of myocardial infarction, you give the treatment of heart failure, or in the heart failure or cardiac arrest, you give the different treatment. The patient will be bye bye, tata bye bye, katam. Story will be over. Patient's story will also over. Your story will also get over. I'm not making a. I'm not just trying to make you feel like inferior, but the thing is, you have to do a lot of hard work. Literally, a lot of hard work is needed because tomorrow you think like that. You are a doctor. You have that thing in your mind. You have that like you deserve that respect. I'm agree with that. But you ask yourself, once you ask yourself, put your hand on your heart and ask yourself, do you really deserve that respect? People are respecting you. People are calling you this and that, right? But do you really know things? Do you really have that thing that you can treat any patient? You can sit alone in the OPD, you can sit and you can watch your patients. Are you going to do justice? Or are you going to go to such a doctor who is less than excellent? You have some issues at your family, you will take you're just having stomach ache, you go to gastroenterologist, isn't it? You find who is the best gastroenterologist we are having. How can we expect that we are going to open our shop and we are going to run our shop with this particular base? This is the last time when you are studying. Make sure you study like that. Make sure you study like that. It's my work is to do rapid revision. I can teach you. I can run also. That's completely doable for me, and you're not even going to get realized about it, right? But the thing is, I'm doing my hard work. You will also need to do your hard work. Make sure you have a good timetable after this tomorrow class. Revision has been started, but we are not in a state of revision. And luckily, we have good enough of time. Enough time. We are meeting at the good time. Right? We have enough time that you can pass your examination with the knowledge. Right? Like I don't know how much you are grabbing, but I believe nobody is dumb. Nobody is smart. It's all about the hard work. You tell me I don't understand, I don't even believe it. I'm going to teach you from the zero. I can teach a non-medical also this thing. So if I can teach a non-medical this thing, you are a doctor. So if you tell me I don't understand, language might be a barrier. You don't like it in Hindi, you don't like it in English. Some people don't understand. You can have it in Telugu, right? But make sure you learn it somehow. Without learning, if you go to hospital, you will hide yourself. Trust me, I can give you hundreds of examples. Those people who are even reaching to the NEET PG, they have passed NEET PG, they are doing residency, still they are left in their residency program. They are they are doing something else. So we are not going to make the mistakes that other people have made. We are going to learn things. Be curious. Why you are coming to the class is not to just complete this syllabus. It's not your duty to complete this. It's my duty to complete this. Your duty is what? Your duty is to learn things. If you are not having, you can ask me, sir, please go in detail. We can have 1 more hour extra. I'll be here today, tomorrow, day after tomorrow. I'll be having the flight, right? I'll be here. If you have issues, if you are not understanding, come to me in break. But please clear your doubts. I would be more than happy if you ask me, sir, why this thing is not happening and that thing is not happening. I would be more than happy, right? So make sure you learn things. You are here for learning, not to complete this, right? And it's not difficult. It's very, very simple. All things are simple. It's about the perception. What is your perception? That is going to matter. Like, let me teach you about this H. pylori. You already know H. pylori is a bacteria which is going to cause ulcer. Now, why, sir, have this thing come to your mind? Why this thing is going to cause ulcer? Let me make you understand. This H. pylori is going to block with cells. It is going to kill your delta cells. And what this delta cells are the cells which are going to make what? Somatostatin. Delta cells are going to make what? Somatostatin. And in your complete life, remember, somatostatin is a universal inhibitor. Wherever it goes, it do the inhibition. So what is the function of this somatostatin? It will inhibit the gastrin. What is the function of somatostatin? It will inhibit the gastrin. This is the normal physiology. Delta cells will be there, which is going to make what? Somatostatin, and somatostatin is going to inhibit gastrin. Now you are having an infection. This is H. pylori infection, and this H. pylori infection is going to kill this delta cells. If this delta cells are not there, do you think this somatostatin will be there? No. If this somatostatin is not there, do you think this gastrin will stop? No. If gastrin will not stop, you already know gastrin is going to do what? It is going to make what? Three things which are making acid. One of them is going to be gastrin. And now this gastrin is going to make a lot of acid, and this acid is going to cause what? Ulcer. So you understand why this ulcer is happening. Is it difficult? No, just need one time understanding and it will be with you. Right? So why we are having ulcer because of H. pylori? Because it is going to cause what? It is going to cause this particular thing. First thing. Second, if you go in micro, it is going to be a urease positive organism changing the pH of your stomach. That is what is also the second thing which is going to explain this particular fact, right? How you are going to kill this is it is a bacteria. You give what? You give antibiotic cap therapy. What is cat? Clarithromycin, amoxicillin, and one PPI story will be over. This is known as triple therapy. Why to kill this? Why to kill this bacteria? Is it going to be difficult? Is it going to be problematic for us? Yes or no? Why? It is so problematic. I have lost one of my friend because of this, and he was also a doctor. He passed his FMG examination. He completed his internship, 2 years of internship. Last month of internship, he was diagnosed with H. pylori infection was there, and he was diagnosed with gastric adenocarcinoma. Okay, 2 cycles and story is over. 2 cycles of chemo, and now he's no more. Right? What is the thing? This bacteria can cause cancer. This is a bacteria which can cause cancer. Two cancer it can cause. One is maltoma. Maltoma is what? Mucosal associated T cell lymphoma. And second, gastric adenocarcinoma. Why adenocarcinoma? Adeno? Adeno means glands will be involved. Because it is a cancer of glands. It is a cancer. Gastric will be having the glands. And cancer means, carcinoma means it is a epithelial tumor. Right? So we are having what? Gastric adenocarcinoma. You understand this? gastric adenocarcinoma and maltoma. Simple understanding. If you have identified this, you have killed this. This is not going to convert into cancerous, and this is not going to cause cancer. You understand this, right? Very very important thing. All these things are important. Like we can have ulcers. Gastric ulcer can be there. How to identify those ulcers? Gastric ulcer can be there. Duodenal ulcer can be there. Gastric ulcer means stomach. Ulcer is where? When you eat food, what will happen? You you will be having increased pain due to eating. Increased pain due to eating, and this pain will be relieved by vomiting. This patient will do the vomiting. This pain will be relieved. Okay, and this patient is not going to eat anything like that. So this patient will be a thin patient. Whereas duodenal ulcer means now the ulcer is where? Duodenum. And when this patient is going to eat, this pain will be relieved. Okay, so this pain will be relieved by eating. This pain will be relieved by eating because when this patient is going to eat something, the acid which is there is going to be used up. And when the acid is going to get used up, what will happen? He will be having less acid going into the duodenum. He will be having less pain. So these are the patients who are continuously eating all the time. Every 2 hours, they need the food, right? There are some people they are always eating something. Otherwise, they will be having pain, epigastric pain, right? So that is going to be a symptom of duodenal ulcer. And since they are eating every time, they will be a thick patient. They will be chubby patient, right? So when the patient will come to you, you will also understand. Thick patient is coming, there is a possibility he might be having duodenal ulcer. Thin patient is coming with the symptom of vomiting. Every time I eat, I need to do vomiting. Calocium occurs can be there, right? Anorexia nervosa from psychiatry. And second thing, this you have to keep in your mind, right? You do endoscopy, and whenever you find any lesion, an endoscopy for ulcer, whenever you find any lesion, you bring out that lesion, you do a biopsy, endoscopic biopsy also. That biopsy sample you send for two places. One is pathology lab where they will be identifying whether it is cancerous or not. Second, you will send it for the microbiology where they are going to put the Warden starry silver stain. And always remember, silver stain is always going to give you black color. Stain in the morning, I told you, is the color, right? So if you find black color, this bacteria, black color bacteria, that means H. pylori is confirmed. And the treatment I told you, this is going to be CAP therapy. CAP is the triple therapy. Clarithromycin, amoxicillin plus PPI. Okay. Quadruple therapy also you study in pharmacology that would be having sucralfate or bismuth subsalicylate, right? You understand this ulcer? Okay. Now about the iron metabolism. So same story. This is the food. This is the food will be here. Whatever food you are eating, iron will be present in ferric or ferrous form. Iron that you are eating is going to be present in the +3 or +2. Okay. Ferric will be having C. C is going to be +3. You can remember like that. Okay. So what is going to be the ferric form? Ferric means +3. You can remember, right? C is going to be A, B, C is going to be the third +3. Ferrous is going to be Fe2 plus. So whatever iron you are eating, you have studied about this iron metabolism. You know about this? You know ferrous ferric only. Right. Okay. So whatever food you are eating, this is going to have what Fe3 plus. 2 minutes definite question they are asking from iron. Be it your physiology, be it your pathology, medicine, from any one subject, they are going to ask a question from iron, right? So what is going to happen? Look here. This iron you are eating in the ferrous form, in the ferric form, not ferrous, ferric form, Fe3 plus. Now this iron cannot go inside the cell in the Fe3 plus form. It requires to convert into Fe2 plus first. It requires to convert into Fe2 plus. 2 minutes and you will understand this. Okay, just give your complete concentration on the board. Whatever things you are eating, food iron you are eating, it will be having what? Fe3. Now Fe3 cannot come inside. This is what? This is your food. This is your mucosa. This is going to be the epithelial cell we are having, and here you will be having what? Blood vessel. Here you will be having blood vessel. That means this is what? Submucosa. You understand this thing? Orient yourself. Okay, so food you are eating and food will be having Fe3 plus. after digestion, and absorption is happening at the level of duodenum. Iron absorption happens at the duodenum. Now this is the duodenum. You are eating food, and let's say you are eating uh, spinach. Let's say you are eating cashew, right? It will be having iron. This iron will be present in the Fe3 plus. Now this iron cannot go inside directly. It cannot go into blood vessel directly. So what will happen with this iron? This is what we need to know. This iron will be present in which form? Ferric form. Fe3 plus will be there. Now it needs to convert into Fe2 plus, and this is conversion is happening because of duodenal cytochrome B. And it will convert into Fe2 plus, and now this Fe2 plus can enter inside. Because here you will be having divalent metal transport. Divalent metal means divalency can only enter. Divalency means only 2 plus can get enter. Okay. So this is also a question. This is also a question. Okay. Food iron you are eating in the form of Fe3 plus. It will convert into Fe2 plus with the help of everyone speak with the help of duodenal cytochrome B. Now this Fe2 plus can get inside. This Fe2 plus can get inside with the help of DMT. DMT1 is what? Divalent metal divalent metal transport 1. Now this iron can store in the form of ferritin. Ferritin is the storage form of iron, and this iron storage is happening where? In the duodenal cells. These are the epithelial cells of duodenum, right? If it is not getting stored, what will happen? The extra iron will be going where? It will be coming into the blood vessel. And what is the port? What is from where it is going to come out? Ferro means iron, port, and in. This is going to release what? Iron. The iron that you are eating from food, it is going to come out into what now? This is going to be this is going to be what? This is going to be this particular part is going to be this is the blood vessel. So here this iron is going to come out into the blood vessel. But this iron is going to be in which form? Fe2, because we have already converted this here. Divalent, right? So this is going to be Fe2. But this Fe2 cannot travel in the blood alone, right? So what it will do, it will convert into Fe3, and this conversion is happening because of what? Hepastine. Hepastine. After converting into Fe3 plus, now what is going to happen? This Fe3 plus is also not able to travel alone, right? So it will bind with the it will bind with the transporter of iron. What is transporter of iron? Trans iron. Iron is ferrin, right? So transporter is what? Transferrin is the transporter of iron. Copper transporter is copper transporter. Copper transporter. Ceruloplasmin, right? ATP7B defect can lead to Wilson's disease. ATP7A will lead to Menkes disease, biochemistry. That is the copper transporter, ceruloplasmin, right? Here, the transporter of iron is going to be what? Transferrin. Now, what will happen? This transferrin will transport which form? Fe2 or Fe3? Fe3. And now this transferrin will take iron. Iron is required where? Sir, in the bone marrow. Iron is required in the where in the body? Iron deficiency anemia, right? Iron is required for the synthesis of what? RBCs, hemoglobin, right? Hemoglobin will be having rings of iron, right? So RBC synthesis or iron is required for the hemoglobin synthesis. So it will go to bone marrow. It will also go to some amount of iron will also go to liver, right? And now when this amount is going to be enough, body is having break negative feedback, right? Now when this is going to be get enough, you are eating lots of spinach every day, right? You are having lots of spinach, lots of cashews, right? Now what is going to happen? You have enough iron. Now this liver is going to send a signal. It will tell what? It will send the hepcidin, and this hepcidin is going to put a brake on ferroportin. Now, if this break is there, what is going to happen? Do you think this ferroportin is going to release more of Fe2 plus into the blood? No, this is the break which is happening, and this is the story we are having. You understand this story? What is the story? Iron metabolism. You are eating iron in the form of Fe3 plus. Okay, you understand this? I'll give you patholink, right? You understand this? You are eating Fe3 plus. Now what is going to happen? This Fe3 plus is going to convert into Fe2 plus, which is the form which can get inside. What is the name of the transporter? Divalent metal DMT1. Very good, right? And storage form of iron is going to be ferritin. Now what is going to happen? It is going to come into blood vessel via which? Ferroportin. Now ferroportin will convert, this ferroportin is going to do the transport, right? Now this Fe2 plus will convert into Fe3 plus with the help of Apestin. This Fe3 plus cannot travel alone, so it requires what? Transferrin. Transferrin will take it to the bone marrow, it will take it to the liver, right? And it will be, liver will be releasing a brake, and the name of the brake is absidin. Absidin is a brake for ferroportin. That is the only important question that they can ask you. Now, one question they ask you, if there is mutation of this HFE gene, if there is mutation of this HFE gene, or if there is mutation of this hepcidin, simply you can remember, if there is problem with this hepcidin, what is going to happen? This disease is known as hemosidrosis, right? What is going to happen in hemosidrosis? Do you think this iron will be coming more and more in the blood, right? If there is more iron in the blood, it will go to your liver. It will go to your liver. It will deposit over your liver. It can cause what? Liver cirrhosis. It go to your pancreas. It will, iron is traveling in the blood. It will go to your pancreas. It will get deposited in the pancreas. It is going to cause a special type of diabetes known as bronze diabetes. It will be present on your skin. It is going to get deposited there. It is going to show certain manifestations on the skin. Wherever, whichever organ is going to have iron deposition, there will be some problem. You will understand this, right? So this HFE gene mutation can lead to hemocytosis. You understand this, how these things are happening? This is the normal functioning. If you understand the normal functioning, if you want to give someone iron, this iron absorption is going to get increased by, iron absorption is increased by acid. It is going to increase by acid. Which acid? Like citrus fruit. Okay, citrus fruit. What is the fruit which is having the most amount of vitamin C? This is going to be the amla, right? We are having citrus fruits. Like we will tell our patient to drink it with, drink this particular thing with the lemonade. We are having lemonade, right? So we will give the iron tablets and we will tell the patient to take it with the lemon. What are the things which are going to decrease the absorption? These are going to be your phytates, your oxalates, okay, your tea, coffee, wine. All these things should be avoided. Milk, they should be avoided with the iron. They should be avoided with the iron. The examiner asks question around it, right? If someone is having iron deficiency anemia, you are going to give iron to the patient, right? You can give iron sucrose injection, iron dextromaltose injection. You can give oral iron also to the patient, right? In pregnancy, do we give iron to the patient? Yes. First trimester, first month, the pregnant female is coming to you. First month, the pregnant female is coming to you, and she is having what? She is having hemoglobin 9. Now, would you like to, in pregnancy, hemoglobin 9 is considered less than 11 is considered to be as what? Less than 11 is considered to be as anemia, right? Female is having, let's say, 7. You are going to give what now? Folic acid, yes, iron. Folic acid you are going to give, but what about iron? What about iron? And don't give me dose. 400. No, that is about the folic acid. Iron would you like to give in the first month, first second month? She will be having a disease. What is the disease? She will be having. No, no. For neural tube defects, you are giving folic acid. I understand that. Right? Oh, that is dependent on the low risk pregnancy or high risk pregnancy. If pregnancy is low risk, you are going to give the normal dose, right? If pregnancy is high risk, then you are going to give the high dose of folic acid, right? That is the folic acid. But we are also giving iron folic acid together, but not in the first month. First month, the patient will be having what? Nausea and vomiting, and this particular thing is known as morning sickness. Morning sickness. Okay? Morning sickness. Hyperemesis will be there, na? Hyperemesis gravidarum, right? So morning sickness will be there, and this iron, remember, this iron is going to cause what? This iron is going to be not suited by anyone. If you start taking iron, you will be having nausea and vomiting. So if I'm giving this iron to such a patient who is already having nausea and vomiting, this is going to be a problematic thing. I know she is having what? Iron deficiency anemia. I know she is having low blood, but this low blood I can manage after 1 month also. This low blood, we have a long term for the pregnancy. This low blood I can manage after 2 months or 3 months also, right? I can give injections to the patient. I can give iron folic acid to the patient. But right now, the major problem this female is having about the morning sickness. So first month, second month, we are going to avoid this. And then when she will be having this particular normalization of this morning sickness, then we can add on what? Then we can add on the iron to this particular patient, and that is going to be a good thing to do, right? Folic acid you can give in the beginning also. But if someone you are going to give iron in the beginning, that is going to be a problematic thing, right? Now we are going to discuss about the, you understand what is about the GIT, important question. They are going to ask you about the motility. Definitely they are asking question. Second question, they are going to ask you about the iron metabolism. This is also a definite question. Sometimes they will ask you about the particular enzyme, particular things they are absent or present, what is going to happen, right? Now the next thing we are having is going to be the endocrine endocrine system. Endocrine system will be having what? Endocrine. We are having three types of glands in the body. We are having exocrine, endocrine, and autocrine glands. The things which are coming in the autocrine, they are known as autocoids. The things which are coming from the autocrine, they are known as autocoids. The things which are released from the exocrine, they are known as juices. We are having juices, right? And the things which are going to come from this particular endocrine system, they are known as the hormones. They are known as hormones, right? Now, these hormones can be classified into four categories. We are having class one, we are having class two, we are having class three, we are having class four. How many classes we have? Four classes. Class one will be amino acid derivative. This can be tyrosine, tryptophan, histidine, arginine. Tyrosine is going to be precursor for, I told you, T3, T4. Tyrosine is coming from black coffee. It is activating T3, T4. T3, T4 is activating your metabolism. It is going to activate your melanin. That is why your grandmother always say, if you drink more tea, more coffee, you will get black, isn't it? Yes, she knows about this tyrosine. This is going to make tyrosine, and tyrosine is going to make you black, right? We are having epinephrine, norepinephrine, and dopamine. All this epinephrine, norepinephrine, and dopamine. These are all things which are going to be made from what? Tyrosine. These are collectively known as catecholamines. Epinephrine, norepinephrine, dopamine, they are known as catecholamines collectively, right? Second is tryptophan. This tryptophan is responsible for the sleep. It is going to make what? Melatonin and serotonin. That is why when you eat food, you will be having what? More level of serotonin, more level of eat, sleep, eat, sleep, be happy, and repeat like that. Okay. So that is what is going to happen. Melatonin is going to make you sleep. Right. After food, you will be having what? Sleep will be there, right? Some amount of sleep. After food, you will be feeling happy. That is going to be the happy hormone serotonin, right? This is going to be the serotonin, right? Histidine is going to do what? It is going to make what? Histamine, and histamine is a two function. Histamine has two functions in the life. What are the two functions of histamine? In vessel, it is going to do what? And in bronchus, it is going to do what? Right? And I told you in the morning, whenever a vessel is dilated, something will be coming out. You had a mosquito bite, you had a insect bite. What will happen to your skin? Inflammation is a generalized term. Let me make you understand. Whenever you had any insect bite or something, mosquito bite, let's say, what is going to happen? This vessel will get dilated because this histamine is going to get released. Right? Histamine is going to do vasodilation, and whenever this histamine is released, you will be having vasodilation. Now, from that vasodilation, what will happen? RBCs will come out, and this RBCs is going to give you red appearance. Second thing, the fluid will come out, which is responsible for the edema of that particular thing. And here you will be having this histamine is going to be a local inflammatory mediator. So you will be having that itching also, right? So you will be having itching, you will be having that RBCs coming out. So always remember, histamine is going to do what? Red thing which is happening is because of really, dilatation of the vessel. In the same story, we are having in the nose also. In rhinorrhea, in viral disease, we are having what? Nose vessels are getting dilated. Nasal vessels are getting dilated. When these vessels will get dilated, you will be having what? Water coming from the nose, isn't it? water is coming from the nose, running nose. You take what? Antihistaminic. You take what? Levocetirizine. You take levocetirizine. I know you take, but you don't know why you take, right? So that is the reason we are taking. What it is going to do? It is going to cause. It is going treatment for common cold that you are taking. What are the drugs you are taking for common cold? Antihistaminics or decongestant, antihistaminics. What else? Name of the drugs. You're done with pharma. Yesterday was pharma. Yesterday for biochemistry. Before 4 days, 29th and 28th was biochemistry. Biochemistry. Okay. I'm just giving you basic understanding. Today we have discussed about the alpha one. Yes? Monte Lucas. I'm so done with this Monte Lucas. This Monte Lucas, don't use Monte Lucas. Just trust me. I'll teach you later. I don't have time. Right? But don't give Monte Lucas to anyone until or unless he is having asthma, until or unless he is having allergic rhinitis, until or unless he is having bronchoconstriction. You have bronchoconstriction in normal common cold? You do not have. Don't take Montelukast. It can cause Chidia-Kigasi syndrome. This is a completely irrational and a wrong thing that you are doing, right? As a doctor, you should remember you should not give it to also, right? You are giving Montelukast and azithromycin also. If it is a viral disease, no need for antibiotic also, right? So viral disease, what is going to be the treatment? The problem is what? Problem is vasodilation. Because of that nasal vasodilation, you are having running nose, right? How you can treat? You can constrict the vessel. You can give alpha one agonist. Now you will be telling me. You know about the Otrivin? Yes, sir. Otrivin spray. You know about phenylephrine? Yes, sir. Phenylephrine. You see any anti-cold, sumo cold, chest and cold, nam cold, any anti-cold, you find what? Phenylephrine. You find chlorpheniramine maleate. You find paracetamol. What are these drugs? These are alpha 1 agonist. Why we are giving alpha 1 agonist? Because they know we are having what? Vasodilation. And because of that vasodilation, we are having the running nose. Right? We are having running nose, and this is what is known as symptomatic treatment. We are giving alpha 1 agonist. What is the function of alpha 1? Sympathetic nervous system. Alpha 1 is going to do what? Vasoconstriction. This vasoconstriction will be there. Do you think there will be anything coming out now? No, right? So that is the basic funda. Once you understand the basic, no need to mug up this, right? Any group of drugs you are giving, epinephrine or epinephrine, you are mixing with certain drugs so that it will not come into the systemic circulation. Now you understand how. Epinephrine will cause vasoconstriction and vasoconstriction will close these pores. So now the drug will not go into systemic circulation. You give like prilocaine, we are using anesthetic agents. There you will be giving adrenaline along with it, right? To prevent systemic toxicity. Now we understand how it will prevent. It will close the pores. It will cause local vasoconstriction. You understand this? Okay, you are having a disease like in liver cirrhosis, you are having esophageal varices. Varices means dilatation of vessel. Whenever you have dilatation of vessel, RBCs will come out, and that RBC will come in the form of blood. If it is coming with the sputum, it is hemoptysis. If it is coming with the blood vomiting, it is hematemesis. What is the treatment? Treatment is V1 receptor agonist. V1 receptor, I told you today, V1 agonist is going to cause what? Vasoconstriction. In ADH, I have told you V1, V2, V3. V1 is causing vasoconstriction. V2 is going to cause aquaporins, right? This V1 is name of the drug is terlipressin. So this is going to be the first line drug. Second line is going to be the drug of choice. That is going to be the octreotide. You understand what we are doing basically? What we are doing, we are having a dilatation of the vessel. We are just constricting it. Right? These concepts are simple. Once you understand the concept, no need to mug up. Right? This is going to be the thing. You understand the system in nitric oxide is going to do what? It is going to do vasodilation. This is what we are using in the cases of MI and all. Right? Next thing is about the large protein. These are going to be what? Insulin and parathyroid hormone. Next one is going to be cholesterol derivative. This cholesterol is responsible for formation of these hormones, sex hormones like aldosterone, sex steroids, cortisol. Right? And lastly, we are having certain vitamins which are also acting as a hormone. These are vitamin A and vitamin D. Vitamin A and vitamin D are also acting as hormones. They are also acting as hormones, right? Now we are having certain receptors also. These receptors you studied in pharmacology also. Yes, GPCR receptor, tyrosine kinase receptor, Janus kinase receptor, right? Receptors means they will be present outside the cell or they can be present inside the cell. Means we are having certain hormones and we already know hormones will be present in the blood. Hormones will travel in the blood. Hormones can't travel करेंगे where it will be traveling in the blood, right? And now these hormones can come on the cell surface. So these are known as extracellular receptor. They are also known as cell membrane receptor. Most important is going to be GPCR. And those subunits that I've told you in the morning, GS, GQ, GA sub 0, these are going to be the subunits of this GPCR. Okay. Second, we are having is what tyrosine kinase, Janus kinase. Right? These are the example you have to remember. Intracellular, it can be at two places. One is on the cell, one is on the nucleus. This is going to be nuclear receptor. One is on the cytoplasm. These are going to be your cytoplasmic receptor. In the first slide itself, I told you cell is the basic structural and functional unit of life. All these hormones which are coming from various glands, they are going to come through the blood because blood is the connective tissue. Now they can work on the outside of the cell. This is going to be extracellular. They can work inside of the cell. This can be intracellular. They can work in the cytoplasm. This is going to be your cytoplasmic receptor. Is that okay? Right? Now I will teach you about the hypothalamus. What is this hypothalamus? And what are the different hormones which are going to come from hypothalamus? Can you identify anatomy stand? Can you identify this particular structure? This is corpus callosum. Okay. Here somewhere, this is going to be what? This is going to be medulla, right? This is going to be cerebellum. Here you will be having which structure? Hypothalamus. Above that will be thalamus. Here you will be having hypothalamus. And below hypothalamus, this stalk-like structure, pituitary. Here you will be having what? Not visible. So this is the hypothalamus, right? And this is going to be the pituitary. Here somewhere you will be having a special structure. This is going to be what? Above the pituitary. Ophthalmology. Ophthalmon. Not pineal, it is going to be above the pituitary, it will be optic chiasma will be there. Optic chiasma will be there. Here you will be having the crossing. Optic chiasma will be there, right? So this pituitary tumor can compress optic chiasma and a special vision will be there. What is that vision known as? Bitemporal amyotrophy. You know what? I know what you know, right? I know this is going to be the optic chiasm. This is going to be the thalamus, same diagram, right? This is going to be the thalamus. Now you can see. This is going to be the pituitary. This part is going to be the thalamus part. Okay. Sorry, hypothalamus part. Above will be thalamus. And this particular thing is going to be what? This particular thing is going to be optic chiasma. This is hypothalamus. This is anterior, posterior pituitary. And things will be made here in the hypothalamus. They will be given to what? Anterior or posterior pituitary. Is that okay with you? No issues till now? Yes. I'll give a break after this. Okay, this is the slide. I'll give a break. I'm a person. I give a break every 2 hours, but the thing is, we have a lot to cover, and I have very limited amount of time. Right? If you have read all those things, I would go a little bit more faster. But uh, like I cannot leave you like that. If I will not teach you, will teach you like that. I think like that. Okay. So that is the thing I'm having. That is why I'm just trying to explain a little bit more. Right? So next thing we are having is what? This is the hypothalamus we are having. And this hypothalamus will be having total how many hormones will be there? You can remember four hormones will be stimulatory. One stimulatory. Speak. What is the name of this hormone? I'll make you remember this endocrine. If you remember this endocrine, what I'm teaching you, you will be able to solve questions in the medicine also, right? The basics I'm going to teach you. Look here now. So hypothalamus is going to make four stimulatory hormone. What are those four stimulatory hormone? First one is thyrotropin. Second one is third one is speak guys speak. Fourth one is corticotropin releasing hormone. Four stimulatory hormone, isn't it? Yes. Two inhibitory hormone. One is going to be your somatostatin. I told you it is going to be always inhibitory. These are the two inhibitory. Let me use another color. First is going to be somatostatin, and one more is going to be there. That is going to be dopamine. Dopamine is also known as prolactin inhibitory hormone. This is also known as prolactin inhibitory hormone, right? So how many hormones are coming from hypothalamus total? Four. Total. Why six? Count six. Seven, eight, seven. Here also I'm getting different answer. How many hormones are on the screen? Dopamine, somatostatin, corticotropin, vasopressin. Eight. Total. Eight. Two are left. What are those two hormones? These are going to be Wo hormone. These are going to be Wo hormone. These are going to be V is going to be O is going to be oxytocin. These are going to be two other hormones. So four stimulatory hormones. Speak with me. What are the four stimulatory hormones coming from hypothalamus? These are the four stimulatory. Two inhibitory hormones. Somatostatin and dopamine. And two other hormones. Which are two other hormones? Wo hormones. कौन से hormones? Wo hormones. Which hormones? Speak wo. Speak wo. If you forgot wo, you will forget everything, right? Which hormones? Which hormone? V for vasopressin. A for O for oxytocin. Okay, vasopressin is also known as very good. This is also known as ADH. Antidiuretic hormone. Vasopressin is also known as ADH. You can remember wow also. Wow. Okay. Wow. Right? So this is going to be the thing. Now, just try to understand why and have where these hormones are going to work. This hypothalamus will be releasing. Let's begin with the first one. This hypothalamus will be releasing what? Which hormone? I'll just make a short note. You can zoom and see later, right? So this hypothalamus is going to release one hormone. This is going to be growth hormone, releasing hormone. This is the releasing hormone. Yes or no? Yes. This is going to come from hypothalamus, and this is going to go to where? Anterior pituitary. Okay, let it be first. Let's discuss about the posterior pituitary. Because posterior pituitary is not going to make any hormone. Listen to my words carefully. Posterior pituitary does not make any hormone. It will store कौन से hormone? It will store which hormone? Wo hormone. It will store which hormone? Wo hormone, right? So what are those Wo hormones? Posterior pituitary. Let's discuss about the Wo hormone. O is going to be the oxytocin. Oxytocin is responsible for the ejection of milk. Ejection of milk. Oxytocin can work on two places. It is going to be responsible for ejection of milk. It is going to work on the breast. It is going to work on the uterus. Uterus, it is going to be the drug of choice for postpartum hemorrhage. It is drug of choice, and it is also used for the induction also. Okay, so induction and drug of choice, and this is going to cause what? Contraction of uterus, and this is going to be the thing, right? We want contraction of uterus. Now the same story. Why we want contraction of uterus in PPH? We are having vasodilatation. Listen to my words. Vasodilatation means bleeding would be happening. Now what you want? You want uterus to get contracted so that bleeding will not happen. You understand concepts are going to be helpful, right? So this is the drug oxytocin, which is going to contract the muscle, and muscle contraction will lead to contraction of the vessels also, and that is why this patient will be having decrease in the things, right? Second is going to be vasopressin, also known as ADH. Vasopressin, also known as ADH. It is going to work where? In the kidney. In the kidney, ADH is going to work where? On the upper part of the collecting duct or lower part of the collecting duct? ADH. I'm talking about antidiuretic hormone now. Lower part will be having V2 receptor aquaporins, right? Remember V1, V2, V3 receptor I told you. V1 is going to cause vasoconstriction. Name of the drug is vasopressin ka bhai. Who is the brother of vasopressin? That is terlipressin. I given the esophageal varices. V2 is going to be present where? Aquaporins, and this is present in the lower part of kidney, lower collecting duct of kidney, right? And B3 is concerned with ACTH. Even if you don't remember, it's fine for me. right? But remember this, we this kidney will be having this aquaporins, and aquaporins is going to do what? Retain water. I told you if there is decrease in ADH, you will be having a disease known as diabetes insipidus. Right? Patient will be having more urination. If there is increase in ADH, this is going to be SIADH syndrome of inappropriate antidiuretic hormone. Right? You remember this, right? Aldosterone is a different thing. वो भी आएगा. That one also we will discuss. Right? Posterior pituitary is over. Yes or no? Yes, posterior pituitary is over. Now about the anterior pituitary, we are having the growth hormone. First hormone this hypothalamus is going to release is what? GHR. GHRH, growth hormone releasing hormone. It is going to go to anterior pituitary. And now this anterior pituitary is going to release what? Growth hormone. And this growth hormone is responsible for the growth of the body, growth of the muscle, growth of the organ, growth of the overall person. Right? You can have disorders like acromegaly and gigantism over here. Right? That is going to be the growth hormone. Second hormone we are having is, let's talk about second hormone. This is going to be the GnRH. What is GnRH? It is coming from where? I, why I am teaching you this thing? It is coming from where? Hypothalamus. It is going to where? And now anterior pituitary will release what? LH and FSH. This LH and FSH are going to go to ovaries and testes, and now this ovaries and testes are going to make what? Estrogen, testosterone, and progesterone. Right? Third hormone we are having that is coming from the hypothalamus is going to be, let's say, okay, corticotropin releasing hormone. This corticotropin releasing hormone is going to go to anterior pituitary. And now this anterior pituitary will release what? Adrenal gland. Cortico means cortex part. Adrenal cortex tropin releasing hormone. That is going to be ACTH. And this ACTH is going to work on adrenal cortex. Remember, adrenal gland will be having two things, cortex and medulla. Cortex will be having how many layers? GFR, glomerulosa fasciculata reticularis. This glomerulosa is going to do what? It is going to release aldosterone. Now, this was the aldosterone that we were discussing. This aldosterone is going to make what? Yes, this aldosterone is going to work where? Aldosterone is going to work on the upper part of collecting duct, and it is going to make ENAC channel. And ENAC channel will do what? Epithelial sodium channel. Sodium will be coming inside. If sodium will come inside, what will be going outside? Potassium and H plus. Are you able to remember this? Right? It is going to do, it is going to make ENAC channel, and that ENAC channel is going to do what? Sodium and water retention. Okay, this is going to come out from where? Which layer? This is going to come out from the which gland? Adrenal gland. Adrenal gland will be having which part? Cortex. Right? You understand? And one hormone that you were discussing is the renin. Renin is also going to come to adrenal gland, and this adrenal gland, it is going to go to glomerulosa, and it is going to release what? Aldosterone. And this is the aldosterone which is going to do what? Sodium and water retention. And second function, it is going to go to vessels, blood vessels, and it is going to cause what? Vasoconstriction, leading to increase in BP. Are you able to remember everything, right? We have Pohn's syndrome, we have Addison's disease, increase in aldosterone. What will happen? Now you can need not to remember the symptoms. What will happen? Sodium water retention, sir, BP will be increased, patient will be having hypertension. Yes or no? Patient will be having hypertension because sodium is coming inside the body. And if sodium is coming inside the body, what will be going away? Potassium. Potassium is going away, patient will be having hypokalemia. H plus is going away, patient will be having acidosis ki alkalosis? Alkalosis. H plus is going away from the body. Patient will be having alkalosis. You understand? You understand? Need not to mug up anything, right? So that is going to be the Pohn's syndrome, right? So this is going to be the third hormone, right? Fourth hormone we are having, that is going to be thyrotropin releasing hormone, TRH. And this TRH is going to go where? Anterior pituitary. And now anterior pituitary will be releasing what? The thyroid stimulating hormone, which is going to stimulate which gland? Thyroid gland. Thyroid gland is going to make which hormone? thyroid hormone. These are going to be T3 and T4. And these T3 and T4 will be having receptors on beta 1. And beta 1, you already know, will be present where? Beta 1, kidney and heart. And now you know the symptoms also, what this is going to do. This thyroid hormone, you heard about the term thyroid storm. You heard about the term thyroid storm. What happens in thyroid storm? When you cut the thyroid, you can have rupture of this T3 T4 come into blood. When this T3 T4 come into blood, they go to beta cells. Beta cells will be having functioning. Now you know the functioning. Beta 1 will be activated, SA node will be activated, tachycardia will be there. AV node will be activated, conduction will be more. Muscle will be activated, you will be having palpitation, right? You will be having tachycardia, you will be having hyperconduction, you will be having palpitation. And second thing, it will be activating your renin, leading to increase in BP. You will be having hypertension. Now, all these things collectively known as the drug of choice for that. What is the drug you are going to give? Why you are giving propanolol? You understand propanolol is a basically a beta 1 blocker, right? So this is why we are giving what? Propanolol. You understand? If you mug up things, this one will not retain with you for longer times. But if you see the concept two, three times, you do two times revision, you are not going to forget everything. And this is how you are going to remember the things also, right? This is the right way. Okay, not just for the passing of the examination, you need to understand this also. This is activating beta 1, and beta is a part of sympathetic nervous system. You can also correlate those people who are having hyperthyroidism, they will be thin or thick. Hyperthyroidism. Thin. Why thin? Because beta 3 will be activated. Beta 3 will do what? Adipolysis. That is why these patients are going to be thin patient. On the other hand, on the contrary, those people who are having low T3, low T4, they are going to have what? Take chubby patients. You understand? Chubby patients and they are cold intolerant patients, right? So all those symptoms will be there, right? You understand this? Hypothalamus hormones. If you remember this particular graph, you are able to remember lots of important things, connections. Like we cannot cover everything, but yeah, most of the things that should be remembered by you will be here itself, right? Now we will take a break of like 10 minutes, and then we will continue with the thyroid. Okay, have a cup of tea or coffee, and please be active. I'll go with the super fastest speed after this. Okay. And please turn off the AC also. This one is getting for. Sir, is that here? Uh, hmm. Zoom like. Right, guys. So the next topic that we are going to learn is about the thyroid gland. Okay. Next thing we are going to discuss about is the thyroid gland. Whatever food you are eating, let's try to understand with the basics. What are the basics we are having? So this is going to be what? This is going to be a thyroid gland. Thyroid gland will be having what? Precursor will be what? We are having two types of cells in the thyroid gland. We can have follicular cells, we can have parafollicular cells. So this is the thyroid gland that we are having, and these are the follicular cells. These are the follicular cells. So these are the cells, they are known as follicular cells. These cells are known as follicular cells. Okay? These cells are known as follicular cells. And near the follicular cells, they are known as parafollicular cells. Nearby the follicular cells are known as parafollicular cells. Parafollicular cells. Okay. So we can have this follicular cell. Nearby follicular are known as parafollicular cell. Nearby is known as para. Thyroid gland. Nearby thyroid is going to be parathyroid gland. Okay. And this one is going to be the blood vessel. This one is going to be the blood vessel. And this is what I'm going to take out. And this is going to be what? This is known as poloid. This is known as poloid. This is a complete follicle. Okay, this is a complete follicle, right? So what can happen? Let's try to understand this. We are having these the cells. So for example, you are eating something. What you are eating? Let's say you are eating that dosa. What is going to happen with that dosa? Let's try to understand this now. Okay, dosa will be having multiple things. It will be having iodine, yes or no? Yes, it will be having salt. Salt will be having iodine, and that iodine will be after digestion coming into the circulation. This is the iodine which is traveling in the body because blood is a connective tissue. And now this iodine will be coming where? Near the thyroid gland. So this is going to be the thyroid follicle. Same sequence will be there. Look here. This is going to be the thyroid follicle. This is going to be the colloid. And here you will be having the blood vessel. Look here, everyone. This is going to be the blood vessel. This is going to be thyroid follicle. This is going to be the colloid, isn't it? Blood vessel, thyroid follicle, colloid. Same story. Here, blood vessel, thyroid follicle, and colloid. So what is going to happen? Blood vessel will be having what? Blood vessel will be having the iodine. And now this iodine is going to come inside this iodine is going to come inside a follicular cell. When this iodine is going to come inside a follicular cell, this is going to be present in the I minus form. And this I minus will be coming into the colloid now. This I minus is going to come into the colloid via which form? This is known as pendrin. And now this I minus will convert into what? It will convert into I. And loss of electron is known as first step. This is known as oxidation. This is known as what? Oxidation. First reaction is oxidation. After iodine will be converting into I minus is converting into iodine. Now what will happen? This iodine is going to bind with the thyroglobulins. Here we are having thyroglobulins, and this thyroglobulin will be making in biochemistry, where tyrosine is going to make these thyroglobulins. When this thyroglobulin is going to bind with single iodine, this is known as monoiodothyroglobulin. When this thyroglobulin is going to bind with the two molecules of iodine, this is known as diiodothyroglobulin. Now, this is the second reaction. This reaction is known as organification. Now comes the third reaction. What is the third reaction? Third reaction is going to be coupling. This mono plus di is going to make what? Right. This is going to make the T3 and di plus di is going to make what? T4. So this is how you will be having formation of T3 and T4. This T3 and T4 is formed with all these three reactions. They are happened with the help of a same enzyme, this TPO, thyroid peroxidase is the enzyme which is going to catalyze all three reactions. All these three reactions are catalyzed by thyroid peroxidase enzyme, thyroid peroxidase enzyme. Right? Now what is going to happen? You can have multiple diseases over here. You can have diseases like just tell me the diseases that you know. We will conclude. You are having okay. Let's talk about you are having first thing goiter. What is goiter? Inflammation or hypertrophy? Look here. Now you know the things. You know everything, right? Hypothalamus will be releasing what? Thyrotropin releasing hormone. This thyrotropin releasing hormone will go to anterior pituitary will release what? Now this TSH will go to thyroid will make what? And they will go to body. Now what is happening? You are having iodine deficiency. Iodine deficiency will lead to goiter, isn't it? Yes, you do not have iodine. Do you think this iodine is not there? Do you think you can make T3 or T4? No, you cannot make T3 and T4 without iodine. So what is going to happen? These hormones are going to be working. This TRH will come and it will tell anterior pituitary to release TSH. And this TSH will be coming out and this TSH will be going to which gland? Thyroid. It will tell the thyroid, please make T3 and T4. Thyroid will be like, I can't, I don't have iodine. Right? So do something about it. I don't care. This TSH will set like that. And what will this thyroid is going to do? I told you any cell you are going to stimulate, either it is going to increase in number, either it is going to increase in size. So you will be having increment in the size of thyroid, and this is what is known as hypertrophy of thyroid, and this is what is known as goiter. You understand what is goiter, right? Second problem. Second problem you are having Hashimoto thyroiditis. Hashimoto thyroiditis is a type of what? It is a most common autoimmune. It is the most common type of hypothyroidism. Most common type of hypothyroidism, where you will be having what? We will be having which antibody? Anti-TPO antibody. So if there is anti-TPO antibody, this oxidation is not going to take place. This organification is not going to take place. This all three reactions are going to take place. Yes or no? No, if three reactions are not going to take place, do you think are you able to make this T3 and T4? No, you cannot make T3 and T4 without them, right? So this is going to be the Hashimoto thyroiditis, most common thyroiditis. Prevalence data is out of every 5 female, 3 will be having this particular Hashimoto thyroiditis, right? This is going to be anti-TPO antibody, and treatment will be what? You give thyroid from outside, that is going to be T4 levothyroxine. Levothyroxine. Right? You can also have one more disease that is known as Pantrid syndrome. What is this Pantrid syndrome? Remember this? Yes, here you will be having hyperthyroidism. This particular gene is known as Pantrid. And if there is no Pantrid, do you think this iodide ion is going to come into colloid? This is follicle, this is colloid. Right? So do you think this iodide is able to come into colloid? No. If iodide is not able to come into colloid, how it is going to make T3 and T4? It is another type of hypothyroidism. You understand hypothyroidism? So hypothyroidism means what? Either this sodium, sorry, this iodine is not reaching till this particular point. It is always hypothyroidism. T3, T4 is not there. Hypothyroidism, right? What is hyperthyroidism? Hyperthyroidism will be having what? Like Graves' disease. What happens in Graves' disease? You can simply remember this T3 and T4 which is formed. This T3 and T4 which is formed, it will come back to the follicle. It will come back to the follicle. It will store in the follicle itself, right? And whenever required, this T3, T4 will break down and they will come into what? They will come into blood. This T3 and T4 will come into blood. Why this T3 and T4 is going to come into blood? Because it is a endocrine hormone, and endocrine glands are going to release their substances directly into the blood, right? So we can have a disease where you will be having Graves' disease, and here you will be having LETs, long-acting thyroid stimulating immunoglobulins or thyroid stimulating immunoglobulins antibodies, which are going to cause what? Which are going to cause hyperthyroidism in the patient. You understand this? They are going to stimulate this gland, and then this is going to release T3 and T4. That is what is going to happen over here. Okay, drugs you want to remember, drugs are already written here. You can do what? If you want to treat hyperthyroidism, this is the treatment for hyper. What you can do, you want to treat hyperthyroidism, you can block this from sodium iodide support. These are your perchlorate and thiocyanate. Thiocyanate, cabbage is also having the thiocyanate, right? That is why it is avoided in the females, right? They will be having high risk of thyroid, so we are avoiding cabbage in the female. TPO inhibitor, these are going to be your carbimazole, methimazole, and propylthiouracil group of drugs. Secretion inhibitors are going to be your sodium iodide and potassium iodide. This is going to inhibit the secretion. Peripheral conversion inhibitors are going to be your PT drugs, propanolol, PTU, prednisolone, and amiodarone. These are going to convert the, normally this T3 will be there, and this T3 will convert into T4, right? This is going to be the conversion. We are also having a gland destroyer that you can use iodine 131 isotopes, which are going to emit beta rays, and they are going to kill the gland. Okay. And lastly, symptomatic treatment. This is what we are giving propranolol. Right. For this hyperthyroidism, the treatment we are going to give is going to be the levothyroxine. If you want to remember the dose, 1 to 1.6 times of the body weight we are going to give. 1 to 1.6 times of the body weight. For example, a 50 kg female is coming, I can go till 0.75 mcg, 75 mcg, right? So I will start with the least minimum dose possible. That is going to be 0.25. Say I will start, and then I will reach till a level where everything will be sorted, right? How I can check for these things? I can check for the levels of TSH, T3, and T4, right? T3 and T4 in this case will be low, and in this case, TSH will be high. What is your diagnosis? T3, T4 will be low means what? Hypothyroidism. And if there is a hypothyroidism, what will happen to the levels of TSH? The TSH will be increasing. This is a hypothyroidism. On the other hand, if someone else is going to come to you with high T3 and high T4 and low TSH, this is going to be what? This is going to be hypothyroidism, right? This is how you can understand this. Symptoms, you can understand what kind of a case they will be giving you. They will be giving you uh, 20, like they will be asking you question. 35-year-old female patient is coming to you, and she is a chubby patient, She is having cold intolerance, she is feeling intolerance. She is feeling weak. She is having weakness. She is having hair loss. All these are symptoms of what? Hypothyroidism. Hair loss is a symptom of alopecia, is a symptom of hypothyroidism. Weakness is a symptom of hypothyroidism. She will complain, so cold intolerance will be there, and she is going to be chubby. That means she will tell you, sir, I'm just drinking water. I'm not at all eating food also. Still, I'm getting fat. What is wrong with you? I'm doing exercise, I'm doing dieting, everything. You tell her, okay, go and check your hypothyroidism, check your thyroid level, and you will be finding surprisingly this patient will be having high levels of high levels of TSH and low levels of T3, T4. You are going to shift this patient on, you will tell this patient to do some lifestyle modification first. Then you will shift this patient on least minimum dose possible of the this particular thing, right? And ultimately, you will increase the dose till the time this TSH and T3 will become normal, right? You will be understanding that. So what is the maximum? What is the dose? Dose is going to be 1.6 times of the body weight we are going to give the dose. You understand this? On the other hand, if hyper patient is going to come to you, he will be a patient who is not able to sit properly. He is always walking, talking, hearing. He will be having all the times what? Palpitation. What are the symptoms? SA node will be activated. He will be having tachycardia, palpitation, diaphoresis will be there. All these things are going to be the symptoms of hyperthyroidism, right? He will be a thin patient. He can eat whatever comes in his way, still he is not getting fat. His complaints will be he's a thin, slim patient. Right? Right? ADHD like symptoms will be there. He's not able to sit quiet because he's always having what hyperactivity will be there. Right? So this is how you can understand these two important diseases, and definitely you will be getting a question from thyroid, right? You understand how to decide the dose. I've already told you about the disease also. What are the different aspects we are having? We have discussed everything about it, right? Then we are having the next thing in the list, that is going to be your pancreas. Doubt? In hyper, we are going to have heat intolerance. Hyper, we are going to have heat intolerance. They are hyper people. They cannot sit in the heat environment. They are having heat intolerance. Okay. They are going to be slim patient. Okay. They are going to be fast. They are having symptoms of like sympathetic symptoms will be more. Okay. Now about the pancreas, we have discussed in the morning. We are having what? We are eating something outside, and now you are going to have all those symptoms, right? So let's say you are eating what? You are eating biryani. That biryani will be having digestion, and after digestion, what will happen? You will be having what? You will be having glucose. I'm talking about diabetes. Pancreas will be having three cells: alpha cells, and delta. Alpha is going to release what? Glucagon. Beta is going to release, and delta is going to release, and somatostatin is going to inhibit both of them. Gastrin also, and both of them. If you are having cancer of glucagonoma, we can give octreotide. If you have cancer of insulinoma, we can give octreotide. Octreotide is the octreotide is the somatostatin analog, right? Now we are having these cells. Now let's try to understand. You were eating what? You were eating soup in the morning. You are eating paratha or biryani, and that you know already that what is digestion. What is digestion? Biryani say you are going to make what? Glucose. Okay, you are going to make glucose. And now this glucose is going to present in the blood. Now this glucose is going to be present in the blood. Suppose this is going to be your blood vessel. Suppose this is going to be your blood vessel, and this blood vessel is having more of a glucose. This is known as what? This is known as hyper. Look here, everyone, please give your complete concentration. This is a very important topic. Definite question will be there. I can guarantee without thyroid, without diabetes, there is no paper. Right? I'll make you understand. Simple in simple language, I'll make you understand. Right? So we begin with the story. We are having eating anything. It is going to make what glucose, and this glucose is going to enter into blood. After digestion, it will come into systemic circulation. It will come into your blood vessels in the submucosa. This is going to be hyperglucose in the blood. This is known as hyper means more, glucose means less, and emia means in the blood you are having more glucose. Now this glucose is a connective tissue. No, blood is a connective tissue, and this glucose will be traveling in the body throughout your body. Right now, what is going to happen? This glucose is going to come to this one cell also. What is this cell that you are having in front of you? This particular cell is known as the particular cell that is present in front of you. This cell is known as beta cell. What is this cell? Beta cell. And beta cell will be having this blood transporter. Which blood will be there? Two. Blood two will be there. Beta, you can remember one, two. Beta is going to be B. That is going to be blood two. And after blood two entry, there will be entry of glucose. And you already know this is the cytoplasm. Glucose will convert into all these steps, right? And this is going to be the pyruvate. Here, how many ATPs they will be making? Seven ATPs will be formed. This is going to be the pyruvate. Now, this pyruvate, whenever we are having formation of this ATP, just give your understanding here. Whenever you are having ATP synthesis over here, it is going to close what? It is going to close the potassium channel, because we are having ATP sensitive potassium channel. Which channel? These are ATP sensitive potassium channel. Once we are going to close this channel, what is going to happen? This potassium is going to stay inside the cell, and this cell will undergo depolarization. Okay. Once this cell will undergo depolarization, what will happen? Sir, calcium will come inside. And you already know three function of calcium. In muscle, calcium is going to do what? Muscle contractions. In vessel, it is going to do vasoconstriction. In cell, it is going to do exocytosis. Exocytosis. Only three function of calcium. So as soon as this calcium is coming inside a cell, what will happen? This insulin will be coming out of the cell. This is known as exocytosis. And I told you this is a endocrine gland. An endocrine gland will release their substances directly into the blood, right? So this insulin will be going where now? This insulin is going to come where? Here. Now you are having two things in the blood. Are you connecting my story? Now you are having two things in my blood. You are eating biryani. You are having hyperglycemia. Because of that hyperglycemia, this glucose enter into beta cells because it is a facilitated diffusion. It enters into beta cell and it will be making what? Some ATPs. And because of those ATPs, here potassium channel will be closed, and potassium channel closed means potassium is accumulated inside, and whenever a positive charge is present in the cell is known as depolarized cells, or you simply remember because of positive charge accumulation, you will be having entry of calcium. Once the calcium will enter inside, it is going to activate your insulin, and this insulin is going to come out. And this insulin is going to come out where? Into the blood. Now you are having hyperglycemia, still you are having hyperglycemia, still you are having insulin in the blood. Right now, what is going to happen? Now, this complete blood is a connective tissue. It will be traveling all around the body. Let me make one cell. This is with cell. This is with cell. This cell is the cell is where do we have blood for? This blood for will be present in the skeletal muscle. It will be present in the skeletal muscle. It will be present in the cardiac muscles. It will be present in the adipocyte, right? So what is going to happen? This glucose will be there. And now this is the key. I told you this is what? This is the key. This is what? Insulin, right? And I told you when I teach you about the GLUT4, they are going to be insulin dependent, right? So what is going to happen? Now this glucose molecules which are extra in the blood, which are extra glucose molecule in the blood. Now this key will come. This key will come, and this key is what? This key is insulin. And now what it will do? It will it will pick up those glucose molecules and it will transfer those glucose molecules into the cell. You understand? It will transfer those glucose molecules into the cell, and this is known as. And now what will happen in the blood vessel? In the blood vessel, what is going to happen to glucose? All the glucose will be going inside the cell. So blood vessel will be having what? Normal glycemia. Normoglycemia will be there. This is a normal physiology, right? What this key will be doing? This key will be opening the locks for GLUT4. Now skeletal muscle. You are eating biryani. You are doing exercise. What will happen? This glucose will be utilized as a form of energy. Is that okay? Second thing, cardiac muscle uses for energy what? What is the source of energy for cardiac muscle? Fatty acids. Fat. Remember, yes or no? And what is fatty acid? Fatty acid क्या होता है? What is fatty acid? Long chain of triglyceride is fatty acid. So it will be using fatty acid. That means biryani is using for the heart energy, right? And when this long chain of fatty acid is utilized by this one, but you are eating too much of biryani because biryani, maybe you are getting lots of biryani. So what is going to happen? Whatever extra you are eating, this one is utilized. You do energy exercise, utilize. This one will be used also, right? Heart may used will be. Which one is left extra is going to convert into what? Adipocytes. It will be stored in the long chain of triglyceride. When this long chain of triglyceride is binding with the alcohol, not that alcohol that you are drinking, the body will also have its own alcohol, right? OH group. So that is going to be that alcohol will also convert into here only, right? So everything is going to mix up, and this thing is going to store in the first it will go to the liver. That it will be stored in the form of what? Adipocytes. Adipocytes and adipocytes are what? Fat cells, you will be having the fat cells. You understand extra biryani is going to do what? Extra biryani or extra food, whatever you are eating is going to do what? It is going to do, it is going to store in the form of adipocytes. You know two things. One thing, extra oil is going to do what? Atherosclerosis. Extra food is going to make you more chubby, right? You understand this particular thing? Now, normoglycemia is something that we really want, right? What is the test you know about glucose that you know? What are the tests we are doing for glucose identification? What is this HbA1c? Hemoglobin is there. Hemoglobin has a, or RBC has a half life of how many days? 120 days will be normal lifespan of RBC. Remember, when this RBC is having hemoglobin, when this RBC are having what? Hemoglobin, sorry, RBCs are having hemoglobin. When this RBC is going to have what? Or you could simply say when this hemoglobin is having what? Glucose. This is known as glycated hemoglobin. This is known as glycosylated or glycated hemoglobin. And this particular thing is going to decrease the life of the RBC by 30 days. So it will be living for how many days now? 90 days. So this is the HbA1c testing that we are doing. It is going to tell us about the previous 90 days average sugar. HbA1c is going to tell us about what? Like your body will be having 100% of sugar. If your body will be having 5.4% of cells of your RBC are glycated, that means it is a normal thing. You understand like that? You are having 100% of hemoglobin. If 5.4% of your cells are glycated, this is a normal thing. This is normal, right? 5 point, what is the value? What is the value of pre-diabetic, diabetic, and post like pre-diabetic, normal, and diabetic? Less than 5.4 is going to be less than 5.4 is going to be normal. This patient six 5.4 to 6.5 is going to be pre-diabetic. This is going to be pre-diabetic. Okay. And 6.5 and above, this is going to be what? This is going to be diabetic. That means this is the normal value. Some people are coming to you with the amount of 10, with the amount of HbA1c 10. That means their body is having what? 10% of glycation. That means they are having average sugar of somewhere around 300, right? You can multiply it by 30. You can identify it will be like 21 to 30. You can take a value and it will be around like 200 to 300 sugar will be there, right? Average for the last 3 months. So this is what we are doing the HbA1c testing, right? You understand what is HbA1c? It is the glycated hemoglobin, right? Now two types of diabetes you always discuss. One is going to be type 1 and type 2. Type 1, can I make a eye? Can I make a eye of type 1? So this diabetes will be having insulin problem, right? Insulin dependent diabetes. Here we do not have, key will be absent. If there is no key, do you think are you guys able to open this lock? If there is no key, no opening of the lock. Okay. In type 2, you can make a R. Can I make it as R? Yes. Here you will be having the key. Yes or no? Key will be present, but lock is jammed. If lock is jammed, what is the lock? Glut4, right? What you can do, you can give drugs like metformin to this particular patient, and this metformin is going to do the insulin resistance. It is going to help you, right? All the drugs, you can give all the drugs, right? 9 classes of drugs, all the drugs will be working here. And the ultimate function of all the drugs is to do what? Decrease glucose in the blood. Ultimate function of any drug that you are using is going to be what? I can explain you. We do not have time, but right, I can give you a video if you want to learn, right? So what is going to be thing? We just want to decrease the glucose here, right? We just want to decrease the glucose over here, and all the drugs, sulfonylureas, your glimepiride, gliclazide, okay, gliptin, all your liraglutide, semaglutide, all the drugs are going to do what? They are going to decrease glucose in the blood. Major issue is what? Hyperglycemia. Why? Sir, this glucose is also a single molecule. It will go where? It will go to your eyes, it will cause retinopathy. It will go to your nerves, it will cause neuropathy. It will go wherever it can go, it can cause micro and macrovascular complications. Right? So that is why it is important to identify and to treat. Right? Your sulfonylureas will be working where? Pride group of drugs are going to work here. They are going to directly block this particular thing. If they directly block this particular thing, you will be having what? Increase in potassium. Increased potassium lead to increase in calcium. Increased calcium, increase insulin. You will be having insulin outside. Right? All these drugs will be working here itself. You understand this? Anything you want to ask here? Next thing we are having is adrenal gland. Adrenal gland will be having what? Cortex will be there. Medulla will be there. Adrenal gland is a suprarenal gland. It will be having two parts. Cortex will be having G, F, and R. G, F, and R. G for glomerulosa, F for fasciculata, and R for reticularis. You can remember sweet, salt, and sex. First will be salt. First will be salt, then sweet, and then sex, right? So here you will be having aldosterone. The complete story of aldosterone you already know. It is going to make which channel? Epithelial sodium channel. And this is going to do what? This is going to retain water and sodium, right? Second is going to be cortisols, and this cortisol will be having anti-inflammatory action. It is going to have all the anti-inflammatory action. Sex steroids are going to be your dihydroepiandrostenediones. They are going to be the primary androgens which are going to convert into certain hormones further. What about medulla? Medulla is going to have a catecholamines. Medulla is going to catecholamines. What are the catecholamines that you know? Epinephrine, norepinephrine, dopamine. If you are having a tumor of this adrenal medulla, this is known as what? Adrenal medulla tumor. PO, homocytoma. Symptom you will be telling me. It is going to make what? Epinephrine, norepinephrine, dopamine. You will be having what symptoms? Sympathetic symptoms. Patient will be having palpitation. Patient will be having diaphoresis. Patient will be having hypertension. Okay. Anxiety like symptoms. So all those symptoms will be there. Okay. This is what is going to be pheochromocytoma. Drugs you have to remember intraoperative what you give, post-operative before operative, pre-operative, and intraoperative what you are going to give. Phenoxybenzamine you can give, phentolamine you can give. Okay. Next we are having is reproductive system. Female reproductive system, your offspring is strong. I hear this, right? So you will be studying female reproductive system over here. Over there, male reproductive system, I'm going to teach you, right? So what is this male reproductive system? What are the important things we are having in the male reproductive system? Let's try to understand. Here, how this male is going to form, just remember we are having a sperm, we are having a ovum, they are meeting where on the ampulla. On the ampulla, after meeting or at the ampulla, they will go to form zygote, and then two cell stage, four cell stage, they will be having implantation. Right after implantation, this is going to get bigger. 1 month, 1 week, 2 week, 3 week, 4 week, 5 week, 6 weeks. Can you identify the sex of a person? When you can identify the sex of a person? Six, 6 weeks will be there. 6 weeks. Till 6 weeks, you cannot identify. Till 6 weeks, at least till 6 weeks, no one can identify. No one can identify till 6 weeks, because till 6 weeks we have the bipotential. Bipotential means this person can become a male person, this person can also become a female person. It is non-specific till 6 weeks. Is it a male? Is it a female? That is the wrong thing. Till 1.5 months, you are not going to identify this is a male, this is a female, or what. right? So bipotential will be till what time? 6 weeks. Bipotential will be there. After 6 weeks, there will be a region. If there is SRY region is going to be present, this is going to be a male person. Why? Always remember Y chromosome is suggestive of a male person. If you see Y chromosome, definitely a male person, irrespective of the what you are seeing from outside. Maybe this patient is having vagina, right? But still, if you are having the Y chromosome, this particular patient is going to be what? Male person, male patient. Like we are having Klinefelter syndrome, right? Klinefelter syndrome is going to be what? XXY. So this is going to be a female or a male? Male person, right? 45X. Oh, that is going to be with Turner. This is going to be a female. You understand this? Y chromosome, you see Y chromosome, this is going to be a male, right? You studied about all this Mullerian agenesis, MRK syndrome. You know how these things are happening. What is the basics behind this? Right, that's great. Okay. Wonderful. Right? So we are having this genital ridge. This genital ridge is going to make what? Now just try to understand what is the chronology. Till 6 weeks, there will be bipotential. On sixth week, if we are having SRY region, listen to my story. Till sixth week, if we are having SRY region, what is going to happen? This SRY region is going to be present. Automatically, this genital ridge, in embryology, you will be studying about genital ridge. This genital ridge will convert into testes. And testes will be having how many cells? Leydig cells will be there and Sertoli cells will be there. So if there is formation of testes, there will be formation of these two cells. That is going to be Sertoli cells. That is going to be Leydig cells. Remember this Leydig cells and what is going to be the germ cells? Germ cells are going to be spermatogoniae. Okay, gonads are going to be different. Germ cells are going to be different, right? So what is going to happen? This Leydig cells and Sertoli cells will be there. Leydig cells, if it is there, it will be making what? Under the influence of LH. This LH is coming from where? Anterior pituitary, above anterior pituitary, was hypothalamus is releasing what? That are going to now anterior pituitary will be releasing LH and FSH. This LH is going to come to where? Testes. In testes, more specifically where? Leydig cells. And this Leydig cells will be making what? Testosterone. That is what we have seen, right? So this is the testosterone which is going to be formed here. What is the function of this testosterone? It is going to make which duct? These ducts also you have studied, Mullerian duct, Wolffian duct. So this is known as Wolffian duct. Wolf are like the male are like the wolves. Okay, so Wolffian duct will be a duct which is going to be present where in the male, right? This Wolffian duct, also known as mesonephric duct, is going to be there, and this is going to generate what? Internal genitalia of a person. Six weeks, this baby was there, no identification, male or female. After 6 weeks, till seventh week, he will be having what? Let's say he is having what? Let's say he is having SRY region, and this SRY region is present means now genital ridge will convert into testes, and now this testes will convert into this testes will be having two cells, Sertoli and Leydig. This Leydig cells will be making what? Testosterone, and testosterone will make what? Wolffian duct, and Wolffian duct will make what? Internal genitalia. What is the internal genitalia of a male? Seed. What is the internal genitalia? Seed. What is seed? S for seminal vesicle, E for ejaculatory duct, E for epididymis, and D for vas deferens. This is going to be the internal genitalia of a person. Right? When this internal genitalia is formed, now the baby will be 3, 4, 5, 6, 7, 8, 9 months. Right? When 9 months will complete, this baby will come out. Right? And internal genitalia, after formation of this internal genitalia, you know what happens? This testosterone will convert into dihydrotestosterone. This testosterone will convert into DHT. And this DHT is conversion is happening because of 5 alpha reductase. And now this dihydrotestosterone is going to make what? This is going to activate your androgen receptor, and now you will be having increase in the growth of the secondary sexual characteristics will be there. It will be making what? Prostate. It will be making the growth of the penis. Now this baby will be coming out, and this baby will be having those hormones, and those hormones will be more activated around the time of puberty also. Right? What is the drug which is going to be androgen receptor blocker? Flutamide. Flutamide and nilutamide that you can use, right? Finasteride is going to be 5-alpha reductase inhibitor, right? This is the basic understanding, right? This is the formation of a male. Second thing we are having is about the Sertoli cell. This Sertoli cells will make a hormone. This hormone is known as Mullerian inhibiting hormone or anti-Mullerian hormone. This hormone is going to do what? This is going to inhibit the Mullerian duct. Mullerian duct is going to make which cell? What organs? Female genital organs. Internal or external? Internal. Obviously, internal, external genital organs. Let me give you one statement that should be with you throughout your life. Every individual is destined to become a female. Everyone is destined to become a female. That means we are by default, if we do not have this anti-Mullerian hormone, we do not have this Wolffian duct, what will happen automatically? Our genitalia from outside will be looking like a female. Maybe from inside we are male. Our genitalia will automatically look like female. This is the genitalia. Are you understanding why we are having those eunuchs on all those things? Right? What is the thing we are having? Wolffian duct is going to make male internal genitalia. Mullerian duct is going to make female internal genitalia. What are the things in female internal genitalia? Fallopian duct, cervix, upper part of the vagina, and uterus. And uterus, right? Four things will be there. Fallopian duct will be there, cervix will be there, and ovaries. Yes or no? Yes or no? Tell me yes or no. This is where the basics come. Ovary is a genital organ, yes or no? Ovary is a gonad. Testes is a gonad. Ovaries is a gonad, yes or no? Ovaries are coming where? From the genital ridge, 6 to 7 weeks. What are the genital organs we are having? Genital organs, internal genitalia is formed from where? From which cells? No, not Sertoli cells. In female, what are the two cells we are having? Females, we are having two cells. Males, we are having two cells. Males, we are having Sertoli and Leydig cells. Female, we are having granulosa cells and theca cells. Females will be having two cells, granulosa and theca cells. Males will be having Sertoli cells, Leydig cells. You understand this Leydig cells? Yes, Sertoli cells in males it is producing what anti-Mullerian hormone. In females it is not going to produce anti-Mullerian hormone. Other in females if there is anti-Mullerian hormone and ovaries are there, what will happen? Which syndrome? Anti-Mullerian hormone or Mullerian inhibiting hormone. What will not be there in the female? Think about it. Let me be a little bit slow. I'm talking about a female and she is having anti-Mullerian hormone. And this anti-Mullerian hormone is going to do what? Inhibition of Mullerian duct. So what will happen? Mullerian duct agenesis. Yes, Mullerian duct agenesis is also known as which syndrome? MRKH. M not just uterus, everything will be not there. Cervix will not be there. If there is anti-Mullerian hormone, that means there will be no Mullerian duct. Mullerian duct is going to make female internal genitalia. Female internal genitalia will be having four things. First, upper part of vagina. Second, cervix will be there. Third, uterus will be there. And fourth, fallopian tubes will be there. So all four things are going to be absent. There will be no fallopian tubes. There will be no uterus. There will be no cervix. There will be no upper part of vagina. But lower part of vagina is going to be there. And from externally, when you see this female will be having vagina, yes or no? Yes, from outside, but this is going to be a blunted vagina, right? This is going to be a vagina which is not completely developed. She will be growing. MRKH female, she will be growing 10, 11, 12, 13, 14 years. She will be having everything fine, fit and fine from outside. Everything is looking great, right? But when she get married and she will try to get pregnant, is there any possibility she will be getting pregnant? Why? She can have she can have babies, yes or no? Why she cannot have babies? She can have how? She is having the ovary, yes or no? Surrogacy. That is why the surrogacy came into play, right? I just want to check your concept. I just want to know where you are standing, right? So surrogacy can be there because ovaries are over there, right? If ovaries are over there, that means what? Ovaries are there means every month ovulation will be there, but she is not having periods because there is no uterus, right? She can have babies, but these babies are going to be surrogate babies, right? That is why we are having IVF clinic and all, right? You understand? Very good. It will go to pouch of Douglas. That particular thing, this ovulation will be there. She will be having those basal body temperature. Everything will be fine. Normally, 14 days ovulation will be there. She will not have those particular changes normally in the body, but yes, inside the ovaries are functional, right? Another syndrome we are having where we are going to have problem with the you are telling me testicular feminizing syndrome. That means patient is having what? Patient is having. Yes, this patient is going to have problem with the testosterone receptor. If testosterone receptor are problematic, just try to understand. 6 weeks, sperm will be there, ovum will be there, zygote will be there, and it is implanted, right? First week, second, third, fourth, fifth, sixth week, there is going to be SRY region is going to be present. Wonderful. This is going to become a male. He will be having formation of testes. Very nice, right? Testes will be there. He will be having Leydig cells. He will be having Sertoli cells. Wonderful, right? Sertoli cells are going to do what? Mullerian inhibiting hormone will be there. Anti-Mullerian hormone will be there. Mullerian duct will not be there. Wonderful, right? Complete. You understand this? This is a male patient or a female patient. He is having Y chromosome. This is a male or female? Male patient. What is going to happen about Leydig cells? Leydig cells are there, sir. Testosterone is also there. But the receptors of testosterone are not working. If receptors are not working, do you think internal genitalia of a male? No, no Wolffian duct, no seminal vesicle, no ejaculatory duct, no epididymis, no vas deferens. If no vas deferens, no ejaculatory duct, nothing will be there. What is going to be happening in this patient? Try to understand this is a patient who is having what? Testes. Who is having testes? Who is having what? Anti-Mullerian hormone. What is the external genitalia? Automatically by default. Is it good? Try to understand my words. This internal genitalia will be there. Then this internal genitalia will make this testosterone will convert into dihydrotestosterone, and this is going to responsible for the external genitalia. So where we are having external genitalia, because of this dihydrotestosterone, but here we are having defect in the androgen receptor, right? So this is going to be a person who is going to have what? Who is going to have testes inside, but the external genitalia will look like what? Female. Why? Because everyone is destined to become female, and everyone is having the automatically development of external genitalia like female. You understand this particular thing? He is a this particular person. I'm going to call him as he or she. This person will be having normal breast development. This person will be having vagina. This person will be having everything normal. She's looking like a girl. Why? Because androgen receptors are defective. She will, like, he will be looking like a girl, basically, right? And when you are going to do karyotyping or do ultrasound scan, you will find that testes are going to be there in the inguinal canal, right? Testes are not descended. Where should testes will come if there is no scrotum, right? So testes are non-descendant. He will be having the testes, and when you identify this patient is going to come to you, and he will be telling you, I'm not able to have periods. I'm 15, 16, 17 years old. I'm not having periods, no menses. Okay, my vagina is also blunted, right? What you are going to understand? You are going to understand. Okay, let's do a ultrasound scan. You do ultrasound. Oh, you have the testes. You have the testes. You are not she. You are he. Right? You remove those testes. Why to remove those testes? Testes is a differentiative organ, right? It will have mitosis, and this mitosis can convert into cancer also. You check for the cancer. If it is non-cancerous, you remove the testes. You do some reconstruction surgery. You will try to make her female. Does she? This female is going to have babies throughout her life. She is not even a female. She is a male, right? She is looking like a female. She is having characteristic of a female. The reason is simple. We are having androgen receptor defectivity is there. You understand testicular feminizing syndrome, right? Come back to the male system, right? We are having this particular thing. If till 6 weeks, listen to me, if till 6 weeks we do not have testes, what is going to happen? Automatically this patient will be having, if till 6 weeks there is no SRY region, 7th to 8th weeks automatically there will be production of ovary. This genital ridge will convert into ovary. Now there will be ovary production. If there is no No. If there is ovary production, there will be Leydig cells, yes or no? No. No Leydig cells means there will be Wolffian duct, yes or no? No. If there is no Wolffian duct, there is no Leydig cell, there will be Sertoli cell, yes or no? No. If there is no Sertoli cells, what will happen? There will be no anti-Mullerian hormone. There will be automatically Mullerian duct will make its functions. It will make what? It will make whatever structures, fallopian tube and all those structures. And now you will be having the female. Now you will be having the female child automatically. She will be there. You understand this? What is puberty? Like, tell me one thing. We are having this GnRH since the beginning of the life, right? But why we are having the symptoms of puberty at the age of around 13, 14, 15, 16, and why some people are having it early and some people are having it late? Can anyone give me reason for that particular fact? Hmm? Is this thing can also happen, but normal understanding is what? Normally, I'm asking. I'm not asking about the disease why patient is having delayed puberty. Listen to me. How now I will make you understand how this puberty is going to come. This thing will add on to your concept. Okay. So what is going to happen? You must have seen those people like nowadays. Girls are coming or boys are coming. They are chubby. Those people who are chubby, they are having early puberty. Like for me, like I can see tell you with the experience, people are coming to us, right in the hospital, in pediatric department, people are coming. 8-year-old girl or 7-year-old girl, she's coming to us, and mother will be very very anxious about her, and she will say that my baby is having this girl is having this, she's just 7-year-old and she's having what, she's having menses. I look at the baby, baby's chubby baby. She is eating all the junk food. Mother will always think like that. They are very thin and slim. Their babies they cannot find like healthy, right? So mother is thinking like that, and she is giving food, and she will be like, why she is having all those things? Right? Sedentary lifestyle is there. So why this? I'm talking about why this fat is the important concept over here. So just try to understand one more concept. Let me give you. You have studied about this continuous and pulsatile release of GnRH, so continuously if I teach you for like or continuously your father is telling you to study, are you going to study? Every time he see you and he will tell you to son, you have to study. No. If your father is calling you on a constant interval, like he will call you someday, he will sit along with you and he will be like, you should study, this is the high time. It's been 5 years, I've not said you anything, right? It's been 5, 7, 8 years, right? Now it is the time. Please do it for me. And you will be sitting the whole night. You will be thinking like that, that um, something is fishy, right? There is something he's not telling me. He's worried or something like that, right? So you will do what? Here you will be having a positive feedback. Here you will be having positive response. Whereas if they will always see you, why don't you study? You will never study. Trust me on this. If someone will always mock you, you are never going to study, right? When an egg is ruptured from inside, you will be having a life. You understand, right? So that is life we are waiting for, right? How many hammers I'm going to put, it is going to make the omelette only, right? So please try to become that chicken, right? Rupture from inside, right? So we are having this continuous and pulsatile release. So what is going to happen whenever you are having before puberty? Listen to my words now. Before puberty, pulsatile release of GnRH is inhibited by GABA. If pulsatile release is inhibited, that means continuous release should be there, right? And if there is continuous release, what is going to happen? There will be positive action or negative action. Negative action. There will be no puberty because pulsatile release is inhibited by GABA. GABA is inhibitory neurotransmitter. Now, around the puberty, one hormone will come. This hormone is known as kiss peptide. This will come around the puberty, and now what is going to happen? This kiss peptide is going to inhibit what? GABA. This kiss peptide is going to release the inhibit of GABA, and now you will be having activation of this pulsatile release, and pulsatile release will lead to what? Puberty, right? And this kiss peptide is going to be under the control of one more thing. This is going to be the previous year question. This is your leptin. Leptin is going to play a permissive role. This was the exact statement that was written. Leptin is going to play a permissive role, and leptin will tell us about what? Adequate fat storage. Now I'm telling you the same thing in simple words. What is the simple words? When you have the adequate fat storage, When you will how your body will get to know it's time for puberty? When you have the adequate fat storage. This is the time this leptin will come out, and now this leptin is going to do what? It is going to activate your kiss peptin. Now this will say that okay, this boy is ready, this girl is ready. So now this kiss peptin will be coming out, and this kiss peptin is going to inhibit what? GABA. And inhibition of GABA will lead to pulsatile release of GnRH, and pulsatile release of GnRH is going to lead to what? Puberty. You understand how this particular thing is happening. Now, why this mother is coming to me? Her baby is very fat. Her baby is very fat at the age of 7. And she is going to have what? More leptin at the age of 7. And this leptin is going to activate your kiss peptin. And this kiss peptin is going to inhibit the GABA. And this is going to do what? Pulsatile release will be activated. And she will be having early puberty, also known as precocious puberty. Right? Also known as precocious puberty, right? So this is going to be the problem over here, right? These are the drugs that you can use. Continuous release is going to decrease gonadotropin. It is going to decrease LHFSH, right? Uses, what are the uses when you want to do, when you are having precocious puberty, like this female is coming to us, right? I can give what? I can give continuous release to this particular patient, and she will be having stoppage of puberty for now. She will have the symptoms when I'm going to stop the drugs, right? Second thing, you are having fibroids or cancer. In this case, also, I just want to decrease my levels of estrogen and progesterone. So we can also give what? We can also give continuous drugs, right? Continuous, if I'm going to give, remember it is going to decrease LHFSH. LHFSH decrease means decrease in testosterone, estrogen, and progesterone. You understand this? Okay. Pulsatile release means what? When you are going to give pulsatile release, it will increase gonadotropin, it will increase LHFSH. So when we can use, if someone is coming to you, she is not having a fat. A boy is coming to you or a girl is coming to you and she is not going to have a fat, right? Now what we can do, if she is not having the fat, she is not going to have the puberty also. Pubertal changes are going to get delayed. She's 14-year-old slim girl and she's not even having puberty right now, right? So what you are going to do? You are going to give what? You are going to give pulsatile injections of GnRH, and that is what is going to help this patient. Someone is having infertility, we can also use that. And hypogonadism, size of the gonads are going to be small, we can also use this, right? These are the drugs. These are all drugs are going to be ending with the renin, and these are all drugs are going to be ending with the X. GnRH antagonist is going to be X, agonist is going to be relin, and one more you have to remember, that is going to be liprolide. Relin means boserelin, okay, rolidin, right? All these drugs are going to have what? Relin. Is it okay? Now comes the respiratory system. You understand what is respiratory system? In respiratory system, we are having total multiple models we are having, but the most accepted one that we are accepting, this is going to be the Weebles airway model. Which model? Weebles airway model. First 16 generation are going to be considered as conducting airways. 17 to 23 generation are known as exchange or acinar airways, where exchange will be happening. Okay, we can have terminal bronchiole on which generation? 16th generation. And alveoli, remember, they do not have a smooth muscle. If they have smooth muscle, they will get contracted, right? So first to 16th generation means what? Trachea. Do you have gas exchange? No. In trachea, do you have gas exchange? This is how they are dividing: trachea, then bronchi, then bronchiole. So first to 16 division, there will be no air, no gas exchange. This is known as conducting airway. 17 to 23, there will be exchange. This is known as acinar airway. Is that okay? Now the most important question they are asking is about the V by Q ratio. V is going to be ventilation and Q is going to be perfusion. What is perfusion? Perfusion means blood flow. Okay. So how much is the ventilation in the lungs? This is going to be 4.2 liter. How much is the perfusion? That means how much blood is coming from the heart in a minute. That is what is perfusion. So how much blood is coming from the heart in a minute? This is going to be 5 liter, right? So this is going to be the ratio. V by Q ratio is coming out to be 0.8. This is suppose your lungs. It will be divided into three parts. It will be divided into three parts. This is going to be the apex. This is going to be the mid part, and here you will be having the base. In the apex, do you have more oxygenation? Yes or no? We are taking shallow breathing. Right now, we are taking shallow breathing. So, do we have more oxygenation in the apex? Yes, that is why aerobic infection, aerobic bacteria infections like TB. Why TB is happening in the lungs? We have more oxygenation. Why Pseudomonas, ventilator associated pneumonia? This is also because we are having more oxygenation, no cardia, aerobic bacteria, all aerobic. Why to study aerobic anaerobic? Why to study aerobic anaerobic? Aerobic means superficial infections, skin infections, lung infection. Anaerobic means deep infections like gas gangrene, clostridium, okay, tetanus, clostridium. These are going to be fusobacterium, bacteroids, right? Actinobacter, right? So these are going to be the classification, right? So this is going to be what? Apex, mid, base, right? What is going to be the ratio? If you don't want to remember this, just remember V by Q ratio will be more at the apex. That is going to be 3.2. V by Q ratio will be more at the apex. V by Q ratio will be low at the base. Just a minute. Okay, V by Q ratio will be more at the base. If ventilation is more, perfusion is less. This is going to be what? More in the apex. If ventilation is low and perfusion is more, this is going to be ratio will be coming less. Right? The question they are asking is very, very simple. If you don't understand, just remember this thing. V by Q ratio will be zero when ventilation is going to be zero. So simple understanding when zero is divided by any number. When zero is divided by any number, what you will be getting? Zero. Second question they are asking V by Q ratio will be infinite when? Okay. So here you will be having any number that means 5, 10, 15 divided by 0. This is going to be what? Infinity. So just make it 0. You will be understanding. So when you will be having V by Q ratio will be 0, that means ventilation is 0. If ventilation is 0, that means suppose you are having foreign body obstruction. You are having foreign body obstruction. What is going to happen? Do you have oxygenation now? No, if there is no oxygenation, V by Q ratio will be coming out to be 0. So you can have it in the shunted blood, you can have it in the emphysema, you can have it in the foreign body obstruction, right? V by Q ratio will be infinite when, what is pulmonary embolism? So you are having the oxygen, but now suppose this is the pulmonary vessel and here you will be having the emboli. So there will be blood flow, yes or no? No blood flow. If there is no blood flow, that means perfusion is going to be what? Zero. If there is perfusion is going to be zero, this is going to be what? The ratio will be zero. The ratio will be uh, infinite. Ratio will be infinite. Okay, perfusion will be zero, ratio will be infinite. Right? So this is what they are asking because they know you don't know maths. Right? So they don't know, they know what will happen when you divide zero with any number, right? That is why they are asking this question. Now comes the neural regulation of this respiratory system. How this respiratory system is regulated by the nervous system, right? So can you appreciate these are the same things we are having? This is going to be the pons. This is going to be the medulla we are having. So in pons and medulla, we are having respiratory center. I'm going to make you understand how you are going to breathe and what are the centers which are responsible for your control of breathing. So how you are going to breathe, look here. What are the centers which are going to be responsible for the breathing? So we are having the pons and medulla. We are having pons. Pons will be having how many receptors? What are the centers which are present in the pons? Okay. What are the centers which are going to be present in the pons? Pneumotaxic and apneusic centers. She's answering from the back. See the dedication. By crooks or hooks. By crooks or hooks, you should pass. Right? You should pass. That is If she will pass, she is just around the, like, this is just a corner, right? She will be getting this time. She will be getting maximum marks, and she will pass with the flying colors, right? Believe in yourself. You have to answer all of them. More than 200. Okay. So we are having pneumotaxic center. We are having apneustic center. Pneumotaxic center, apneustic center. We are having this pre-Borzinger complex. What is this pre-Borzinger complex, Vita? This is going to be the this is going to be the thing which is known as pacemaker. This is the pacemaker, and this is going to control what? Respiratory rate. This is the pacemaker of respiratory system. Pacemaker of GIT is interstitial cells of Carl. Pacemaker of cardiac, that is going to S node, and here pacemaker is going to be pre-Borzinger complex. We are having two groups. One is going to be dorsal respiratory group. One is going to be ventral respiratory group. This one is on the back side. Back side is going to be what? Dorsal. This one is on the front side. This is going to be ventral. So we are having dorsal respiratory group. We are having ventral respiratory group. Is that okay? Till now it's fine. Okay. So what is going to be the functioning of all these things? You can simply remember dive. You can simply remember the mnemonic dive. Okay, let me make you understand. Pneumotaxic center is going to limit the inspiration. You heard about some poisons, snake poisons are pneumotoxic, right? That means they are going to live. They are going to inhibit the. They are going to limit the inspiration. Whereas this apneustic center is going to prolong the inspiration. It is going to prolong the inspiration. Okay, DRG is going to responsible for the inspiration, smooth rise in tidal volume during inspiration. This is going to be DRG. Whereas this VRG is going to be responsible for the control forceful expiration. Okay, so DRG is responsible for the dive spot. DRG is responsible for the inspiration, and VRG is responsible for the expiration. You understand this? If you see this picture now, you just hear this and you will understand this. Just give me 2 minutes and you will understand this. Okay. Look here. Normally, how you are inspiring. Give your concentration and you will understand. Okay. You will think somewhere else. You will not understand. Simple understanding. Okay. So we are having this pneumotaxic center. We are having this apneustic center. Apneustic center means apnea is happening. If apnea is happening, you want to inspire? Yes or no? Apnea means absence of oxygen. You want to inspire, yes or no? Yes. So this apneustic center activation will lead to what? This is your DRG. This is your VRG front side. This is going to be your DRG. So it is going to activate your DRG. And now this DRG is going to go where? To your lungs. And it will do what? It will do two things. It will work on two things. What are the two things? First thing, it is going to work on the diaphragm. Second thing, it is going to work on the external intercostal muscle. These things are based on a law. The law is Boyle's law, right? What Boyle's law will say, whenever you have increase in pressure, you will be having decrease in volume. Whenever you have increase in volume, pressure will be decrease, right? It is inversely proportional. Pressure is inversely proportional to volume. So let's try to understand this particular thing. So we are having what? We are having apnea, and we want to do what? Inspiration. We want to do what? Inspiration. So before inspiration, which center is going to be responsible for inspiration? Inspiration, which center is responsible? DRG or BRG? DRG is responsible. Now let's understand DRG will do what? It will activate your two muscles in the body. One is going to be your diaphragm. So your diaphragm is going to get below. If your diaphragm is going to get below, do you think volume will come inside? If volume will come inside, what will happen to the pressure? Volume will be increasing, pressure will be decreasing. Second thing, this diaphragm will go down. This is responsible for 75% of breathing. That is why sometimes you have diaphragmatic muscle paralysis, patient will die. Right? You will be having problem. Second thing, we are having external intercostal muscle. These are the muscle which are going to be present here. So they are going to dive, they are going to do what? They are going to do, they are going to go externally away, right? And this is going to increase volume or decrease volume? And if it will be going away, that means volume will be coming inside. This I'm talking about the lungs. If it is going below, it is going away. That means volume will be increasing and pressure will be decreasing. This is the first thing. 25% of inspiration is happening because of external intercostal muscles. 75 percent of inspiration is happening because of diaphragm. Now, inspiration is done. Now, what is going to happen? This V is going to come. Dive. I told you dive. Now, VRG is responsible for what? Expiration, limit aspiration, right? So this now pneumotaxic is going to get activated. You will be having the activation of this VRG. And VRG is responsible for what? Expiration. So it is going to activate two muscles. One is going to be your accessory respiratory muscles. Second one is going to be internal intercostal muscles. And now what is going to happen? This internal intercostal muscles are going to compress inside. If compressing inside, that means pressure is going to increase or decrease. Pressure is going to increase. What will happen to the volume? Volume decrease. So what is going to happen when you are going to compress your lungs from outside? These external intercostal muscles, they are going to compress inside. You will be having increase in the pressure, decrease in the volume. Volume will go away. You will be having what? Expiration. You understand? This particular muscle is responsible for expiration. So how this inspiration and expiration is happening is based on these five things. Five centers. That's who is the pacemaker? First question. Who is the pacemaker? Everyone. Pre-port singer complex. Who is going to be responsible for inspiration? TRG. Who is going to be responsible for expiration? What is the maximum? Which is the muscle which is going to contribute maximum during inspiration? Diaphragm. Which is the muscle which is going to compress during expiration? Right? Internal intercostal muscle. Okay. Option may they will be giving you external, internal both. Right. You have to remember during compression. During compression means inward. It will be coming inward. Inward means internal intercostal muscle will be there. Right. You understand this? This is how we are expiring and inhaling the air. Right. Next important question they will be asking you is from the hemoglobin oxygen dissociation curve. Next question they are going to ask you is from hemoglobin oxygen dissociation curve. So hemoglobin and oxygen has a story. What is the function of this hemoglobin? Do you remember this? Do you understand this? Yes? Okay. Tell me what is the story of this hemoglobin and oxygen? Hemoglobin has a function to transport oxygen. RBCs are going to be having the hemoglobin, and hemoglobin oxygen dissociation curve means what? When it will be dissociated. So when it will be dissociated from hemoglobin, oxygen, when it will be dissociated from the hemoglobin, when your body will require oxygen or when your body will not require oxygen. देखो, this is a couple. This is a couple. This is a couple of hemoglobin plus oxygen. When you are going to have the breakup, when third here, when we are going to have the breakup, look here. When it's not matching, whenever there will be reduced in affinity, when love will be decreased, reduced in affinity. You can simply remember right shift of the curve will be seen whenever there is going to be reduced in affinity. Reduced in affinity. Affinity means love, right? So reduced in love, what is going to happen? Both of them are going to get apart. Hemoglobin will go. They will part their ways. Hemoglobin will go to another story. Oxygen will be going to the tissues, right? So when oxygen will go to the tissues, when tissues require oxygen, yes or no? And when tissue require oxygen, whenever there is hypoxia or hyperoxia, hypoxia. Just remember this particular thing. Everything will be sorted, right? I'll just give you a concept. So whenever you are having hypoxia, hypoxia means decrease in the oxygen. Decrease in oxygen. Can I also write it at increase in CO2? Decrease in oxygen means increase in CO2. Who is the brother of CO2? Remember from now onwards, who is the brother of CO2? H plus. Anytime you have rise in CO2, always remember there will be rise in H plus. And right, they are brothers for life, forever. Right? Anytime you have rise in CO2, you have rise in H plus, right? And H plus rise, we call it what? Acidosis, alkalosis. We call it acidosis. And whenever you have acidosis, what will happen to pH? pH will decrease, right? You know everything, right? So when you are going to have right shift of the curve, whenever there is going to be R for R reduced affinity. Reduced affinity means we will be having decrease in the affinity. This is going to be known as reduced affinity. Why this affinity is decreased? Because there is some hypoxia at the tissue level. That is why this hemoglobin oxygen dissociation will be happening more, right? This hemoglobin is giving more oxygen to the tissue. Why? Because tissue needs oxygen, right? And tissue need oxygen means what is more? CO2 is more, and CO2 ka brother is H plus. And H plus and CO2 will be more. That is known as acidosis. And here you will be having decrease in the pH. This is the right shift, and this particular effect is known as Bohr effect. This is known as Bohr effect, right? 3 point extra you have to remember. When this reduced in affinity will be there, everything will be increased. This is going to be increase in 2-3 dpg, increase in temperature. All things will be explained, right? When you heat it, when there is fever, what is going to happen? You require more oxygen. That is what is going to be increase in temperature will also be there, right? Another story. Look here, another story. You will be telling me the another story. Left shift will be when you will be having the left shift of the curve. When you will have the left shift of the curve. Now, here it was reduced in affinity. Here there will be increase in the affinity. Increase in the affinity. Increase in affinity means hemoglobin and oxygen are going to bind together very nicely. Janam Janam ke saathi, right? So they are going to become partners for life, right? So what is going to happen? When they are going to bind together, when hemoglobin is not going to deliver the oxygen, when already there is oxygen, when already there is oxygen, that means already there is hyperoxia. Hyperoxia means what? Decrease in CO2. Decrease in CO2 means, and decrease H plus is considered as alkalosis. And what will happen to pH in alkalosis? Increase in the pH, right? So these are the situation when you will be having what? Left shift of the curve. Left shift of the curve. And this particular effect is known as Haldane's effect. Here L will be bigger. You can remember here L. And here you can remember R. When do you see right Bohr's effect? When do you see Haldane's effect? Now the next thing is about the hypoxia. How many types of hypoxia we are having? We are having 4 types of hypoxia. First is hypoxic hypoxia. Second is anemic hypoxia. Third is stagnant hypoxia. Fourth is histotoxic hypoxia. Hypoxic hypoxia means there is low oxygen outside also, right? You are going to go to where you are going to a mountain, high altitude. Okay, mountain, there is no oxygen outside, no oxygen. How you can inhale the oxygen? This is going to be hypoxic hypoxia. Hemoglobin will be normal or increase or decrease here? Normal. You can have the same thing in the ARDS in the lungs diseases also, LRTI, lower respiratory tract infection. Anemic hypoxia, you will be having anemia means decrease oxygen in the blood. Anemia means decrease in blood. Decrease in blood means decrease in hemoglobin. Decrease in hemoglobin means decrease in oxygen. Right? So anemia will be having decrease in hemoglobin. Hemoglobin will be decreased, yes or no? Yes. And if hemoglobin is decreased, you will be having what? You will be having this type of symptoms. What are the symptoms? You can have hypoxia will be there, right? Apart from that, if there is a like anemia, these patients will get tired very easily. They are having what symptoms? They are fatigued. They are getting fatigue. They are getting weakness. They are getting all those symptoms very commonly, right? One more symptom, anytime you have rupture, anytime you have anemia in your body, anytime you have rupture of RBC, what will happen? You will be having what? If you will be having splenomegaly. What will happen? You understand? Spleen is also known as. You know this, but you don't know why splenomegaly is happening. Yes, now you know, right? Whenever you have splenomegaly, like malaria, how we will assess malaria? Fever with chills with splenomegaly. This is going to be what? Most likely, this is going to be malaria, right? So, how you will check for the spleen? You will tell the patient to lie down. You will flex the knee. You will start from this particular part. You will feel the spleen from this particular part, from the lateral border, and you will start from here. You will tell the patient to take breathe from the mouth, and we will go in this particular direction. Spleen will be coming like that. Splenomegaly, that much big splenomegaly can happen that it can travel from here. Here should be the spleen. It can travel all the way back till this particular part, right? So that is what is important, right? Next thing we are having is about the stagnant type of hypoxia. Stagnant means there will be some kind of a blockage will be there. Some kind of a blockage will be there. So we are having ischemia, we are having what? Atherosclerotic plaque, we are having MI, we are having some kind of a vasospasm is there, right? Or maybe some kind of embolism. Because of that, blood flow is decreased to the tissue. This is known as what kind of hypoxia? Stagnant. And histotoxic means now oxygen is also there, but tissues are not able to utilize oxygen. Cells cannot use the oxygen. This is happening in the which poisoning? Can anyone tell me what is the drug of choice for cyanide poisoning? Here it is going to inhibit the complex 4, okay, in ETC, and that is going to inhibit your cytochrome P450 enzymes, leading to what? Death of the person. Cell death and person death will be there. Cyno, cyanide poisoning. Cyanocobalamin, methylcobalamin. Okay, this is going to be the vitamin B12 is going to be the. Earlier we used to give amyl nitrite and other things, but now we are giving what? Vitamin B12 analogs. Then comes the next, the surfactant. Surfactant has a function to decrease the surface tension in the alveoli. That will prevent the collapse of alveoli. Surfactant is produced by which cells? Type 2 pneumocytes. Okay, it is produced by the type 2 pneumocytes. Composition will be, it will be having phospholipid. Phospholipid is going to be which lipid? Dipalmitoyl phosphatidyl choline. Dipalmitoyl phosphatidyl choline, also known as lecithin. Surfactant production starts at ऑप्स गए नहीं बोलो 20th week it will start, and at 34th week it will be maximum. Okay, what are the factors that are going to increase the production of surfactant? These are going to be thyroid hormone, these are going to be glucocorticoid, these are going to be the factors which are going to increase the surfactant. What are the factors which are going to decrease the surfactant? One is going to be smoking, second one is going to be insulin, right? These are the factors which are going to decrease the insulin surfactant, right? And disease is going to be respiratory distress syndrome, which is hyaline membrane disease, and where you will be having this whiteout lungs, right? Normally, this lungs should be having what? Air, and air should be looking which color? Black. Here, what you are finding? White color. These lungs are known as whiteout lungs. So when you see whiteout lungs, this is very much suggestive of what? ARDS. This is very much suggestive of ARDS. If it is acute situation, this is here in this case is going to be RDS, respiratory distress syndrome. If this thing is happening in us, same whiteout lungs in COVID-19 we are having, that was your ARDS. That was your acute respiratory distress syndrome, right? Because on the basis of duration. You know about GDM mother, GDM baby? Tell me fast. What happens in what happens in GDM baby? Hypoglycemia, direct hypoglycemia. If the mother is having more insulin, what what is what is GDM? GDM is mother is having more glucose in the pregnancy. Mother is having more glucose in the pregnancy. If mother is having hyperglycemia, mother will be releasing that glucose to the baby. Yes or no? This glucose will be going to the baby. Yes or no? Right? If baby will be having more glucose, baby will be having more adipocytes formation. Yes or no? Baby will be macrosomia, also known as large for gestational age baby. Right? This baby will be big baby. Big baby will be there. Right? Second thing, if this baby is getting big, he will be getting more glucose. What will happen? He will be having hyperplasia of beta cells, leading to what? Increase in the levels of insulin. And that insulin, we already know insulin is going to do what? Decrease in the surfactant production. Insulin is going to decrease the surfactant production. Yes or no? So baby will be having decreased surfactant production. Yes or no? Baby will be having decreased surfactant. First problem, right? And second thing, what is going to happen? If baby will be having decrease in the surfactant, and this baby is a big baby, normally surfactant should produce within 34th week. But here this baby is a big baby, and there might be some difficulties during delivery, right? So what we can do, let's say we are doing here LSCS, and we forgot this particular thing. We are doing here what? Delivery we are doing, and we forgot about this particular thing, that insulin will be more and baby will be having baby will be having insulin will be more, and insulin will decrease the factors, insulin will decrease the production of surfactant. So this baby might be having RDS. Yes or no? This baby might be having RDS, but you are a good doctor, you know about it. You give what? You give corticosteroid. Why? Why they are going to? Why? Corticosteroids like dexamethasone, betamethasone has a side effect. What is the side effect? That is what is important, right? What is the side effect we are having? Dexamethasone and betamethasone cause hyperlipidemia. This side effect is going to happen in you and me also, right? But at baby, hyperlipidemia means what? What is the lipid? Dipalmitol phosphatidylcholine is a type of lipid. It is a type of lipid. So this lipid hyperlipidemia is going to make what? It is going to make phospholipid, and baby will be having lung maturation, right? We are that is why we are giving dexamethasone, Dexona, right? Here, what is going to happen? The lungs are mature, and now the baby is coming out. Now the baby is coming out. When the baby is going to come out, you need to check for what? First thing, you will be checking for the lungs. Lungs are okay, and you will be happy. Baby will sleep. If you will not check for hypoglycemia, baby will be opening his eyes in the heaven again. Right? He will be like, okay, डॉक्टर इज वेरी गुड राइट सो कम बैक वेलकम हो जाएगा उसको वेलकम बैक हो जाएगा राइट सो व्हाट यू नीड टू रिमेंबर यू ऑलवेज नीड टू चेक hypoglycemia component because outside the outside the just try to understand outside the mother when or let's think like that whenever this baby is inside the mother he will be getting placenta will be there and placenta will give him lots and lots of glucose but when the baby is coming out, there are certain times when mother is even not able to feed the baby. Right? There will be no breast milk. Second thing, you cannot give any glucose to the baby, other glucose, right? Third thing, what is going to happen? This baby, even if you are giving glucose, what is happening? This baby is already having what? Hyperplasia of beta cells. And these beta cells are going to release what? Increased levels of insulin. And if you are just giving a little bit of milk or something like lactose, how much is going to be the absorption is going to be how much glucose is going to get from outside and not as compared to the placenta, nothing as compared to the placenta, right? So what is going to happen? This patient will be having hyperinsulinemia, and this insulin is going to cause what? hypoglycemia in the baby, and this baby, this this bachcha can die. This hypoglycemia is a component which is a silent killer, right? So what you gotta do? You gotta assess the glucose levels. Glucose monitoring should be done. This patient should be given dextrose. This patient should be given dextrose until the time this beta hyperplasia will get normalized. We need to take care of them. We need to do the monitoring of the baby, right? That is what is important. You understand? These are the concepts which are going to help you, right? We are having what? Hypoxia. What is hypoxia? Hypoxia means decrease in the oxygen. We are having anoxia. Anoxia means absence of oxygen. We are having cyanosis. Cyanosis means decrease in the blood leading to bluish discoloration will be there. What is this atelectasis? This is going to be complete or partial collapse of the lungs. This is known as atelectasis. Pneumonia is going to be infection of lungs. It can be typical, atypical. Consolidation, in fact, is the feature of typical type of pneumonia. Only typical pneumonia will have that consolidation. Pulmonary edema means what? Accumulation of fluid in the alveoli or interstitial space. Okay. And pleural effusion is going to be accumulation of fluid in the pleural cavity. Both things are clear or not? Suppose this is going to be your lungs. Suppose this is going to be your lungs, right? Suppose this is going to be your lungs. This particular lungs will be having an extra cavity, and this cavity is known as what? This cavity is pleural cavity, everyone, right? This cavity is known as pleural cavity. And when you have water accumulation, fluid accumulation in this cavity, this is known as pleural effusion. It can have 2-3 liters of fluid also, right? Whereas when you have this fluid accumulation inside the lungs, this is known as pulmonary edema. Don't confuse between these two things, right? What is emphysema? Here you will be having decrease in the elasticity of the lungs. We can have this emphysema due to smoking, due to alpha 1 antitrypsin deficiency also. And asthma is going to be inflammatory disease, type 1 hypersensitivity reaction, and this is due to leukotrienes, and Montelukast drug is a Montelukast is a leukotrienes inhibitor, right? So anytime you have what? Anytime you have leukotrienes are the most powerful bronchoconstrictor. If they ask you most potent bronchoconstrictor, what are the most potent bronchoconstrictor? Your answer will be what? Leukotrienes are the most potent bronchoconstrictor, right? This is going to be the drug you will be using in this particular case, right? Next system is going to be your muscular system. Muscular system will be having what? Just try to understand this. Here we are going to have what? We are having three types of muscles will be there: skeletal muscle, cardiac muscles, and uh, skeletal muscle, cardiac muscles, and smooth muscles. Muscular system will be having three muscles we are discussing about. Skeletal muscle fiber I'm teaching you, right? Skeletal muscle fibers are of three types. You eat chicken, right? In chicken you will be finding sometimes white fibers are there, sometimes red fibers are there. What are those white fibers and red fibers? Red fiber is a fiber which is having what? Myoglobin. Red fiber is a fiber which is having what? Myoglobin. Just like hemoglobin, they are having what? Myoglobin, and that myoglobin is going to give what? Color to the red fibers, right? They are going to do what kind of glycolysis or what kind of energy production? Aerobic. Aerobic. If this particular thing is going to be present, this is going to be aerobic glycolysis. If you do not have this if you do not have this myoglobin will be having mitochondria. If mitochondria is present, then only aerobic glycolysis will happen, right? If mitochondria is absent, how can you do aerobic glycolysis, right? Contraction velocity will be slow, fast. Here, just remember this particular thing. This type 1 fibers are responsible for endurance and posture. Like you are sitting in the class since morning. Which fibers are mostly activated in your body? Type 1 fiber. They are going to help you in sitting, right? Whereas this type 2 fiber, type 2A fiber are responsible for moderate intensity work like walking. If I tell you to walk, you can walk with me like 5, 7, 10, or 20 kilometers. Then after that, you will be having fatigue, right? And what are these type 2B fiber? They are going to be anaerobic fibers. So they are going to be fast. Fatigue resistance will be slow, and these are going to be responsible for intense short duration exercise. Like I tell you to sprint, you can sprint for 100 meter, 200, 500 meter, let's say. Then what is going to happen? You will be having anaerobic glycolysis, and end product of anaerobic is ultimately going to be what? Next day you will be having the pain in the body. I'll tell you, okay, let's come with me, let's play football, right? So what will happen if you play football with me after this class? Next morning you are not able to move. What is going to happen? You will be having this anaerobic glycolysis. These are the sprinting fibers, type 2b fibers. And once you have this lactic acid formation, you will be having what? Pain. Yes or no? Yes or no? If no, let's play football. Right? So we will have the pain over here. Anesthesia is done. Online, offline, done is done. Malignant hyperthermia. You heard about this term, malignant hyperthermia? Hmm? Don't remember. Okay, malignant hyperthermia means what? So this thing is emergency that is going to happen when you are going to go to anesthesia department, right? In anesthesia, this is the emergency that can happen whenever you are giving succinylcholine or any inhalational agent. Any inhalational agent. Now you tell me four inhalational agent. Four drugs inhalational agent anesthesia. Yes. Louder, please. No, no issues. If you make mistakes, no issues. Nobody is going to judge you. I'm not able to hear. Yes. Next. Hello. CO. ISO. DES. Enfluorine. Methoxyfluorine. All these things are what? Sevoflurane. Isoflurane. Desflurane. These are thing what? These are your inhalational anesthetic agent, right? Succin Succinylcholine or any inhalational agent if a patient is taking. Okay, this is going to be the problem, right? Now, what is going to happen? This patient will be having what? This patient will be having activation. What is the activation he will be having? He will be having activation of what? He will be having a mutated receptor. These receptor are known as rhinodine receptor. These receptor are known as, this is the main cause, rhinodine receptor. This is the main cause behind the disease. When you have this mutated rhinodine receptor and you are taking this any of this anesthetic agent, this rhinodine receptor is going to bind with dihydropyridine receptor DHPR, and it is going to open what? It is going to open calcium channels. It is going to open calcium channel. It is going to be a mechanical conversion, and calcium channel will be open. You know the function of calcium in vessel. It is going to do vasoconstriction. Calcium in muscle is going to do muscle contraction. It is also going to do exocytosis, and all these things, excessive muscle contraction, excessive vessel contraction, that is what is going to lead to a disease that is known as malignant hyperthermia. This is known as what? Malignant hyperthermia. And the drug of choice for this particular situation is going to be IV sodium dantrolene. The drug of choice will be IV sodium dantrolene. Yes, Lenovo is right. Can anyone tell me what is this particular sign that you are having in front? This is known as Gober sign, and this Gober sign is characteristic in which diseases? It is a sign that you will be finding in muscular dystrophy. Okay, we can have two type of muscular dystrophy. One is going to be Duchenne muscular dystrophy. Second one is Baker's muscular dystrophy. Duchenne will be having complete loss of dystrophin gene, complete loss of dystrophin, whereas Baker's will have partial loss. Okay, partial loss of dystrophin. Dystrophin is the largest gene present on chromosome number 1. So, what is going to happen? This Duchenne patient is going to die early. This patient is going to die in 20 to 30 years, whereas this can die into 40, 20, 30 years. This will be dying 35 to 45 years. ये थोड़ा ज्यादा जी लेता है 35. This sign is known as Gover sign. So this patient will be looking normal. When this patient will come to OPD, you will tell the patient, okay, sit down and again stand up. So when this patient will sit down and again trying to stand up, he will be having what? He will be using his body support for standing up. He will be using his body support like that. He cannot stand up directly. So he will be using all the hand supports, and then he will be somehow able to stand up. And then you will understand. You will also notice pseudo hypertrophy of calf. In fact, whenever you see pseudo hypertrophy of calf, you will always suspect about some kind of muscular dystrophy. Next one in the list is neuromuscular junction. Neuromuscular junction. So how this nerve impulse is going to come? This nerve impulse, like for example, I'm thinking to contract my hand. If I'm thinking to contract my hand, what will happen? The impulse from my brain is going to come all the way here till the muscle, and now I will be doing some kind of a contraction, right? So here, this what is going to happen? This nerve action is going to come with the sodium. This sodium is going to come inside, and this is the sodium which is going to do action potential. And here you will be having what? Here, this cell will get depolarized whenever this positive charge is coming inside. This is known as depolarization. And because of depolarization, what can come inside? Calcium. And whenever calcium will come inside a cell, it will do what? Exocytosis. It will release what? Acetylcholine vesicles will be coming out. And now this acetylcholine vesicles will be taken up by something, and they will be having the muscle action potential will be there, and muscle contraction will happen, right? This is how this muscle contraction will happen. You can have antibody against this nicotinic acetylcholine receptors. What is the name of the disease? Graves. When you have autoantibodies against nicotinic acetylcholine receptor, this is going to be the myasthenia gravis. When you have antibodies against this calcium channel, this is going to cause a disease. This is known as Lambert myasthenia syndrome. Lambert-Eaton syndrome, you can remember. When this acetylcholine is going to come, this acetylcholine is going to activate what? It is going to activate it is going to do the what? Depolarization here. Can you appreciate this acetylcholine is coming? It is going to make the action potential, and this action potential is going to ultimately convert what? It is going to do what? Contraction of the muscle. Okay? What happens? You're out? You want to break? So you want to go home? Don't ask me about going home. You understand this or not? So you want a break? Okay, take a break, no issues. We are having CVS. Before CVS, I think I should give you a break. And then we are having what? CNS. And then we are having what? HEMAT. We will finish. 1.5 hour you can stay till 9:30. Two things are there. I can go faster, and you will be. I don't know whether you are going to understand or not. Okay, means I can give you only important things. Or second thing, I can go a little bit slower, and I can revise very properly if you are having issues in the CVS and CNS, because these are the chapter which are always going to be problematic. You know what is a murmur? You don't know. What is end diastolic and systolic volume? I'll go a little bit slower. You have to push a little, but you will understand. I can guarantee that, right? So these three chapters we are going to do, not in a hurry. We will take a break for like 10-15 minutes. Okay. Have a cup of tea or coffee, whatever you want, and then we will start with the CVS. Okay. Have some energy. Huh? Okay. Okay. So in cardiovascular system, we are going to discuss about three things. I told you three things today, right? What are the three important things that we are having? This is going to be in the heart. We are having SA node, we are having AV node, we are having muscles, right? So how this SA node is going to work? Let's try to understand this. I'm going to teach you the core basics what we are having. So before that, let me make you understand the cardiac myocyte so that you will be in a better situation to understand this one. So cardiac myocyte, I'm just trying to draw certain cells in front of you, and then we are going to see how these cells are having the transport of things across it, right? So I'll just make you understand how the things are traveling. What is the meaning of depolarization? What is the meaning of repolarization? All these things we are discussing now. Let me just cut it down. I'm putting it here, right? So what is the meaning of depolarization? Depolarization, systole, and contraction. They are same. They are same. Repolarization, just understand this fact. Diastole and relaxation are going to be same. If you don't know these terms, you cannot understand medicine, right? I'll make you understand what is end-diastolic volume, what is unsystolic volume, okay? What is preload, what is afterload? Because in medicine they will talk like that. What is ejection click? What is systolic murmur? What is diastolic murmur? All these terms I'm going to make you understand here itself, right? So we are going to have anything. One thing you already know: sodium will be more where, outside or inside the cell? Sodium will be more outside the cell. So whenever a sodium will come inside, normally, just understand this. I've told you every cell will be, having what? Every cell will be having a window. A window for what? Potassium. So potassium will leak out automatically. Potassium will leak out automatically. Now what is going to happen? This potassium will leak out. We are having two things. One is known as resting membrane potential. Resting membrane potential means it is a potential at which there is no ion movement. Potential means it is a current at which there is no ion movement between intra and extracellular. Okay, I'll keep it simple for you. So what is going to happen as soon as the sodium is going to come inside? The sodium is going to come inside. What is going to happen? Let me draw this. Suppose this is what? Minus 90. This is somewhere 0 and this is plus 20 millivolts, right? So normally what is going to happen? This is minus 90 millivolt is what? Minus 90 is the resting membrane potential. This is your resting membrane potential, right? At minus 90, resting membrane potential means at minus 90, there is no movement of ions. Nothing is coming inside, nothing is going outside, right? Then what is going to happen? Then the sodium is coming inside. Sodium is a positive charge or a negative charge. 5-10 minutes and you will understand it. Okay? It is a positive charge. So when sodium will come inside, this potential will go up or no? When a positive charge is coming inside a cell, this is going to go up, yes or no? Yes, it will go till what point? It will go till plus 20. Then what is going to happen? As soon as it will reach plus 20, what is going to happen? You will be having opening of another channel. This is going to be potassium. So it will switch, it will touch the switch plus 20. It will open what? Potassium channel. And now potassium is a positive charge going out. What will happen to the potential? It will be positive or negative now? It will come below, right? It will be coming negative. Till what point it will come negative? It will hit the again switch. This is going to be 0. This is going to be till the 0. It will be coming out to be negative. You understand this? No issues till now. Now what is going to happen? As soon as it will touch the 0, you will be having opening of calcium channel and calcium will come inside. If calcium will come inside and potassium keeps on going outside, what will happen? There will be a plateau. There will be a which phase? A plateau phase will be there, like that a plateau phase will be there. Okay? And then what is going to happen? Then this potassium, more channels will open. This more channels of potassium will open, and then this membrane potential will again coming back to zero. Till what time this potassium is going out? Till what time this potassium is going to go out? Till the time it will again come back to zero. And this is the time where everything will be normalized. Normalized is going to be what? No potassium is going out, no sodium is coming in. This is known as resting membrane potential. You understand a cell is in resting state means a cell is in the resting membrane potential. Okay. So this is going to be the graphical representation of a single contraction. Now, if you understand this, you will understand other things also. So whenever this positive charge is coming inside, we call this cell what? Depolarized, yes or no? We call it depolarized. Can I call it systole? Yes. Can I call it in a contraction state? Yes. Normally, every cell will be present in electron negativity because sodium will be more outside, potassium will be more inside. So this cell will always be in the electron negativity. That is why these cells are known as resting membrane potential. This potential is known as potential means difference of current. So this is known as resting membrane potential. How this information is going to travel? Because we already know they will be having which junctions? Gap junctions will be there. So this sodium which is coming to this first cell will travel to another cell. Then it will travel to another cell. Then it will travel to another cell. Are you understanding how this impulse is going to get transferred? I want to contract my this hand. I want to contract my this hand. What I will be doing, I will be thinking about it. This sodium is going to travel from multiple cells like that. First, one cell will get depolarized, then another cell will get depolarized, then another cell will get depolarized, then another cell will get depolarized. What is the meaning of depolarization? Sodium will come inside. Okay. Then what is going to happen? Potassium will go outside. Then what will happen? Calcium is coming inside and potassium is going outside, and ultimately you will be having repolarization because of loss of positive charge. And this sodium will be going to another cell, to another cell, to another cell. Like that, this impulse is transferring in which direction? In this direction. You understand this? How this current is traveling till this particular point? Every cell will be having this particular funda. In your body, the current is traveling in the form of this particular funda. You understand this? No issues with this? Now, if no issues with this, they are going to ask you what questions. This is a single contraction. They are going to ask you what is this phase 4? Phase 4 is going to be resting potential. Phase 4 is going to be resting membrane potential. What is phase 0? And phase 0 is due to what? This phase 0 is due to sodium influx. Sodium is going to come. Phase 1 is going to be due to potassium efflux. Potassium is going out. Phase 2 is due to calcium influx and potassium efflux will be there. And phase 3 will be having what? Potassium efflux, and phase 4 again coming back to resting membrane potential. This particular phase 0 is known as what? Phase 0 is known as depolarization. Phase 0 is known as, okay, phase 3 is known as what? Phase 3 is known as repolarization. Okay, we can also call it systole and diastole. Is that okay? No issues with this? This is second thing we are having. Now I'm teaching you about a SA node. One SA node you will understand all the pacemakers in the body, right? So pacemakers do not have resting membrane potential. First golden statement. They have what? They have restless membrane potential. They have what? Restless membrane potential. That means their potential will be oscillating between a range. Their potential will be oscillating between a range. What is the range that is going to be oscillating over here? This is going to be between minus 40 to minus 60 millivolt is going to be the oscillating range, right? So this is going to be oscillate between minus 40 to minus 60 millivolt. Is that okay? Now, what is going to be the first phase? The first phase is going to be again depolarization. This is going to be the phase 0. This is going to be depolarization. And then we have the phase 3, which is going to be repolarization. What is the question they are asking? This phase 4 is known as what? This phase 4 is known as pre-potential. This phase 4 is known as pre-potential. And what is the meaning of pre-potential? There are going to be three important things. This pre-potential is due to first thing, funny current. First thing is going to be funny current type of sodium channel will be there. So what type of sodium channel? Funny current. Second thing is going to be second thing is going to be T type of calcium channel, transient type of calcium channel, and third thing is going to be decrease in the potassium efflux. Decrease in the potassium efflux. These are going to be the three reasons of prepotential. These are going to be the three reasons of prepotential. Just try to understand ultimate function is what they are retaining the positive charge inside. So first function, sodium channel, funny current sodium channel. If sodium channel is coming inside, this is going to increase the potential, yes or no? Second thing, T type of calcium channel. T means transient type of calcium channel. Here, calcium will come inside. Is this going to be a positive charge? Yes or no? Third thing, decrease in potassium efflux. Normally, potassium was going out. We have already seen in the beta cell, if potassium efflux is decreased, that means potassium will accumulate inside the cell. Yes or no? And this is known as depolarization. This is known as depolarization. So this is going to be the phase 4. This is known as free potential. Rest will be simple. Phase 0 is going to be due to what? Phase 0, here you will be having long lasting type of calcium channel. L type calcium channel will be there, responsible for depolarization. And phase 3 is going to be what? Phase 3 is going to be same repolarization, which is have the same reason. What is the same reason? Decrease in increase in potassium efflux. Right? You understand this? Only one difference you have to remember between these two. Only one difference you have to remember between these two. What is the? Yes, one difference you have to remember. This phase 4 is going to be what? What are the question they are going to ask you? Look here. They are going to ask you phase 4 in SA node is going to be due to pre-potential. All of the following are the causes of pre-potential except. So sodium channel, calcium channel, decrease in potassium efflux. Another option they will be writing you increase in potassium influx, right? Or decrease in potassium influx. Some option they will be giving you. This is going to be the question number 2, right? Phase 4 here it is pre-potential. Here phase 4 is what? Here phase 4 is resting membrane potential. So that is the second question they are going to ask you. Here phase 0 is going to be what? Depolarization. Here also depolarization. They cannot ask you anything. Here phase 3 is going to be repolarization. Here also repolarization. And reason is simple. Reason is simple. Lead to potassium efflux. Lead to potassium efflux, right? Now, what we are discussing, what is this particular thing? This is 1 second. This is the time period that is given. 1 second. This is a single contraction that I'm teaching you. This is a single contraction of SA node. Single contraction of SA node that I'm teaching you. So what happens in 1 second? You will be having one contraction. So heart rate will be how much? In 60 seconds, how much is going to be the heart rate? This is a single contraction that is happening in 1 second. So what is going? This is the SA node. SA node is always concerned with heart rate. SA node is always concerned with heart rate. So this is a single contraction that is happening in 1 second. Heart rate will be how much? 60. This is going to be normal, yes or no? Less than 60 will be bradycardia. This is going to be normal. If you already know, you know sympathetic nervous system will do what to heart rate? Increase or decrease the heart rate? Sympathetic nervous system increase the heart rate. SA node will be increased, right? So how this SA node will be increased? Now let's try to understand. Give your complete concentration here. It is going to increase the slope of pre-potential. Look here. It is going to increase the slope of pre-potential. If slope of pre-potential will be increased, look here. Slope of pre-potential will be increased. What is going to happen? You will be having one contraction. You will be having two contraction. In how much time? 1 second. 1 second. What would be your heart rate? 120. Okay. So how this SA node? You already know sympathetic nervous system will increase the heart rate. How it is going to increase? It is going to work with these three things. These are the three things. This funny current that you are studying, a drug you will study, evaporating, right? Two places only. One is in the eye and second is in the SA node. Two places only evaporating. Okay. Funny current, two places you have to remember. This is the first thing, sodium channel. Ultimate function depolarization means what? Systole. So ultimately, what is happening? The sodium is going inside. This is going to cause excessive. This is going to increase the slope of the potential. T-type calcium channel. This is also going to increase the slope of potential. Third thing is going to decrease in potassium efflux. That means potassium will accumulate inside. This is also going to be what? Positive charge accumulating inside. This is known as depolarization. Simple understanding, right? What parasympathetic nervous system will do? It will decrease the slope, right? It will decrease the slope. It will inhibit the entry of the sodium and all those things. So what is going to happen? Now we will be having half of contraction over here in 1 second. Total contraction will be 30 in a minute, right? So parasympathetic, how it will decrease the heart rate? Parasympathetic will decrease the heart rate by decreasing the slope of prepotential. Sympathetic will increase the heart rate by increasing the slope of prepotential. Sympathetic increase the slope of prepotential. Prepotential. These are the very, very important questions. And if you have this type of concepts along with you, nobody can make you fail in any examination, right? If you ask these things to like NEET PG students who have cleared this NEET PG exam, went to the hospital also, they don't know how this thing is happening. But if you have the knowledge, if you know this about these things, how this is happening, you are going to utilize your drugs very well. Right? Concepts are very, very important. This is what? This is a single contraction of cardiac myocyte. This is also a single contraction of cardiac myocyte, 1 second contraction of cardiac myocyte. Right? You study about the drugs arrhythmia. You study about arrhythmia. Arrhythmia means abnormal rhythm. We are having what kind of drugs? This is going to be the cell. So first class will be what? Arrhythmia classification. First class of drugs will be sodium channel blocker. Okay. Second class of drugs will be beta blocker. Third class of drugs will be potassium channel blocker. Potassium will sodium. Look here. Sodium will be more outside. First class of drugs. Beta receptor will be present on the cells. Second class of drugs. Potassium will be more inside. Third class of drugs. Fourth class of drugs will be calcium channel blocker, which is going to be inside. And fifth class will be having others. Fifth class will be having other drugs like adenosine and all those things, magnesium sulfate, right? So that is going to be that is how you can remember the anti-arrhythmic drug, right? And now the sodium channel blocker is going to do what? It is going to block sodium entry. If sodium entry is blocked, try to understand this thing, right? This is a 1 second, one contraction of what? Cardiac myocyte. This is a single contraction of cardiac myocyte. Suppose your myocytes are contracting very fast, you are having what? Tachyarrhythmia. You are having what? Tachyarrhythmia. Now you are giving a drug sodium channel blocker. Now what will happen? This will take time, yes or no? This slope will be increased. This will take time, yes or no? Yes, if this will take time, that means the slope will be increased. And these are the drugs like quinidine, procainamide. We are using flecainide group of drugs, lignocaine group of drugs. So all these drugs are going to work here. These are sodium channel blockers. We are having what? Drugs which are going to control the rate. That is going to be beta blocker. We can have potassium channel blocker. Potassium channel blockers are going to work here. They are going to decrease what? इसको बंद कर देंगे. We are going to block this. What will happen? It will take some time. You understand? You will utilize these things there. You understand what I'm trying to discuss with you, right? No issues with this. No issues with this. Are you understanding? Okay. Now comes this graph. You understand this graph? Have you studied about this? Okay. This is a pressure volume graph. Okay. I'm going to make you understand. Look here. I'm just developing what this is a heart. This is your heart from the basics, from the zero. This is going to be your right atrium. This is going to be your right ventricle. This is going to be your left atrium, left ventricle. Right will be first. It will be having 3 number will be coming first. So it will be tricuspid valve. 2 number will be coming late. It will be bicuspid valve. Left ventricle will be having what? Aorta. So here you will be having aortic valve, and this aorta will be transporting blood to the body. From aorta, the blood will be going to the body, and from the body, deoxygenated blood will be coming where? In the right atrium via vena cava. We are having superior inferior vena cava, and this blood will be going to the right ventricle. And from right ventricle, this deoxygenated blood will be going where? Oxygenation will be happening in the lungs. So here you will be having blood will be going into lungs, and from the lungs, oxygenated blood will be coming where? In the left atrium, and this blood will be going to the left ventricle. This blood will be going to the body. From the body, deoxygenated will come into right atrium, right ventricle, it will go to lungs. From the lungs, it will come into left atrium, from left ventricle, and this cycle will be continuing like that. Okay, so this is the cycle of the heart. This is known as heart cycle, cardiac cycle, right? Now I'm going to make you understand what happened in one contraction. If you understand what happens in one contraction, you will understand all the pathologies behind it. What is antisystolic? What is antidiastolic? What is preload? What is afterload? What is systole? What is diastole? Right? These terms are, if these terms are clear to you, what is mid-systolic murmur, early systolic, ejection click, all these terms will be clear in this particular diagram. Okay, so I'm starting this point. If you have any issues, if you have any issues regarding this particular basic, you can let me know. Any issues? You understand this particular diagram? First thing. Second thing, we are having two types of wall. One is known as atrioventricular wall. So these are going to be the wall between atrias and ventricle. They are also known as atrioventricular wall. And these are known as semilunar walls. Semilunar means they are crescent shape. So we are having pulmonary, we are having aortic wall also. Right? Now I want you to remember two things. Whenever you are going to get a sound, when you get a sound, when you have the closure, when you have the closure, you get the sound. Only the sound will be produced when there will be closure of the gates, right? So this is the first thing. And second thing I want you to remember, I will teach you about the left side of the heart. Automatically, right will follow. Right? If I say by this particular valve is known as what? This is a tricuspid. This is known as which valve? Bicuspid. What is the other name for bicuspid? It is also known as mitral valve, right? So whenever I will say bicuspid valve closure, automatically you understand tricuspid will be closed. When I will say aortic valve closure, automatically you will understand pulmonary will be closed, right? So I will teach you about this particular side of the heart, and automatically this one will follow. They will be working together, right? So let's begin with the left ventricle. You can take any point from here. I'm just taking a point B. I'm just taking a point B. This is the graphical representation. Okay. Give your complete concentration. It is very, very simple. Nothing fancy. Just need understanding once. Right. So this is a point B. At point B, I am having how much blood? 120 ml of blood in the lungs, in the heart, 120 ml of blood in the left ventricle. That is what I am imagining. So, what is happening? We are having left ventricle, and how much is the blood here? 120 ml, right? And now, what is going to happen? Now, this 120 ml, can I directly open this aorta? This blood will go to the body? No, it cannot go. We need to generate some pressure first. This wall of the left ventricle is thick, right? Because it needs to transport blood to complete body, it needs to have some pressure, right? This is a pressure volume graph. Here you will be having pressure, here you will be having volume, right? So at point B, 120 ml of blood is here, but it cannot go to the body. First thing we need to do is generation of the pressure. So now we are generating the pressure. And this pressure generation is known as isovolumic contraction. Isovolumic means same volume. What is the volume we are having? First understand is what is the volume we are having? 120 ml. And now we are doing the contraction, just like pressure cooker. Pressure cooker will be having same volume, and we are increasing the pressure, right? Increasing the pressure till what time? At point C. At point C, what is going to happen? Now which valve will be opening it up? After generation of complete pressure, when you have enough pressure that blood can go to complete body, which valve will be opening? Aortic valve. Do we get any sound due to opening of valve? No. So aortic valve will open, and here at point C you will be having 120 ml. And after aortic valve opening, what will happen? Two steps. One is going to be rapid ejection. This blood will go rapidly, and then second stage will be slow ejection. This blood will go rapidly and slowly to the body. Is that okay? No issues with this. Now what will happen if the blood is gone? Some amount of blood will be left here. Now what will happen? This aorta will be closing. Yes or no? Yes, aorta will be closing, and aorta closure is going to give you some kind of a sound or not? Aortic valve closure will give you some sound, and this sound is known as what? This sound is known as S2 sound. S2 sound first, okay? And now what is going to happen? This is the S2 sound you are having. S2 sound you are having, you have sent the blood to the body, but it is not completely empty. How much blood is left here? Remember, out of that 120 ml, 50 ml will be left here. 50 ml will be left here. You can appreciate this is the 50 ml which is left here. Right? Now, can I open this valve? This valve is closed. Yes or no? This valve is closed. Yes or no? Yes. This is a closed cavity which is having how much amount of blood now? 50 ml. Now, can I open this valve? No. If I open this valve, what will happen? This 50 ml will go there because the pressure is already very high here. What is the pressure? The pressure is high. So first of all, I need to decrease the pressure, and this process is known as what? Isovolumic relaxation. This process is known as what? Isovolumic relaxation. Isovolumic relaxation. When this pressure is going to come to zero again, when this pressure is going to come to zero, can I open this valve now? Can I open this valve? Do we get any sound when opening of the valve? No sound, right? So now I can open at point A, I can open what? This bicuspid or mitral valve, yes or no? Right? And because of opening of this valve, 50 ml is already there. You will be having filling. You will be having filling, and you will again have what? How much blood? 120 ml. Till it will become 120 ml, what will happen? Now this valve will be closing, yes or no? Yes, and this closure is going to give you some sound or not? Yes. So this valve closure is going to give you sound, and this sound is going to be what? At point B, you will be having mitral valve closed, and this mitral valve closure will give you which sound? Here you will be having the S1 sound. Okay, here you will be having the S1 sound. No issues with this. This is the normal cycle. Just try to understand. I'll just recap it once again for you. Okay, we are having 120 ml of blood here in the left ventricle, and I am assuming now I am having what? I am having 120 ml. First thing I need to do, I need to generate the pressure. This particular pressure generation is known as isovolumic contraction. This is known as isovolumic contraction. Then what will happen? Point C will come, or you can think like that. C point is going to be what? C point is aortic valve open. Now aortic valve will open, and there will be rapid ejection. There will be slow ejection. But is it going to lose all 120 ml? No, sir. 50 ml will be stored. 70 ml will be going away. And at this point D, what is going to happen? Do you think now blood is gone? 50 ml is left. Now what is going to happen? This valve will be closed. Yes, and closure of aortic valve will give you with sound. S2 sound, right? And now can I open this? No, sir. If I open this, there will be some regurgitation, right? There will be some backflow of the blood that I don't want. I'm not teaching pathology right now, right? I don't want this to open. I don't want this blood to go back. So what I will be doing? I will be doing what? I will be decreasing the pressure. This is on the same volume. Isovolumic relaxation. How much is the volume? 50 ml. We are decreasing the pressure till point A, and now what is going to happen? When the pressure will be decreased, now you will be having the normalization of the situation. When this pressure will be decreased, 50 ml is already there. Now point A will be working, and point A means what? Mitral valve will open, and once mitral valve will open, you will be having filling again. Till what point? Till it will reach 120 ml again. And whenever this 120 is done, what is going to happen? This valve should be closed. Yes or no? Mitral valve. And mitral valve closure is going to give you first sound. This is known as S1 sound. No issues with this. You understand how this S1, S2 is happening. Wonderful. Right? Next thing we are going to have, can I divide this cycle into two phases? Yes, I can divide it into two phases. This is the cycle I am dividing into two phases. Can you appreciate? I am dividing from here. From here, this particular side is going to be systole, and this particular side is going to be diastole. Systole means contraction, systole means depolarization. You agree with this word? Systole means depolarization, systole means contraction. Same thing, right? So let's try to understand isovolumic contraction. Is it a systole? Rapid ejection, slow ejection, is it a systole? Yes, then these are the systole. These are the systole, right? From here, we are having isovolumic relaxation, and there will be filling, and this filling is due to gravity. This is going to be diastole. No issues with this. Whatever volume we are having after the systole, after the contraction, whatever volume we are having, this is known as what? And systolic volume. This is known as end systolic volume. So tell me, what is end systolic volume? How much is going to left after contraction? 50. So end systolic volume is going to be 50. What is going to be your end diastolic volume? At the end of diastole, what is going to be the volume? 120. So now you know what is end the diastolic volume, what is end systolic volume, and you always want to get to know about the stroke volume. What is stroke volume? Stroke volume is end diastolic minus end systolic. Diastolic is going to be after the relaxation there will be 120 ml, and after the systole there will be 50 left. Whatever is going away is known as what? Stroke volume. It is known as stroke volume. Okay, and I told you what is cardiac output. That is going to be heart rate into stroke volume. Heart rate will be suppose 72, stroke volume will be 70. Is it going to be somewhere around 4.9, or you can simply say it will be around 5 liter? Yes, in the morning I told you cardiac output will be how much? In a minute your heart will be releasing how much of blood? 5 liter, right? It will be having stroke volume. That means it is going to beat 72 times, and every beat will be having 70 ml of blood going away. You understand? This is what we are discussing, right? In heart failure, you will be having ejection fraction will be decreased. All those things will be there, right? Basic. You understand this, right? Now, if you have any kind of sound hearing in this particular part, this is going to be early systolic murmur. This is going to be early murmur means what? Abnormal sound. Abnormal sound. Turbulence. Yes, it can be abnormal sound. It can be early systolic murmur. If you hear this particular sound here, this can be mid systolic. And if you hear at the end of this particular phase, this is going to be late systolic murmur. Same thing will go with the diastole also, right? Now what is important? Now what is important? Let's learn about the what is regurgitation. What is like regurgitation? What is another thing? Stenosis, right? Stenosis means there will be hardening. There will be hardening, and regurgitation means there will be weakness leading to what? Backflow. Now you tell me, if at this particular point, this particular point it should be closed. It should be closed, right? Now what is happening? You are having some problem with the mitral valve. What is the problem? It is not completely closed. Maybe there is some stenosis. So what is going to happen because of this high pressure? Do you think there will be backflow of blood? Backflow of blood will be there, and this particular disease you will be hearing where? What kind of like murmur you are going to get? You are going to get early diastole murmur, isn't it? You are going to get early diastolic murmur. So you are going to put the stethoscope and you are going to understand. Okay, sir, this patient is having. When you do this thing, when this thing will get into your mind, you will easily understand. You will look between the two sounds, S1, S2. This is going to be love. This is going to be dub. If something is coming between love and dub, this is going to be systolic. And something is coming between dub and love, this is going to be diastolic. If you are finding something here, how a clinician, how I will tell the patient, okay, you are having early dystolic, early diastolic, late diastolic, mid systolic murmur. This is how I will understand. I will see, I can understand these two sounds very clearly. If you hear this, this is going to be loved up. Like that, you will be having the love and dub, right? So if you understand this love and dub, you can easily understand you will be having early diastolic, mid diastolic, or late diastolic murmur, right? If it is the early diastolic, what can be the cause? Just try to understand what can be the cause. Here you can have stenosis, here you can have regurgitation, backflow of the blood, and you can easily understand, okay, this patient is having mitral valve regurgitation. You can definitely confirm these things with the echocardiography. You can do 2D echo. You can see the blood flow also, right? But this is what is a better clinician will understand. Okay, at least you have that understanding when you will send your patient for echo. When you find some problems during hearing of the sound, right? So if you are finding some problem during hearing of the sound, then you send this patient. Okay, this patient is having some abnormal sound. Okay, let's send this patient for echocardiography. You do echo, you will identify, okay, this patient is having endocarditis. Maybe this patient is having a culture negative or culture positive endocarditis. Maybe this patient is having rheumatic fever in childhood. This is going to cause what? Mitral valve prolapse can be there, mitral valve pathologies can be there, right? So those pathologies you will understand, but I just give you the understanding how to identify these things. Okay, you know what is end diastolic volume and systolic volume? No issues with this. What is preload? What is afterload? Preload means before. Preload means before contraction. Preload means before the contraction. After load means contraction. After load means after the contraction. Simple understanding. So what is going to be the preload? How much is going to be the preload, beta? Preload means before contraction, how much blood is there in the heart? That is going to be 120 ml. After contraction, after load will be after contraction. How much is that? It's not difficult. It's just we did not go through this particular thing. We direct jump to medicine. How you are going to understand what is preload, what is afterload? They do not have time to explain you all those things, right? That is why it is important to go through the complete subject, right? You understand this? This is preload, afterload. Yes. This is the complete cycle that you should be having. At least this much you should be remembering, right? You see, if you find difficulties, do ask me. No issues with that. Okay, I will help you out. Next thing is about the JVP waveforms and their regulations. So what is this JVP waveforms we are having? This is going to tell us about the situation of the right atrium. This is going to be telling us about the situation of right atrium. You can simply remember A wave is going to tell about the atrial systole. C wave is going to tell about the bulging of tricuspid valve into right atrium during isovolumic contraction. Okay, during isovolumic contraction, what will happen? These ventricles are contracting, both the ventricles are contracting, they are generating the pressure. Because of that pressure, you will be having this particular thing bulging into bulging of tricuspid valve. Tricuspid valve will be here. Bulging of tricuspid valve into right atrium during isovolumic contraction is going to give you a small wave. This is known as C wave, right? This is a pressure difference we are discussing in the right atrium. So A wave, C wave, X descent is going to be, X is going to be relax. X is going to be due to relaxation. V is going to be due to filling. V is going to be due to filling. And Y for, you can remember simply emptying. Rapid emptying due to opening of tricuspid valve. Rapid emptying will be there due to opening of tricuspid valve. So A is going to be, if you want to understand, I can give you the videos, you can see that, right? If you want to remember, if you want to solve question, what I'm telling you is going to help you to solve question. So this is going to be A wave. A wave is going to tell us about the systole. C wave, this has been asked previously. This is going to be telling us about the bulging of tricuspid valve into right atrium during which phase? Isovolumic contraction. X is going to be relaxation, and V is going to be filling, and Y is going to be emptying. Y is going to be emptying. Only V you have to remember, that is going to be the filling. Only V you have to remember, this is going to be the filling, right? Is that okay? These are the JVP waveforms. Next is the BP and its regulation. We are having how we can regulate the BP. Okay, so we are having certain rapidly active mechanisms. We are having intermediate active mechanisms. We are having long-term mechanism or slow-acting mechanisms, right? So rapidly acting, we are having baroreceptors. We have discussed about baroreceptors. We can have chemoreceptors. We can have CNS ischemic response. We can have this epinephrine coming from the adrenal medulla, which is going to activate your sympathetic nervous system. You will be having increase in the BP. Intermediate acting are going to be your capillary shift, fluid shift mechanism. When you have the more fluid in the blood vessel, capillaries will get dilated, it will remove the blood. This is how body can decrease the BP. It can do relaxation, it can do stress relaxation, or reverse stress relaxation also can happen. Renin angiotensin mediated vasoconstriction, you already know about it. RAS is going to do what ultimately? RAS is going to do what? Vasoconstriction, leading to increase in the BP. Long-term mechanism is going to be with the help of RAS aldosterone system. This is what we have seen. And second one is renal fluid conservation mechanism, where it will be working on ADH. ADH is going to do what? ADH will be having V1, V2, V3 receptor. And this V2 will be having what? Aquaporins, and it will do what? Renal fluid conservation means it will acquire, it will reabsorb the fluid, it will be increased. V2 receptor will be more. What is going to happen? If V2 receptor are going to be more water will be coming inside the body, right? This is going to be the V2 thing. Atrial natriuretic peptide is going to cause what? It is going to cause natriuresis. Natriuresis. Natriuresis means what is going out? Sodium is going out. What will happen? Water will also go out. And this will be coming from where? Atria. That means whenever your heart is feeling more pressure, your heart is feeling that there is more pressure and I'm not able to work, what this will release? This will release atrial natriuretic peptides. Peptides are protein hormones, right? And this atrial natriuretic peptide will cause natriuresis, and now you will have automatically decrease in the BP, right? Aldosterone system, we have already seen. This is going to make what? ENaC channel, and those ENaC channels are going to retain what? Sodium and water retention will be there, right? Once these topics will get into your mind, no need to worry about anything. Medicine will be just a piece of cake, right? It will be very, very easy for you. Look here, same thing about BP regulation. Now you know complete BP regulation. You just need to remember ABCDN, right? You need to remember ABCDN. You know all the drugs, doses you have to remember, and you can utilize them, right? Now comes the CNS. First, you want to study CNS or hemat? Hemat is simple. कर लो कुछ भी कर लो है ना. So, chalo, let's listen to the online people. They want to study about hematology. CNS after hemat. Are you understanding? Yes or no? Okay, these are the basic understanding should be there, right? At least you are understanding what you have left, what you need to study before starting medicine, right? So we are having hematology. Whenever in hematology, I'm going to teach you about two, three important things, right? Hematology will be study of blood, right? Study of blood. They are not going to ask you so much of questions from there, but they are going to ask you questions from the clotting cascade, right? This is going to be the clotting cascade. We are having many mnemonics for that. In Hindi, I can tell you one. Face pe tere chunri lal PAX, PACS, pay, hum, FIDA, you can remember. Okay, so there are multiple mnemonics you can search and you can remember. But no need to remember everything. What I'm telling you, just remember this one. Factor number one is what? Fibrinogen. Factor number two is what? Prothrombin. Factor number two is what? Prothrombin. Factor number 10 is what? Stewart power factor. 8 is going to be what? This is 7. 8 is going to be 8 is going to be what? Anti-hemophilia A. 9 is going to be anti-hemophilia B. This is what you need to remember. And 13 also you can remember. This is going to be fibrin stabilizing factor. Right? What is going to be the picture behind this particular thing? I'll just try to give a basic common example. Like you are having a cut on the hand. Right? You are having a cut on the hand. What will happen? In how much time do you have stoppage of bleeding? Normal bleeding time will be 2 to 9 minutes. Normal bleeding time will be 2 to 9 minutes. You are cutting vegetables, you have a cut within 10 minutes, this blood will be stopped. But you are a nasty person, and what you will try to do, you need to send this picture to your girlfriend and you are going to press it. Okay, you are going to press it. Is it going to bleed within 15-20 minutes? Yes or no? It is going to bleed. Yes, yes, it is going to bleed. So first hemostasis, hemo means blood, stasis means to stoppage of blood. First hemostasis that is happening is known as primary hemostasis. Second hemostasis that we are having is known as secondary hemostasis. So always remember, in our body we are having two types of hemostasis, primary and secondary. Primary hemostasis is somewhat is going to stop the blood for the first time. But if you press, it is going to bleed again, and it is going to bleed. This is the primary hemostasis only, right? But after 1 day, after 2 day, 1 day, 2 day, you are going to press that lesion. Is it going to bleed? Same lesion. You are having, you pressing 15 minutes later, it is going to bleed. Or let's say after 6 hours or 10 hours, is it going to bleed now? No. Now what has happened? This has completed the secondary hemostasis. So we are having two types of hemostasis. One is primary, another one is secondary. Primary hemostasis, you will be having formation of weak plug. Secondary hemostasis, you will be having formation of strong plug. And this primary hemostasis, remember, it is due to platelets, whereas this secondary hemostasis is due to fibrinogen. If these terminologies are clear, your everything will be clear. You know what is anticoagulant, what is antifibrinolytic, what is platelet, antiplatelet. All these drugs are same or different? Different or same? Antiplatelet, antifibrinolytic, anticoagulant, different. Okay. We will understand. So I'm just giving you a simple story. What is the simple story? We are having two types of pathways here. One is going to be what? One is going to be extrinsic pathway, another one is going to be intrinsic pathway. So we are having intrinsic pathway, we are having extrinsic pathway. So just remember, look here how to remember this. Extrinsic will be having what? Factor number 7. Extrinsic will be having factor number 7. Look here everyone. Second one, we are having factor number 1, 1 2 ja, 2, 2 5 ja, 10. This is going to be the common pathway. This is going to be the common pathway. What is left? After 7, there will be 8, there will be 9, 10 we have already covered. What is left? 11 and 12. These are going to be which pathway? These are going to be intrinsic pathway. This is going to be extrinsic pathway. This is going to be the common pathway. Let's try to understand. Am I teaching you right or not? This is going to be which pathway? Factor number 7, extrinsic pathway, isn't it? Look here, everyone. Factor number 7, extrinsic pathway. Factor number 1, factor number 2, 1 to the 2, factor number 5, factor number 10. This is going to be which pathway? This is your common pathway. 1, 2, 5, 10 is common pathway. What is left? 8, 9, 10 we have covered, 11 and 12. This is going to be which pathway? Intrinsic pathway. Ultimate function. If I give you a single word about this complete coagulation cascade, ultimate function of this coagulation cascade is to make what? Fibrin. To make what? Fibrin, to make factor number 1A. To make factor number 1A. This is the ultimate function of this complete coagulation cascade. This ultimate function is the formation of factor number 1A. No issues with this. ये बात समझ में आती है? This thing is clear to you. Okay. Next thing, what is primary hemostasis and what is going to happen when you are having a cut? I'll just make you understand this particular thing. So normally this is a blood vessel. Just 2 minutes and this topic will be clear for you forever. Okay, just 2 minutes, give your complete concentration. This is a normal blood vessel we are having. Always remember, a blood vessel is going to bleed, right? You are having a some kind of injury because of a knife maybe, and you are having this injury, and because of that you are having what? Bleeding, right? Understand this. So what is going to happen? These are the platelets which are going to be present in the blood. And why this platelets and why this blood vessel is going to be like that? Normally why we are not having bleeding, normally why we are not having clotting? Because of this antithrombin 3 tissue plasminogen activator, this prostacyclins and nitric oxide. No, if you don't remember, it's okay, right? Just remember what I want to convey. So whenever you are having a vessel injury, what is going to happen? You will be having release of thromboxane A2, you will be having release of endothelin. This is an injury which is happening, right? After this injury, what is going to happen? There will be the primary change or the first change. The first change that is happening because of endothelin or thromboxane A2. Endothelin and pulmonary hypertension, you have studied in pharmacology, right? It is going to do vasoconstriction. So first thing it is going to do what? Vasoconstriction. Now the vessel will be constricted. What is going to happen? These platelets will be coming here. These platelets will be coming here, right? So first change will be vasoconstriction, right? Second change will be what? Whenever a cell will rupture, it will release something. And what is the thing that is going to come out? Von Willebrand factor. What is the thing that is going to come out? This red color thing. This red color thing which is coming out, this is going to be what? Von Willebrand factor. Von Willebrand factor, VWF. This is the thing which is going to come out. And this von Willebrand factor will be acting as a glue. This von Willebrand factor will be acting as a glue. Now look at the glue. And what are these cells? These are your platelets. Blood will be having what? RBC, WBC, platelets, and plasma. Okay, so RBC, WBC, and platelets, these green color cells that you can appreciate, these are your platelets. Suppose these are your platelets, and now these platelets will be having a exteriorization. That means there will be formation of something, right? What is that something it will be having? This will be having formation of something. This something is known as glycoprotein 1b. Okay, and now this glycoprotein 1b can travel from this particular part and it can come here and they can bind like that. This is the second change that is going to happen. First change is vasoconstriction. Because of vasoconstriction, these platelets will come then these platelets will be having exteriorization and they will be traveling all the way here and they will be binding here. This is the second change. You understand till now? But this binding is not going to be enough for stoppage of blood, right? So you will be having third change. What is the third change? Third change is going to be degranulation. Now these platelets will rupture. Okay, and three things will be coming out from the platelets. Everyone look here. First thing will be ADP. Second one will be calcium, thromboxane A2. Third one will be calcium, and fourth one will be GP2B3A. This is going to be Feviquick. You can remember like Fevicol. What is whatever you want to remember. This is also going to be a kind of a glue kind of thing. Okay. So what is going to happen? These two cells are going to bind together now, and these two cells are going to bind means what is going to happen? You will be having this stoppage of the bleeding, and this particular process is known as platelet aggregation. This process is known as platelet aggregation. You understand this? What is platelet aggregation? This is primary hemostasis. If you press, is it going to bleed? Yes, this is primary hemostasis. I'll make you understand. Everyone look here, just 1 minute. Okay, I'll make you understand what is going to happen. So you are going to have multiple platelets will be there in the blood. Multiple platelets will be there in the blood. As soon as you have vessel injury, what is going to happen? First change will be vasoconstriction. Now just imagine these are the platelets. Now this platelets, before the platelets, what is going to happen? This layer will be having what? Release of von Willebrand factor, that is known as the glue. Now this glue will be released, and what is going to happen? These platelets will come. These platelets will be having exteriorization. That means GP1B will be coming out, and now these platelets will come and bind over here. Okay, these platelets will come and bind over here. Okay, let me correct. Now this platelet will come and this platelet will come and they will bind over here. After this platelet will come and bind, they will be having degranulation. What are the four things will be coming out? First one, ADP. Very, very important previous year question. Second, thromboxane A2. Third one, calcium. And fourth one, GP2B3A. All of them are question. All of them are question. Right? When four things will come out, they will bind together. They will bind together. This is known as platelet aggregation. This is the complete process. Vasoconstriction, platelet will come nearby. Exteriorization, GP1B, von Willebrand factor coming, binding here. Degranulation, great. First, second, third, fourth. Binding together. This is known as primary hemostasis. What is secondary hemostasis? We have already covered that. Now you will be having fibrin formation, and this fibrin will come over it, and this is known as secondary hemostasis. You already know this, right? You understand this? Secondary hemostasis means fibrin deposition. What is the function of this secondary hemostasis? Secondary hemostasis or clotting cascade is a part of primary hemostasis or secondary hemostasis? Secondary hemostasis. That is very, very important. Primary bleeding, stoppage of primary bleeding is due to platelet or it is due to fibrinogen, fibrin or something else? Platelets. It is due to platelet. It is due to platelet. If you remember this, you will be discussing in pathology multiple diseases like you have von Willebrand factor disease. If there is no von Willebrand factor, what will happen to bleeding? Is it going to stop the bleeding? Look here, von Willebrand factor is not there, glue is not there. Is it going to bleed? Yes, sir, it is going to bleed. If you have GP1B deficiency, this is known as B. You can remember Bernard-Solier syndrome. Bernard-Solier syndrome, you will be having bleeding. Okay, you can have decreased levels of GP2B3A. This is known as Glanzmann's thrombocythemia. Again, you will be having high risk of bleeding. If you are having antibodies against this GP2B3A, this disease is known as immune thrombocytopenic purpura (ITP). Here also you will be having the bleeding, right? This is the basic, right? This ADP inhibitor drugs ka naam, post exposure MI. Post MI, what are the drugs patient is taking? Clopidogrel, this thromboxane A2 inhibitor, name of the drugs is. You see how important is this? You see how important is this? Once you understand this basic, now This ADP inhibitor is what? Clopidogrel, ticagrelor, or prasugrel, right? What is this thromboxane A2 inhibitor? This is going to be aspirin. They will say we are giving a blood thinner. And in normal layman term, what we say, or let me write it down for you. So we are having three group of drugs. These are going to be antiplatelet. What are the antiplatelet drugs? These are going to be thromboxane A2 inhibitor. These are going to be ADP inhibitor. These are going to be GP2B3A inhibitor. Right? Thromboxane A2, that is going to be aspirin. ADP inhibitor is going to be clopidogrel. And GP2B3A, you can easily understand A and B is there. That is going to be AB 3 to ja 6. So this is going to be AB6C. And MAB means it is a monoclonal antibody. This is going to be AB6C MAB. These are the antiplatelet drugs we are having. And remember, antiplatelet drugs are used in arterial events like myocardial infarction or stroke only. Have you seen any patient taken on a antiplatelet like aspirin on the DVT patient on aspirin? Never, right? Second, we are having is anticoagulant drugs. Anticoagulant drugs are the drugs which are working on secondary hemostasis. These are the drugs like heparin. These are the drugs like warfarin. They are going to work on which pathway? Secondary hemostasis. Secondary hemostasis, right? And secondary hemostasis means they are going to be factor 2A inhibitor, factor 10A inhibitor. Now you know what is prothrombin, dabigatran, what is multiple drugs you are having. Just go and see and try to correlate. You will find everything easy, right? And these drugs we are going to use in the venous events. What are the venous events we are having? Like pulmonary embolism. Okay, we are having deep vein thrombosis, pulmonary embolism, right? Here we are going to use anticoagulant. And last, we are having anti-fibrinolytic, not anti, basically we are having fibrinolytic drug. Fibrinolytic, also known as thrombolytic drug. This is going to break down the thrombus. The example is going to be streptokinase, altiplase, or retiplase. What it is going to do, it is going to convert plasminogen into plasmin. And plasmin is going to cut what? It is going to cut the fibrin. It is going to cut the fibrin. And here the enzyme will be tissue plasminogen activator. You understand what is antifibrinolytic, what is antiplatelet, anticoagulant. This is the short summary that I can give you. Right? Now you tell me hemophilia A patient, hemophilia B patient. It will be primary hemostasis, secondary hemostasis. Secondary hemostasis. Does this patient is going to bleed throughout the life? No, they are going to be surviving, right? You understand what is primary, second, but they will be having pressure every time you will be having pressure. What will happen? They can have little bleeding. That is why they are having what? Heme arthrosis, right? They are the people who are coming to hospital with the heme arthrosis, right? Some people are having von Willebrand factor disease, von Willebrand disease, right? What you are going to give this patient? Von Willebrand factor. I think this much is enough for you. This much time we can cover this much only. AB6 it will be having A, it will be having B, it will be having 3 to just 6 AB6C, and MAB, it is going to be a monoclonal antibody, right? Next one we are having is the CNS. In CNS, we are going to discuss about what? How many cells do we have in the CNS? We are having neurons and we are having glial cells. We are having neurons and glial cells. These neurons can be there, these glial cells can be there. We are having the first cell in the list, that is going to be what? Going fast. You understanding? एक दिन में इतना ही मिलता है. One day you can get this much also. right? So we are having this time is time is the only constraint, right? I don't know whether you are understanding or not, but yes, time is the only constraint. So we are just trying to focus on most important stuff, right? So what are the ependymal cells we are having? Ependymal cells are going to make what? It is going to make the cerebrospinal fluid. Cerebrospinal fluid. CSF is formed where? Fluid is formed where? In which plexus? Choroid plexus. Which ventricle? Lateral ventricle. And which cells? Ependymal cells. Okay? Lateral ventricle, ependymal cells, choroid plexus. Oligodendrocyte is going to do, one oligodendrocyte is going to do myelination of 30 neurons. And if there is mutation against this oligodendrocyte, which disease will occur? Multiple sclerosis. If there is mutation against this myelin basic protein in oligodendrocyte, multiple sclerosis will occur. Astrocytes are going to make, they are going to make what? Blood brain barrier. They are going to make what? Blood brain barrier. And microglial cells are the macrophages of brain. Like Kupffer cells are the macrophages of liver. Osteoclast are the macrophages of bone. Langerhans cells are the macrophages of skin. Tomorrow I'll teach you, right? So all these cells, they are monocyte in nature and they go to different organ. We call it different. Swan cell is going to do one swan cell, S for swan, S for single. One swan cell is going to do myelination of single neuron. Single neuron myelination will be there. And here you will be having what? The disease that can happen. Right now, we had an outbreak in Pune few days ago. That is Guillain-Barré syndrome. The drug treatment of choice is going to be what? IV, IG, intravenous immunoglobulins. And two organisms are associated. One is going to be Campylobacter jejuni. Second one is Zika virus. Campylobacter jejuni is going to grow at 42 degrees Celsius. So those people who are eating uncooked raw meat, right? Those people who are eating raw chicken or uncooked chicken, not properly cooked chicken, right? These are the people they are having this infection, right? Uncooked pork, uncooked chicken, uncooked fish. These are all going to cause disease. Uncooked fish is going to cause a cancer. Uncooked fish can cause a cancer. What is the cancer? It is a fluke that is going to be present over there. Clonorchis sinensis. Clonorchis sinensis is going to cause bile duct cancer. And this is happening because of uncooked fish. Uncooked fish. Okay. So always remember uncooked pork can cause what? Neurocysticercosis can happen, right? So always remember whenever you are eating non-veg things, you should be having those things cooked properly. Right? Even the dry fish also. Okay. Yes, definitely. We are having the effects. Ultimate thing you should have what there are going to be toxins. This bacteria they can produce certain toxins, right? And those toxins they will be present till the time those toxins will be present. Some toxins are heat stable, some toxins are heat labile. So those are killed. Those are killed, but some are heat stable. So those heat stable toxin can cause more severe diseases also, right? Then we are having this touch receptor. These are simple. Tomorrow also we are going to discuss. Meissner's corpuscle are going to be responsible for gentle tap and low frequency vibration. Gentle tap and low frequency vibrations. Merkel cells are going to be responsible for corners and braille reading. Very, very important. Corners, edges, के लिए, these are going to be responsible. They can understand. Okay, if I'm a blind people, I'm touching this thing. I can understand this is something like a bottle, right? So this is the blind people. They are going to study. They are going to study with the help of what? With the help of braille. With the help of braille. They can also know. They will be having books like that. You study A by looking at it. They study A by feeling it, right? So they can feel the edges, they can feel the corners. This Pacinian corpuscle is going to be present where? It is going to be present for high frequency vibrations, right? Next thing is about the Ruffini's ending. Ruffini's ending is going to be present where? In the joint capsule. In the joint capsule for skin stretch, they are going to be responsible. Right? This is as it is, you have to remember. Okay. What about the Sarlanger and Gasser classification? I'm just telling you one thing. More the myelination, more the myelination, faster will be neuron. Faster will be neuron. More the myelination, faster will be neuron. So what is going to happen? We are having certain fibers. Like we are having C-type charger. This is a C-type charger. This charger is a fast charger, isn't it? This is a fast charger, right? We are also having this particular charger. This might be a slow charger, right? So on the basis of that, on the basis of myelination, we are also having neurons in the body. Some of them are going to be very fast and some of them are going to be very slow. So let's begin with the this classification. This classification is known as Erlanger and Gasser classification of nerve fibers. So we can have A alpha, we can have A beta, we can have A gamma, we can have A delta, B and C. How many fibers? Speak with me. A alpha, beta, gamma, delta, B and C. Right? Look here, the diameter I told you, the more the myelination, the faster the neuron will be. Like if I ask you what is the drug of choice for erectile dysfunction, sildenafil. Yes, you are answering it very fastly, right? Second question, I am asking you, what is the drug of choice for amyotrophic lateral sclerosis? Amyotrophic lateral sclerosis. You are not able to answer this question, right? So we are having some neurons, and these neurons are having more myelination. Let me make you understand what is happening with you, why you are not able to answer. Wait. Listen, I'm not asking you a question. I'm asking you how why you are able to answer this sildenafil very fast. Because you have this myelination, this neuron, the neuron in your brain which is having sildenafil is having higher myelination, and higher myelination, that means you can retrieve the information very fast. You have studied about amyotrophic lateral sclerosis somewhere in the life, Stephen Hawking disease, right? And the drug you will be using is going to be riluzole. Maybe you have heard about it, maybe you have not, right? So but those things which you have studied once and not going to recall, they will be having low myelination, and whatever things are going to have low myelination, you are not able to recall. Can you forget your names? Can you forget your family names? Can you forget everything that you know very well? Those things you are doing on a regular basis, they will be having what? More myelination. You go home, you need not to even think about it, how to go home. First time when I came here, I was understanding, okay, I have to take this particular pathway. I was making neurons in my brain, right? I have to go through the stairs like that. Now, if I have gone through this particular pathway 5 to 6 times, what will happen? If I'll stay here 4 5 days, I will get to know, okay, chai wahan milegi. There is a tea shop. There is a tea shop. I will get to know, right? So what is happening in my brain? I am having the myelination. I am having a same neuron. I am following the same pathway, and it is having what? Myelination. You understand? You remember certain things very easily. You recall certain things very easily because you have revised that particular thing multiple times. This is the only way. Nobody is dumb. Nobody is smart. If I'm telling you, I'm telling you with the proof, right? That is the proof we are having, right? Second thing, just try to understand what are the different kind of fibers we are having. Like what you need to remember, speak with me. The mnemonic is Prime Minister, Prime Minister, Prime Minister, speak, Prime Minister, pressurized to sign the contract first, right? Prime Minister pressurized to sign the contract fast. So Prime Minister is going to be proprioception and motor function. Pressurized to is pressure and touch. Sign is going to be spindle. The contract fast is going to be touch, cold, and fast pain. B fiber will be there, C fiber will be there, right? So these are the fibers. Now see here, the diameter is going to be strongest. Which one is having the biggest diameter? A alpha is having the biggest diameter. So it will be fastest. Yes or no? Yes. Which is having the smallest diameter? C fiber. So they are going to be the slowest. They are going to be the slowest, right? We are having fast pain. We are having slow pain. What is that fast pain? If I'm putting injection in your hand, what will happen? You will be having suddenly pain. Just when I'm putting injection, maybe I'm giving tetanus. So at the time when I'm giving the TT, that time you will be having the pain. This pain will be fast pain. This pain will be fast pain, also known as first pain, also known as epicretic pain, right? This is going to be the first pain. Then what is going to happen? Next day morning, you will be having slow pain due to muscle spasm, muscle tightness will be there. And that pain is going to be what kind of pain? Slow pain. And this slow pain is due to what? The slow pain is due to which fibers? C fiber. Why C fibers? Sir, C fibers are going to be slow fibers as compared to A delta, which is going to be the my questions are now, which is going to be the fastest fiber. Alpha. If I throw stone or if I shoot or if I throw a knife like this bottle to you, which fiber will be activated first? A alpha. Because they are going to be motor fibers, so you will be acting very fast. I'm throwing something in your eyes, you will be acting very fast. Suddenly you don't even know. They are the fastest one, right? Second one, this slow pain you are having, this is going to be the slow continuous pain that you will be having, right? What is the fiber we are having for the pressure? These are going to be A beta fiber, little bit slower. Then you will be having A gamma. They are going to be slow. Then we are having touch fiber. Then we are having autonomic fiber. Autonomic fiber, we don't want fast action. But motor fibers, we want fast action. My simple question, which is the fastest fiber? Which is the slowest fiber? Who is going to carry slow pain? Who is going to carry fast pain? A delta. Muscle spindle? A gamma. Pressure? Maximum conduction velocity? Air. Minimum conduction velocity? C fiber. Susceptibility to pressure. This is going to be A fibers are more susceptible than B and then C. And hypoxia susceptibility, B are going to be more susceptible than A than C. These are the only 2 points you have to remember. These are the only questions they are asking from you. Right? Now we are discussing about the pathways. I'm just doing what? Now you know the wires in your body. I'll connect all the things in a nutshell. Now you know the wires, you are having different wirings. Some of them are fast wires, some of them are slow wires. Right? Is that okay with you? Now I'm teaching you what is from where, which canal these wires are going. Like in the hole, we are having this pipeline, it is going wire for AC like that. So what are the different wires? What is the canal we are having? I'm just cutting a cross section of your spinal cord and presenting in front of you. So this is going to be your spinal cord in front of you, right? This is the spinal cord in front of you. And this spinal cord will be having what? It will be having two types of pathways. We are having ascending pathway. Ascending means information is going from the body to the brain. Okay, we are having second pathway. This is known as descending pathway. That means information is coming from the brain to the body. Ascending, can I also call it ascending? Can I also call it spino, from the spine to the thalamus? Spinothalamic tract. Yes or no? Descending, can I also call it cortex say corticospinal? Can I also call it corticospinal tract? Yes or no? Very good. Yes, that is good. Right? So, what are the pathways we are having? Look here. This is going to be the dorsal. This is going to be the anterior. This is going to be the anterior side, and this is going to be the lateral side. Okay, just understand this. We are having dorsal pathway, we are having lateral pathway, we are having anterior pathway, and this is what is the cross section of your spinal cord. In the spinal cord, you are having these wirings, right? So, what are the wirings which are going above? We can have anterior spinothalamic tract. Everyone look here, you will understand. Anterior spinothalamic tract. We can have lateral spinothalamic tract. We can have dorsal spinothalamic tract. These are the spinothalamic because they are taking the information about from the body to the brain, anterior, lateral, and dorsal. We are having lateral and anterior cortico-spinal tract. So cortico-spinal tract will be lateral, it will be anterior only. Now let's try to see what are the things which are going to be taken by these ascending tracts, right? They are a specialized fiber. How we will get to know we are having pain and what location, how we are having this particular thing at what location, right? So how we are going to know we are having lateral spinothalamic tract, anterior spinothalamic tract, and dorsal column system. Lath padegi, you can simply remember when you are going to have the lath. You understand, all of you, lath means kick. In Hindi, it is kick. You can make him understand, right? So we will be having what? We will be having pain and temperature. Lath padegi to kya hoga? What will happen when you have the kick? You will be having pain and temperature, right? Anterior is responsible for, you can remember auntie. Auntie is going to have what kind of touch? You will be having crude touch, pressure, and you will be having sexual sensation, right? Sexual sensation. These are the sensations. They are going to be carried out by which pathway? Auntie wala pathway. You can think like that. Okay, so auntie you can remember, aunt or auntie you can remember light touch or crude touch or pressure. Light touch, fruit touch, and pressure will be taken out by auntie and sexual sensations, right? Then next we are having is dorsal pathway. Dorsal will be having two nucleus. Look here, two nucleus will be there. One is going to be race. One is going to be race. Race means when you are going to run. You know you are going to run from the legs or from the hands. Legs. So it will be taking information from the legs. Whereas this cuneatus will be having eat. You are going to eat from the legs or hands. So this nucleus cuneatus is going to be responsible for the information from the hands, and gracilis is going to be responsible for the information from the legs. Okay, and what are the information that are going to go up? Fine touch, proprioception, 2 point discrimination, and vibration. So all these informations are different information, and they are taken up by the different route. You understand? One is line for the AC, one is line for the certain things. Like you understand this? If you understand this, we are done, right? So we are having this particular thing, right? Now we are having how our body will get to know where is the pain that is happening. Okay, you understand two things. What are the two things you know by now? You know which pathway is going to carry pain, and second thing you already know pain. Let's talk about pain. C fiber is going to carry which pain? Fast pain or slow pain? Slow pain. If I am having slow pain here, this information is going to my brain via which fiber? C fiber. Which tract is taking up this information? Lateral spinothalamic tract. You understand? You understand how this supply is happening in our body. Anywhere in my body, if I'm having pain, suppose my hand is having slope, you injected some injection, right? Let's say you had an injection over here, and now I am having TT injection you are giving me, and after the TT, what will happen? You will be having slow pain over here because of that injection. Now the slow pain will be taken up to my spinal cord first. This is going to be the primary neuron. It is going to go to my spinal cord, and in spinal cord, it is going to opt via which pathway? It will go via lateral pathway because it is pain. And what are the fibers which are going to carry it? C fibers. So if it is a slow pain, C fibers, and this information will go to my thalamus. Okay, every information, the same sequence will go. Okay, every information. Let me make you understand. For example, this is a pain. This pain is happening from the, let's say this pain is happening in my hand. This pain is happening in my hand, and now this information is going to come via the first neuron, which is coming is known as primary order neuron, first neuron. Then this is going to be the second order neuron, this is going to be the second neuron, and then this information will be going to thalamus. Every information will be going to where? Thalamus. Here you will be having a nucleus. This nucleus is known as ventro-posterolateral nucleus. And remember, the function of this nucleus is to identify the location. Key, this pain is happening where in the body? And in your brain, you are having a specific area for a specific organ, and it will be sending that, okay, he is having pain in the right deltoid, right? He is having pain in the right deltoid. So this is the function of which organ? Thalamus. And this thalamus is going to send this information to somatosensory cortex, and somatosensory cortex will identify what? Location. And you will feel what? You will feel the pain now. You will feel the pain now. This is a wire. You understand this is a wire. If I cut this wire somewhere in between, what will happen? You will not have the pain. If I block this wire, I give any kind of anesthesia, what will happen? You will have no pain. You understand? This is the wiring. If I cut this charger, do you think this mobile is going to get charged? No charging will be there, right? So this is what is going to happen, right? This is the basic funda we are having. So look here, this is going to be the spinothalamic tract. You have completed this in anatomy, right? A spinothalamic corticospinal. You understanding what is the basic funda behind this, right? So it is going to take the first order neuron. Now this neuron will be going up. This crossing over will happen. This is going to go where? In the thalamus, and this information will be go to somatosensory cortex, and you will understand, okay, I am having pain over here. What kind of pain? Sir, C fibers are carrying it as a slow pain. Sir, A delta are carrying, A fibers or A delta fibers are carrying it as a fast pain. Now, how your body will assess what kind of pain you are having, right? Slow pain or a fast pain, right? Second thing we are having is what? Now the information from your brain will be coming. Suppose someone is injecting, so you will do what? Suppose someone is putting pinching or something is doing like that, right? So what you will do? You will put the response, very fast response. If I try to inject something, what you will do? You will do fast response. Fast response means which fibers will be bringing the information? A alpha motor response, prime minister, proprioception and motor response. That is going to be now this information will be coming from all your brains, right? And from the brain, all the information will be coming. This information will be coming. This information is known as what? Cortico spinal tract will be bringing the information. So it will come via lateral. And can you appreciate, here you will be having anterior, here you will be having lateral. This is what we have seen only, right? We are having only two pathways. This is going to be lateral, this is going to be anterior only, right? So this information is going to come here, and this information is going to go to body, and you suddenly retract your hand, right? You will understand, okay, I am having pain. Once you will feel like that, you will suddenly remove your hand. It is, if you touch something, it is hot, you will suddenly remove, right? If you touch something, you will get to know what is cold, what is hot. Cold temperature is taken up by temperature is a delta. Like that, we are having certain fibers for different things, right? So we are going to have this particular pathway. Basic understanding you understood? Yes or no? Yes. Now, what is upper motor neuron? What is lower motor neuron? Try to understand this. Look here, it is very simple. Whatever fibers which are coming from the brain till the spinal cord, this orange color fiber till the spinal cord is known as what? Upper motor neuron. And from the spinal cord, whatever is coming to the periphery, this is known as lower motor neuron. If you understand this concept, it is very important. A stroke patient will come to you and you will identify whether the patient is having upper motor neuron lesion, whether the patient is having lower motor neuron lesion. Okay, so always remember, or let me just give you one more example. What is upper motor neuron? What is lower motor neuron? And what is going to be the tone over here, right? So we are going to have upper motor neuron lesion. We are going to have what? Lower motor neuron lesion. Or you can think like that. Upper motor neuron is what? Upper motor neuron is like coaching is the upper motor neuron. I am the lower motor neuron, and you are my students, which is going to be the muscle tone, right? Or action, you can simply remember action. You know what is the difference between spastic and flaccid paralysis? No. Okay, look here, you will understand. So, suppose this coaching is not there. This coaching is not there. Upper motor neuron is not there. Upper motor neuron lesion is there, right? That means upper motor neuron is not working. That means where is the problem? From the brain till the spinal cord. This is the problem. This is the stroke. This is the lesion. It can be anything, right? What is going to happen? If this coaching is not there, if no one is there over me, what I will do, I will teach you continuously. And what you will do, you will also study along with me, right? So what is going to happen? This is going to be, it will start from the motor cortex, what is upper motor neuron, cranial nerve nuclei, in the brain, anterior horn cell, spinal cord. What will happen? Tone will increase. Tone will increase, yes or no? Action will increase, yes or no? I will teach, tone will increase, everything will increase. You will be having spastic type of paralysis, deep tendon reflex. You are going to put something, it will be exaggerated. And Babinski reflex is going to be come out to be positive. When you go to hospital, you will take any blunt object and you will run like that. It will be showing you positive flexion will be there. This is known as Babinski positive. This is what you are going to do in the hospital. Any patient is going to come, you will be instructed, okay, go and check for the Babinski. And what is Babinski? Babinski, if it is coming out to be positive, that means this patient is having upper motor neuron lesion. If it is coming negative, that means this patient might be having LMN. LMN lesion will be there. Now, what is LMN? Just try to understand. If LMN is not there, if I am not there, do you think who is going to teach you? Who is going to teach you? There will be study. No study will be there. You will be having decrease in tone or increase in tone. Decrease in tone will be there. You have flaccid paralysis. You have deep tendon reflex will be absent. You have everything absent will be there. You understand? So what is upper motor neuron lesion? You will be having problems somewhere from the brain till the spinal cord. This is UMN lesion. You are having problem from the spinal cord to the periphery. This is LMN lesion, right? This is going to be the UMN and LMN. Stretch reflex, we are having inverse stretch reflex, we are having, right? If I try to lift too much heavy weight, am I going to lift that 500 kg? No, there will be muscle relaxation. But if I do like certain test, stretch reflex, what will happen? Yes, we are having this test will be positive. You can remember simple things, what I'm telling you. Stretch reflex is going to show you muscle contraction. It is going to be a monosynaptic reflex. Sudden tap or jerk of brisk contraction will be produced and alpha motor neuron will be activated? This is going to be the question they are going to ask you, and you will be answering all of them, right? Whenever I talk about stretch reflex, what is going to be the stretch reflex? Muscle contraction and muscle length will be there. Length will be involved. Whereas in the inverse stretch reflex, you will be having what? Just try to contrast now. Here you will be having what? Tension will be there. Muscle will be relaxed here. There will be contraction. Here will be relaxation. There will be spindle. Here will be Golgi tendon organ. Polysynaptic, or you can also remember it is a biosynaptic reflex. Alpha motor neuron will be activated there. Here it will be inhibited, and here you will be having regulation of muscle tension and muscle relaxation will be there. Simple question: if I ask you, tension is involved where? Inverse stretch or stretch reflex? Tension is involved where? Tension is a feature of this. Tension is a feature of this is inverse. This is stretch. Okay. Tension is a feature of inverse stretch reflex. Lengthening reaction, length, stretch reflex. Golgi tendon organ, muscle spindle, monosynaptic, bisynaptic, inverse stretch. Okay. Muscle relaxation, muscle contraction. If you remember these words, your all the questions will be solved, right? Alpha motor neuron activation, stretch. Alpha motor neuron inhibition, inverse stretch reflex, right? This hypothalamus, tomorrow I will give you one video if you are not able to remember this, but important things you have to remember. We have seen already hypothalamus. This anterior hypothalamus is going to be responsible for what? Thermoregulation of hot. You can think like a car. In car, in anterior side you will be having what? Engine. So engine will be hot, whereas on the posterior side you will be having what? Cold thing. That is going to be cold, like cold or shivering will be there, right? This is going to be the important thing, right? We are having, just go through this, you have to read this, nothing important like that, right? What about the brain? We are having different brain areas, and they are going to be concerned with different things. Like frontal lobe will be concerned with what? It is concerned with personality, emotions, attention, concentration, judgment. If you are having any lesion in the frontal lobe, what will happen? You will be having what? You will be having paralysis. You will be having problems with the things, right? You will be having difficulty in language. You can get out the words. This is going to be the aphasia that is going to happen. Parietal lobe is going to be concerned with the eye-hand coordination. If you are having lesion of parietal lobe, you will be having what? Eye-hand coordination. How we are going to assess? Let me, let me just clarify it to you. You can read this. It will be easy. Simple things are written. If frontal lobe lesion is there, patient is not able to get the words out, right? Agar frontal lobe if frontal lobe will be having any lesion, he will not be able to speak the words out. This is going to be frontal lobe lesion. Parietal lobe lesion, this patient will be having difficulty in eye hand coordination. He's not able to do this thing, right? Occipital lobe lesion, how you are going to identify? Patient will be having problem with the vision. Patient might have hallucinations also. Temporal lobe lesion is going to be concerned with the understanding of the speech, right? So here you will be having understanding type of aphasia. That means this patient can speak, but is not able to understand what you want to convey, right? I'm telling you, you're not able to understand. I'm telling you, raise your hand. You'll be like, what you are conveying, I'm not able to understand. Cerebellum is responsible for the control of movements. Cerebellum is concerned with the bellum is concerned with the balance or movement. And brainstem, we have seen, we are having what? Pons and medulla will be having respiratory center. So we can have what? Difficulty in breathing, changes in breathing can be there, right? These are the neurotransmitters we are having. What are the neurotransmitter we are having? Acetylcholine, we have seen it is a neurotransmitter for parasympathetic nervous system. Nicotinic, muscarinic receptors we are having. Serotonin is a neurotransmitter which is going to be present for the 5-HT receptor. We can give drugs like SSRI, SNRI. These are the drugs we will be studying in psychiatry. Dopamine is a receptor. Dopamine is going to do which disease? Parkinson disease. Parkinson. Norepinephrine is coming out from adrenal medulla. That is what we have seen. Okay. Levodopa is a precursor of dopamine. Tryptophan is a precursor of serotonin. GABA is the inhibitory neurotransmitter. We can use the drugs of GABA mimetic. These are going to be your benzodiazepines. Okay, benzodiazepines are the drug. Glycine, we have seen inhibition of glycine. It is also an inhibitory neurotransmitter. This GABA and glycine will be inhibited in which disease? That is going to be tetanus, leading to opisthotonous posture. Tyramine, you have studied in pharmacology. Cheese reaction. Remember cheese reaction? Tyramine is concerned with cheese reaction. And this glutamate is responsible for long-term potentiation of memory. So when you sleep, then only you will be able to make what? Memories. Then only you will be able to make what? Memories. Right? So when you sleep, do you see dreams in the sleep? In which sleep you will see the dreams? REM sleep. Right? In the morning, sometimes you are sleeping and sometimes you suddenly wake up. Right? And you are watching a dream. So you sleep again to continue that dream, yes or no? Yes? Are you able to continue? Should I tell you how to should I tell you how to continue that dream? You said me no. Now I won't tell you. Okay. What kind of dreams you are looking at? You want to continue so badly, right? So we are having REM sleep. We are having an REM sleep. Dreams is a feature of both. REM sleep में जो dreams आते हैं, what dreams you see in REM sleep are going to be remembered by you. The dreams you are going to see in an REM are going to be not remembered by you. Okay, so dreams are a feature of both the sleep. You get the dreams in both the sleeps, but some you can remember. These are the dreams in the REM sleep, and whatever you cannot remember is in the an REM sleep, right? So what are the things we can have in the REM? REM you can have like nightmares. You call those dreams what? This is the worst nightmare. Okay, this is the worst nightmare. That means you can remember it. Whereas an REM sleep, you will be seeing the dreams. These are known as night terror. Like you wake up someday suddenly and you will be like, okay, I had a very bad dream. What was the content of dream? I don't remember. That means that dream was in which sleep? An REM sleep. The dream that you can remember is in the REM sleep. The dream that you cannot remember in the an REM sleep. Right? This is going to be the thing. Now, what are the disorders of this NREM sleep? Or let's discuss about this particular thing. We are having bad dance. You can remember when you come to the class in the morning. When you come to the class in the morning, what was your situation? You were in the beta waves. Beta waves means that means you are fully awake, you are alert, your eyes are open. Then what happens? You enter into alpha waves, right? Alpha waves, you are awake, you are quiet, your eyes are closed. And some of you are thinking like that, I am the most intelligent person, most sincere person. I am listening to each and every word that he is saying, right? I am able to understand everything, listening to him very clearly, right? And your eyes is closed, and suddenly you will enter into T. T is going to be theta wave. Here you will be having light, drowsy sleep. Okay, drowsy sleep after the lunch, which was happening. So this is going to be the theta waves. And lastly, you will be having dance. You can remember bat dance. That is the mnemonic. So this is going to be what? Deep sleep. Some people were in the deep sleep, and this deep sleep will be there, right? And one more person is there in the class which is going to be on the gamma wave. This is going to be the focused attention. If I will get out of the track, you will be getting out of the trap, all of you, right? So I am in the gamma waves, right? So we will be, these are the waves in the brain, right? Now they ask you what is a REM disorder, what is an NREM disorder. REM disorder we are having, that means you can remember. We are having narcolepsy, we are having nightmares. They can be remembered, right? Second thing, an REM, we are having sleepwalking. That means you are walking to another person's house. You go to bedroom of another person. This is going to be punishable or non-punishable? Why punishable? This is in the NREM. NREM is not remembered. Patient don't know about it. If you are going by choice, this is going to be punishable. If you are not going by choice, or you are some under the you are having the diagnosis of this sleepwalking, this is what is known as somnambulism. This is what is known as somnambulism. Some people are talking in the sleep. This is known as somnolique. Somnolique. They are talking like that. Yesterday it took long class. Tomorrow I will tell at the 7 p.m. Leave us at the 7 p.m. like that. So you'll be sleeping in the night. Those people who are living in hostel, they will get to know that people are talking in night, this is going to be somna liquid, right? Next one is bruxism. Bruxism, some people will be grinding their teeth or teeth clenching, right? This is known as bruxism. This is known as bruxism. And some people will do nocturnal enuresis. Nocturnal enuresis means bedwetting. Bedwetting. Okay, what is the drug of choice for nocturnal enuresis? Yes, somewhat near. In bedwetting, you now you know the concept. You can easily understand. We are having V2 receptors. ADH or vasopressin is the thing. ADH or vasopressin V2 receptor will be there, right? Here you will be having bladder. So what we can do, we can give something, some drug like vasopressin. The name of drug is desmopressin, right? What this desmopressin is going to do, it is going to make V2 receptor. When you will be having more V2 receptor, that means what will happen? You will be having more urine absorption. More urine absorption means less urine will be going into the bladder. Less urine will be going into the bladder. That means less nocturnal enuresis. Treatment of choice is going to be bed alarms. And lastly, we are having this night terror. This is going to be what? This is going to be the thing where you will be having what? You will be having symptoms. The patient will be waking up suddenly and he's not going to remember. All these things are not going to be remembered by the patient. Whereas this REM sleep disorders, patient will be remembering this. Narcolepsy, we are going to give what? Moda? Modafinil we can give, right? So with this thing, we are done with the rapid revision. It was a big rapid revision because you have not studied, right? But the thing that we are having, be stronger than your excuses. Uh, this is my Telegram and Instagram. You can connect in case if you want any queries you are having. We can solve those queries. Tomorrow we are going to start the dermatology, and dermatology is also vast. How many of you have studied dermatology with me in AFMG? I've taken full classes, 3 days full classes. You guys must be having some other class at that point of time. So I will be going. I have to teach full in a day, right? So be prepared, sleep well today, and when you come tomorrow, I will try to concise it. It will be taking time, definitely, right? So time I will update you once I will reach home, right? I will update you the time and the group. You will get the time, right? Tomorrow we will be meeting and we will be doing the second part of the. You understand physiology little bit doable hai? एक दिन में in a single day we can do this much only, right? We are limited, having the limited time. But if you are having any difficulties apart from this, if you find any difficulties, always you can connect with me. Okay, I'll explain you. No issues with that. We are having 80 days, and definitely it is doable in 80 days, right? So let's go. Let's end this.